Good morning, all doctors. Welcome you all for the day 2 of the 6th ENTrain workshop. So day 1 has been a resounding success. This has been the recording viewership. Yesterday we had with 2,100 odd registrations and 1,600 people watching this program. So I'm sure day 2 is going to be even more better with none other than our own Bharti madam will be starting the day with papillary and follicle thyroid tumor. She has got an eminent panel here. I'm sure there's going to be another 1.5 hours academic feast from Bharti madam and team. So I welcome all the panelists. And ENTrain every year has been setting records year on year in terms of viewership and academic content. Thanks to our mentor, Dr. Deepak Haldipur. So the topic 2 will be from Dr. Manoj Manikot. He will be talking on sudden HL and auditory spectrum disorder. That will go up to 12 o'clock from 10:30 to 10 o'clock to 12. And then one more live surgery coming up from Royal Pole Hospital, which Dr. Janaki Raman will be taking there from 12 o'clock. So this day 2 is also power packed with academic fees for all the youngsters across the country. I'm sure you will have a great learning. So happy learning to all of you, and I'm handing over to Dr. Krishna.
No, I think we have Dr. Vishwas sir, also the organizing secretary, and he's been instrumental from past 6 years. Vishwas sir, over to you for yesterday's intro remarks and start for today's proceedings.
Yes, sir.
Good morning, everybody. Thank you for joining us today in this 6th ENTrain workshop. And to begin with, we have our Professor M.B. Bharti ma'am, who's been a doyen of head and neck oncosurgery and ENT surgery in Karnataka. It will be befitting for her to start this panel because she's been our teacher and she has guided many students in the past. Thankfully, we have had a great session yesterday with 4 live surgical programs and then a panel discussion. The attendance was exemplary and possibly crossing 2,000 online and hybrid included. And this was something that we always wanted to do, was to teach. And the experts coming together to make sure that the common topics are delivered to all of you all is the vision of the Microlabs team headed by Dr. Manjula ma'am, Mr. Durga Prasad, and the earlier Mr. Pradeep. And this is what we want to do. More than the narrator, it is the narrative. That is what Deepak sir always implies, that the academic should be the highlight or the hero of the program. I hope we continue to do that. And without much delay, we would like to start the panel. And I would like to welcome the panelists who have come here from all over the country, and our moderator, Madam Bharti ma'am, to take over the proceedings. Krishna sir.
Yeah, thank you, sir. Now, today's panel, the topic coming up, the first panel for today, it is the papillary and follicular thyroid tumor. The moderator is Dr. Bharti madam, and we have 5 fantastic panelists joining in from across India to talk about Dr. Though none of our panelists does not require any introduction as a formality, I'll just take you through the next couple of minutes and hand the session to Bharti madam. Bharti madam, as all of us know, she has held the highest position. She has been the president Association of Otology of India, senior professor and former head department of head and neck from JSS Mysore. She has won. She has numerous prestigious awards, and she has several papers to her credit, and she has research works going on, and she continues to be a support for all of us, and she continues to train many more students. Thank you, madam, for joining in today and accepting to be the moderator for today's session.
Thank you.
We have 5 fantastic panelists joining in. First of the panelists is Dr. Ritu Seth. Madam is joining from Mumbai. She has done a master's, and also she has done her fellowship in oncology from Tata Memorial from New York. She has been the speaker at various national international forums. She has various national international publications to her credit. Welcome, madam. Ritu, madam. Thank you. Another prolific speaker for today, Dr. Deepak Balasubramaniam. He's been the professor, Department of Head and Neck Surgery, School of Medicine at Kochi. He has done extensive work in head and neck oncosurgery, several publications to his credit. Also, he has authored several books and book chapters pertaining to head and neck surgery and plastic surgery. Deepak sir, welcome sir. We have Dakshis Patel sir from western part of India joining in today. He has been is MCH head and neck oncosurgery from Amrita Institute of Medical Sciences. Also, he has his fellowship from US, and also is there associated with HCG group of cancer centers from Ahmedabad since 2012. Dakshis sir, welcome sir. Thank you. Dr. Suchita madam, welcome madam. Madam from JSS Department of Pathology. She's been the professor there. She has several numerous publications to her credit. She has been presenting papers across various conferences, various scientific programs. She's been part of projects in association with biochemistry and forensic departments. Special interest of madam is oncopathology and nephropathology. Sucheta madam, welcome. Thank you, madam. Dr. Kiran Kumar, welcome, sir. Sir is for the former head of Bombay Hospital. He's presently the founder and consultant Kiran Nuclear Medicine and PET CT. He has been the ardent speaker in various national and international forums. He has several publications in the peer-reviewed index journals. Thank you, sir. Thank you very much. And over to Bharti madam for the today's first panel discussion, papillary and follicular thyroid tumor. Thank you, madam.
Good morning, everyone. At the outset, I thank Microknowledge Academy and Dr. Deepak, Dr. Vishwas, and their team for giving us this opportunity to be here on Sunday morning. Actually, we are starting a talk on, it's just a panel discussion on, first we'll start with solitary nodal thyroid, and then we'll evolve into well-differentiated thyroid cancers. These are the two common conditions which the ENT surgeons will come across in their day-to-day practice. So we want to give more importance on this, and then our panelists are eminent, as Dr. Krishna Kumar put across. So they'll share their experience rather than reading in the textbook and putting what it is. They'll share what experience they have and how they are managing their cases on day-to-day basis. So this will help all the viewers to take this and adopt in their day-to-day practice. I fail in my duty if I don't talk about these eminent two people who's revolutionized the thyroid surgeries. Bill Roth is a leader in thyroid surgery. Mortality was 88%, shows need for RLN preservation, and defines the need for parathyroid preservation, and emphasis on speed of surgery. And then Kocher emerges as leader in thyroid surgery, emphasis on meticulous techniques, performed 5,000 cases before he died, and he was awarded in 1909 a Nobel Prize for his efforts on thyroid surgeries. Now, to continue this, we have all these eminent speakers with us today in this panel discussion. Now, second. Yeah, to start with, I'll just give a small clinical scenario. You have a patient, maybe a female patient around 40 years with swelling in the anterior neck, in the midline. Now, can Ritu tell how we'll go about this patient and how you're going to ask the history, then examination, and what investigation you like to do. And once she finishes, the other panelists, if they have anything to add on, can add on there. Yeah.
Yeah. So when a patient comes in the OPD with a swelling in the anterior part of the neck, so depending on his location, if we suspect it to be a thyroid disease, first of all, we ask the patient to swallow and to protrude the tongue out to confirm it is a thyroid swelling or not. That is the one thing. And in the history, we would like to ask if there is any change in the size of the swelling, if there has been any difficulty in swallowing or a difficulty or change of voice. And secondly, I would also ask for like to know if the patient is hypothyroid, hyperthyroid, by asking if she has any feeling of bloating in the body or gain of weight, or there is palpitation in the hand or tremors, a palpitation in the chest or tremors in the hand to rule out hyperthyroidism. So clinically, I would like to look for these things in my history and in my clinical examination. Okay. And I would, after examining, I would like to look at the thyroid gland as well as if any lymph nodes are present in the neck.
Yeah. So, as she said, the thyroid function, the signs and symptoms of thyroid, then whether it is solitary nodule or a multinodule, a nodule which is more prominent amongst a small multinodular goiter, then also we'll subject the patient after a clinical examination for the rigid or fiber optic laryngoscopy to know the vocal cords, and then we'll also rule out the cervical lymphadenopathy. Now, you have found out a solitary nodule thyroid now on your clinical diagnosis. So what investigation you ask first?
So usually I ask for a sonography of the thyroid gland, because many times, and for a thyroid profile, and if required, SOS FNAC at the same setting in the sonography. So that is the 3 basic investigation I would like to have for most of my patients.
Okay. If indicated, you said, like ultrasound guided FNAC.
Yes, ma'am.
Yeah. Can Dakshit tell what she means by if indicated? Dr. Dakshit?
Dr. Rakshesh, you're mute.
Dr. Deepak? Yeah.
Dakshit. Yes. Hi. Good morning, everybody. I'm Dr. Dakshesh from Ahmedabad. So, as Dr. Ritu said, the first investigation would be the blood profile for the thyroid function test, and the another most important thing is the ultrasound of the anterior and the lateral neck, wherein our sonologist will help us in determining whether this nodule which we are looking clinically and palpated is malignant or not, right? So there are various criteria for malignancy. There are various criteria to look for where the nodule has gone deeper into the cracks and grooves and crevices of the neck spaces. So all this information we need to categorize the nodule, whether it is benign or malignant. I guess the madam has put the nice criteria of the thyroids, wherein various point system has been given to allow us to know whether that is benign to the suspicious for malignancy. So basically, what helps us in ultrasound helps us in directing the needle towards the most suspicious area where we can take the FNAC and have the diagnosis confirmed.
Yeah. So as Ritu said, we'll do the, sorry, 1 second. Ultrasound and TSH, and then ultrasound guided FNAC. So as Dr. Dakshit put
there's
forward,
something more in the history that we have to ask for.
Yeah.
And the history that we have to ask for, just for completion's sake for the residents, it might not be relevant in clinical practice. But there are several familial syndromes which have papillary thyroid carcinomas. So if you have a family history of 2 first-degree relatives, still the incidence of another primary in the offspring, the sporadic nature is about 65 to 67%. So a family history is one that you have to ask, because that makes it more significant for evaluation. Second, any history of childhood radiation is still important in our context. And if they're living in a familial belt with hypothyroidism, if their belt wherever they're living is hypo, so not all hypothyroid lesions are safe. You have to remember that, because if you have a hypothyroid lesion, there are chances that you develop follicles. So the history has to be complete. So familial history, previous history of radiation, and the other thing that I like to say is the size criteria. Not all thyroid nodules need to be evaluated. So you have to differentiate between an incidental loma and a patient who has. So no thyroid nodule is deemed significant for evaluation unless there is a corresponding ultrasound nodule in that same patient. So you have to have both. If you
What is
only
the
have an
size
ultrasound
criteria you
lesion,
take? What is the size criteria?
1 centimeter without any adverse familial history or adverse history.
Yeah.
So any nodule less than 1 centimeter harbors a less possibility of malignancy. So, and then you have to realize there are two groups of patients: one who will present to you with a thyroid nodule, and one who will present to you with an ultrasound proven thyroid nodule. These are different things in clinical practice. So, whether it's an incidental loma or a clinically palpable nodule, the incidence of malignancy changes. So, I agree with all the authors. Clinical examination, TSH, is very important upfront. You want to see if there's a hyper functioning thyroid nodule which will need medical care. But for the sake of students and the people who are training, history, prior evaluation, prior radiation, and being in a goitrogenic belt are all important when evaluating a thyroid nodule. Yeah, sorry.
No. It's good. Like, if the size is less than 1 centimeter, I'll just summarize. The size is less than 1 centimeter with no red flags in the past, then you can just keep it under observer group. Whereas if the size is less than 1 centimeter with red flags, then you need to evaluate these nodules. Correct? No, Krishna?
Yes.
Deepak,
Yes.
yeah. Now, so these are the physical findings, what Dr. Ritu said, cervical lymphadenopathy. Some patients can just present with vocal cord paralysis, the change in voice, okay? And then very firm nodule, rapid growth and fixation to the adjacent structures. These are the findings which will give you, okay, this might be the case which I'm dealing, that malignancy, maybe it has turned into malignancy. Serum testing, as Ritu said, they'll all go for TSH is the only one which is required in the initial phase. Now, all this, do you do calcitonin? I think it's already there. So can you just highlight any one of you, three of you? When we do thyroglobulin, when we do calcitonin, when we do antibodies?
As madam has put it already in the slide, so thyroglobulin, evaluation of thyroglobulin usually is not done in the pre-operative phase. So only when a patient has undergone a total thyroidectomy, a thyroglobulin is used to evaluate whether the patient has developed recurrence or not. It is like a monitoring tumor marker for the thyroid gland. And as far as calcitonin is concerned, as Dr. Deepak pointed out, if there is a history of a thyroid swelling in the family or something, and we suspect the FNAC has come as medullary thyroid cancer, because that is one of only 10 to 15% or maybe less than 5% would be medullary thyroid cancer. So only in those cases we would do a calcitonin. And as far as Hashimoto's is concerned, usually patient will have symptoms of the pain in the thyroid area or tenderness. And so then we can do a antibody levels for Hashimoto's thyroiditis. And RET proto-oncogene is mainly done in those patients which is suspected to have a medullary thyroid cancer. However, in our set of patients, it's always better to do a vitamin D3 and a calcium evaluation also pre-operatively, because most of our thyroid is more common in the ladies, and they are invariably would turn out to be having vitamin D deficiency.
Yeah.
Yeah, I agree with what Madam has said. The important thing is we in Amrita have started doing pre-op thyroglobulin. See, thyroglobulin is a marker of thyroid tissue. It's not generally a marker of the disease. So even post-op, if you have done a near total or a subtotal, the thyroglobulin levels are still bound to be high. So there's a lot of differing literature whether we have to do it pre-op or not. But doing a pre-op calcium is extremely important because there are two concepts. One is thyroid splinting, calcium splinting, and calcium therapy. So, like Madam said, there are a lot of old people who have hypocalcemia, who have low vitamin D3 levels, and these are the patients who are likely to have post-op hypocalcemia or any of the problems associated with parathyroid insufficiency. So I think it's a good habit, especially in old patients, to do a serum calcium serum free calcium and decide if these patients are at high risk. But thyroglobulin is a post-op marker. TSH is good to see, and anti-TPO or whatever antibodies is good to know if you have autoimmune thyroiditis associated with malignancy. So I agree with whatever Madam has said. Very clear.
Okay. Now, coming to the TIRAD. So all of you agree that we need to, at present, we need to follow this?
Yes, ma'am.
Okay.
Yes, but the previous ATA didn't look at this in great depth, but we have data after that which has looked at ATA. But this is always a correlation with Bethesda.
Yeah.
You don't take ATA by itself, you have to correlate with Bethesda. And the difference between ATA and Bethesda, the new Bethesda, 2023 Bethesda, is that they have mentioned in unambiguous terms what the, so they've removed a lot of the nomenclature from the 2017 Bethesda. So the TIRADS has to be taken together with the Bethesda classification of FNA.
Okay. So all of us will agree that we need to go for the ultrasonogram, TIRADS, and then ultrasonogram guided FNAC. Now, coming to the Bethesda. This is the 2023 Bethesda. Now, Suchita, Dr. Suchita. Hello.
Yes, ma'am. Tell me, ma'am.
Yeah.
Good morning, ma'am.
Good morning.
We have the 6 categories. It has been retained from the previous classification. So the changes are, instead of unsatisfactory, the category 1, they're calling it as non-diagnostic. The second one remains the same, and now they have aligned the terms with the WHO 2022 classification. So we have what is known as follicular nodular disease, which includes the previously we used to call it as adenomatoid nodule, colloid nodule, etc. So all these comes under multinodular goiter. It comes under follicular nodular disease. And the second category in benign is Hashimoto's or lymphocytic thyroiditis. Now, the third category, previously we had what is known as follicular lesion of unknown significance. Now they have removed this term, and this remains ATP of undetermined significance. We have 2 categories in this. One is AUS nuclear, the second one is other. Now, AUS is a term we should avoid as it confuses the clinician. Now, this one should be less than 10%. In a laboratory, it should constitute to less than 10%. And the ratio of AUS to malignancy should be less than 3. So this serves as a quality indicator in cytopathology lab. Now, the fourth category is follicular neoplasm. They have removed the suspicious for follicular neoplasm term. Now, this includes if we should specify if it is follicular or oncocytic. Now, HERTL is replaced. It's a misnomer. Now it is replaced by what is known as oncocytic adenoma or oncocytic neoplasm. Now, the fourth category is suspicious for whatever malignancy like papillary thyroid carcinoma, medullary thyroid carcinoma, metastatic carcinoma, or lymphoma. Now, malignant, we should try to categorize what malignancy we are suspecting. So the risk of malignancy varies in each category. Now, one thing I want to add here is the suspicious category falls between AUS and malignant category. Thus, different include AUS and malignancy. When certain, if the atypical changes are benign, the diagnosis should be AUS. When certain of malignant lesion, but lacks one last thing, quantitatively or qualitatively, we should put under suspicious of malignancy. So this category we have, it falls between AUS and malignant, and we should tell the clinician, we should be very, very careful when we put this category. So these are the changes are in these two, and they have defined this AUS as AUS N and AUS others.
Yeah. Thank you, Dr. Suchita.
One of the important things that we have to remember in the 2023 test is they have taken lift fee into consideration when they have stratified for malignancy. So there are two tables, one with lift fee included into the 6 gradings and one with lift fee taken out of the grading. And they've also quite clearly determined what are the indeterminate nodules that require further molecular testing or further directed. So, ma'am, can you please explain that? What would your impressions be on LIFT-P and whether to include that in the classification?
I think she'll be telling in that histopathology, isn't it, Suchita?
Yes. They have changed a bit of classification. So I have highlighted the changes in the 2022 classification. So you want any clarification in this, Bethesda?
No, I agree. LIFT-P is a pathological diagnosis. It's
Yeah,
not
we are coming late once the
it's
surgery.
not an FNAC diagnosis.
Once the surgery.
I just want to highlight that there are two tables in the 2023 test where they have looked at one LIFT-P and percentage and one, but this is all in hindsight. I agree with you. With FNAC, you're absolutely right. This is what we get. But the more important thing for the petition would be the indeterminate nodules,
Yes.
which require more molecular testing or lobectomy to make it happen.
Yes.
You're absolutely right.
Yes.
Now each category, how we are managing. So the first one, they say that repeat with ultrasound guidance. Okay, but we have already done with ultrasound guidance. We have got non-diagnostic. Do you want to repeat? If you yes, say yes. When do you want to repeat the ultrasound guided FNAC? Anyone can take.
Again, the size criteria comes in, I think.
Yeah.
That's what is important here.
Okay.
The problem with ultrasound guided FNAC is if the nodule is cystic or if it's posteriorly based, even the best ultrasound sonologists find it difficult to sample that. But if a case comes back as SCAT1 with TRAS 3 or lower, I would just keep the form.
Yeah, so as Sir pointed out, I feel that sonography feature should also be taken into consideration. We can't just say see Bethesda category 1 because sometimes the patient comes with large thyroid nodules which are cosmetically disfiguring. So that may also point towards going in favor of surgery rather than just leaving the patient on observation unless the patient is not fit. And unless the patient has a very small nodule and then that is a Bethesda category 1 and it is cystic in nature, then we can observe it, I think.
Okay. My question is, when you want to repeat, see, I've done the FNAC, I've got the report, it's non-diagnostic, but there are some red flags, the size and other things are there. I want to repeat. When I can repeat the FNAC?
I would prefer within 6 months.
Hello?
Ma'am, in Bethesda, they have just mentioned one sentence.
Yeah.
There is no definitive time interval for repeating FNAC. So you are the judge. Probably the clinician is the judge for it. So they're not they've not prescribed any definitive time, ma'am.
Okay. No, why I wanted is like when you people do the FNAC, it's not only one prick. Sometimes you give multiple. So the changes might be there. So
Yes.
how much time it takes for these changes to settle down for us to ask for repeat ultrasound? FNAC. That's what I wanted.
Okay, ma'am.
So if you have 6 clusters of cells with more than 10 cells, I think the FNAC is adequate.
Okay.
And we can wait 6 months to a year. Like Madam had mentioned, there's no specific time criteria.
Yeah.
But as you had mentioned very clearly, if there is any suspicious features on the thread and it's cosmetically disfiguring for a patient, then that is a different indication for surgery.
Okay. Now I think we are clear about the first two. The third and the
another, if I can, Madam.
Yeah, Dakshit.
So the non-diagnostic, see, many times what happens if the FNAC is not done properly and if it yields more of the hemorrhagic material, and as Deepak said, if there are not adequate cellular clusters seen in the slides, then it is better to repeat immediately, like within a few weeks time. because non-diagnostic has to be established with adequate cellular things seen on the slides. If there is a faulty technique of taking FNAC by taking a wide bore needle with aspiration technique, where we get more of the hemorrhagic fluid, then it is a definitive indication to go back and have the proper FNAC.
Okay. Now the problem is in the third ATP of undetermined significance and the follicular neoplasm. So how we are going to go ahead in these two categories, the patients under these two categories? Anyone can take an answer.
So this category 3 and 4 is where all the problem lies. So as Dr. Suchitra pointed out, if it is AUS, what I mean is non-other type. It's just a neoplasm or a benign favors towards a benign disease, then maybe we can observe the patient. But if you have something which is pointing towards an adenoma or could be having features and the sonography features do not are corresponding and you are not very comfortable observing the patient. So in those patients, I think it is always better to go for a diagnostic lobectomy. And as you have put in the slides, if we have the facilities for molecular testing, then we can subject the FNAC to molecular tests for a rule-in and a rule-out test. What do you say, Dr. Suchita?
Recommend a molecular. Hello.
Yeah.
Please,
Definitely.
please
A molecular testing is definitely better than surgery. But in our setting, we have to think of our the facilities what we have. But AUS is something which is like it usually is towards benign, the diagnosis of AUS. However, follicular neoplasm, NIFTIP, everything comes under this this category. So I think a clinician should take a call if the facilities for molecular testing is available for it, or do a diagnostic lobectomy.
Now, AUS has got two different types. So one is architectural atypia and the other is nuclear atypia.
Yes.
So that hasn't been differentiated very well. Maybe the next Bethesda will have enough data to separate. And Thyrosec, Afama are all very expensive in India. And even if you do a rule-in, rule-out, if you look at PPV and NPV, patients don't accept it. Practically, patients don't accept it. If they find something that is different, which is not benign, they don't accept it. So in a patient who's got atypia or follicular, I would prefer to do a lobectomy and tell the patient they're not going to be on thyroxine supplementation or calcium supplementation unless they are already hyperthyroid to begin with, hypothyroid to begin with. So my personal experience is patients don't accept, and for ATP and follicular, I would prefer a diagnostic lobectomy because the genetic tests, there are 4 genetic tests to rule in, to rule out, but they're extremely expensive and I don't think they're widely available in India. So, and then how do you do the test? Do you do a slide scrape? Do you do a second FNA for the yield? Because you have to plan for it. When you do an FNA, you might not have enough material to do the molecular panel. So either you have to do a slide scrape, which is not highly diagnostic yield. You might have to plan, and all these tests are centralized. We don't have the tests in individual laboratories to give them a report immediately. So I think the role of molecular testing in India is quite difficult, and I will just do a diagnostic lobectomy.
Okay. Dakshit, in your center?
Yes, so till now I have not sent any patient for the molecular testing. And it is important to know the patient's mindset as well, because some of the patient will not like anything which is, if we label them benign, as Deepak said, they will be comfortably go home. But if we have doubt in our minds as a clinician, then it is better to have a lobectomy, because see, removing thyroid and maintaining with the thyroid hormone is not a difficult thing. But at least the lobectomy will give the definitive diagnosis and a further guideline what to do next.
Okay.
So lobectomy is better in these cases. Some patients might go for another pass of like another FNAC or the review of the slides, but everything boils down to a lobectomy only.
Okay. So you all plan for lobectomy or hemithyroidectomy?
So in my book, it is always the hemithyroid plus isthmus, because it helps in better evaluating next time when patient comes or next time patient is taken to the theater. So I always do hemithyroid as well as the isthmus.
Yeah.
Yeah, even I do the same thing.
Okay. Deepak? Deepak?
Lobectomy by definition doesn't include the isthmus.
Yeah.
The problem, what people have said is that if you do a lobectomy, there is isthmus hypertrophy, and patients might have a cosmetic deformity. But I agree with Dakshish and everyone that just removing the isthmus is not a big issue.
Yeah.
So
See, because when you're done lobectomy, you just
might be,
extend your dissection and do
yes,
isthmectomy also.
it is better.
Yeah.
I agree with everyone that it's just better to do a hemithyroidectomy.
Okay. So the entire panel have agreed in the third and the fourth category, we need to go for hemithyroidectomy. And then now the question comes, you do hemithyroid, do you send for frozen at that time? And how specificity, sensitivity is the frozen?
To be really honest, in my 15 to 20 years of practice, I have never sent a frozen for thyroid. I have never sent it.
Okay.
Especially if the nodule is cystic or if the nodule has spongiform changes, I've never sent it. But I always counsel the patients for a completion thyroidectomy if there are adverse pathological features.
Okay.
Now, simply sending frozen and proving it's papillary is not the indication for a total thyroidectomy. The indication for total thyroidectomy is the size of the nodule as well as adverse pathological. Size is the first criteria. Adverse pathological features are ones which are coming in now, like multifocality, all that cannot be predicted on frozen. So I don't think frozen is a natural tool to decide completion or total on table. So I would always counsel these patients that if we have multifocality, if we have adverse pathological features, then we might need to do a completion, because frozen doesn't answer that. It only tells you if it's a malignancy or not.
Yeah.
And most of the times, the diagnosis is deferred to the permanent sections, and it's impossible to distinguish adenomas from carcinomas, because we have to take multiple sections to rule out capsular and vascular invasion. So, frozen has a very, very limited role in evaluation of thyroid nodules.
Okay.
That doesn't mean the patients don't ask me. I agree with you, ma'am, that even to see the type of papillary, whether you have tall cell variant, solid variant, hobnail variant, whatever, none of these things can be so there's no way to stratify the patient based on a frozen section. And you have to be very selective in what frozen section that you send. Most surgeons will just send you solid tissue, which might not. So we don't have the eyes that you have to decide whether this is a bad pathology or not. Surgeons are really bad, especially in thyroid, to send you representative tissue.
Sir, one more thing is there are freezing artifacts. See, the diagnosis of papillary carcinoma is made on nuclear features, but because of the freezing artifacts, we so many times cannot appreciate the nuclear features of papillary. So, intraoperative cytology is way better than frozen section if the surgeon, needs for whatever reasons. So, intraoperative cytology is preferred over frozen section because of the freezing artifacts we get. In frozen.
Okay.
Only reason why I do a total thyroidectomy on a patient is if I see extra thyroidal extension. So when I'm doing the lobectomy or hemithyroidectomy, I find that the tumor has breached not the tumor capsule but the thyroid capsule, and it's involving the strap muscles. Then it is a definite. Or if I find central compartment neck nodes and exploration, I would do a total. But otherwise, I don't usually send for frozen section.
Okay. So now all the 4 are over. Suspicious for malignancy, what you will do? The 5th category.
So
I
now
would do a thyroidectomy. I don't see any other conservative surgery.
Okay, total thyroidectomy.
Again, the size.
Okay.
It's 1 to 4 or less than 1. Data suggests that you can get away with partial surgery. So the pre-op ultrasound and what size it was. So this is for both suspicious or malignant, except if the malignant is poorly differentiated. That word is no longer used in Bethesda, but it again depends on the size of.
So you mean if it is less than 1 centimeter, you do hemithyroid, and if it is 1 to 4 or extra, then you do total thyroidectomy.
So we have a lot of data for 1 to 4 saying that majority of patients who have 1 to 4 have multifocality or adverse pathological features that would need a completion. There are a lot of meta-analysis, systematic reviews, which have looked at the adequacy of thyroidectomy in nodules less than 4 centimeters. So while it's accepted to do a lobectomy or hemithyroidectomy in less than 4 centimeters, I don't think majority of Indian surgeons would do a hemithyroidectomy. They would still go ahead and do a total thyroidectomy in those cases.
Yeah.
But yeah, my preference, less than 1 centimeter, I would do a hemi, but anything above that, contrary to published literature, I would still do a total thyroidectomy or a near total thyroidectomy.
Okay. Now just 2 slides on what do you call this? Sorry. Molecular genetics. I mean rearrangement of RET on chromosome 10 in case of papillary, as well as you see BRAF V600E mutations and RAS point mutations we see in follicular thyroid carcinoma, papillary thyroid carcinoma. And then this is the same what percent prevalence we have: 45% of BRAF in papillary, 45% of RAS in follicular. Now, any role for X-ray? Now we'll come back to our radio imaging.
yeah, sometimes the anesthetist definitely wants an X-ray, especially in cases of large thyroid swellings, because there is we definitely see an airway displacement in large thyroids. So they always prefer to have an X-ray of the neck, AP and lateral, to see if there is any airway displacement.
Okay. And then now the other level of radio imaging, scans, CT scan, and then MRI.
So usually if we have adverse clinical features in the patient, like a change in voice, or if there is any difficulty in swallowing, which happens pretty late in a benign disease, but could happen early in a malignant disease. So in those cases, I would prefer to do a CT scan. And sometimes we have the patients who present with lateral neck nodes and there's no thyroid swelling. So in those patients, I would prefer to have a contrast enhanced CT scan to look for the exact swelling size and any features.
Yeah.
So in our hospital, Dr. Shanmusundaram is the head of nuclear medicine. He does not like iodinated contrast for CT scan because that interferes with the iodine uptake for the radioactive iodine. This has not been proven in the ATA guidelines. They don't say you should not do. But if I have a patient who's got low-level neck nodes and the patient has got central compartment neck nodes, I'd like to evaluate the mediastinum also. So that can be done with GAD, and that doesn't affect the iodine uptake. So cross-sectional imaging in thyroid carcinomas, I only have 2 indications. One, when there is aerodigestive tract involvement, and the second is when I suspect that the patient has mediastinal nodes or retrosternal extension. Other than these 2, I don't usually ask for a cross-sectional imaging. And if the patient has mediastinal nodes, obviously in a DTC you address that upfront. But iodinated contrast in Amrita is not practiced. because the iodine uptake later is quite difficult. Even if you do urinary iodine excretion, even if you use thyrogen to stimulate, my head of nuclear medicine doesn't really like it.
Dr. Kiran, your opinion? Dr. Kiran, is it there? I think we'll take his opinion later. Then FDG PET. I think.
But if I say the MRI, the role of MRI, as Deepak said, the CT scan indications are very clear. We use complementary MRI only when we feel that the thyroid nodule has gone like extrathyroidal extension into.
Can you hear me?
Yeah, let Dakshit finish and then.
Sure. Yeah.
We do MRI as a complementary tool to CT only when we suspect there is invasion to the esophageal muscle. At that time, the MRI gives a better delineation than the CT. That is the only place where we do MRI. Otherwise, CT is pretty common where ultrasound suspects extrathyroidal extension into the strap muscle or near the great vessels or lymph nodes in the lateral neck or in the mediastinum.
Okay.
Yeah, madam, basically, again, as sir told, iodinated contrast, it needs almost 4 to 8 weeks to completely excrete from the body. So anyway, post-op, we'll ask the patient to wait for 3 weeks to TSH to increase. So it will, again, interfere with iodine, whole body iodine scan, where iodine uptake will be less. So generally, any pre-op imaging should not have a contrast study. And yeah, for retrosternal extension, all those things, CT is important. One more thing, a thyroid scan, technetium 99M thyroid scan is also used when you have a multinodular goiter. And if you want to do a FNAC, better to do it from a cold nodule. The chances of getting malignancy will be high rather than a warm nodule. One is low, TSH. When the TSH is low, the thyroid scan is indicated, and very helpful in multinodular goiter to choose the nodule for FNAC. And when it comes to FDG PET CT, it's not indicated routinely, but when we do a whole body PET CT and if we see any incidental focal tracer uptake, then there is 35% chances of malignancy. So any incidental focal tracer uptake in FDG PET CT should undergo ultrasound and FNAC. And if there is diffuse uptake, thyroiditis will be the diagnosis. So anyway, it is not routinely indicated pre-op for diagnosis purpose or staging pre-op.
Okay.
My only indication for an FDG is that if the FNAC is follicular and the patient has evidence of skeletal metastasis.
Yes.
So if the patient has symptoms of bone pain or calvarian swelling or any of the other symptomatic lesions, I would like to get the perspective of a skeletal survey. We can't do a bone scan in these patients.
Yeah.
But it's a very rare condition, sir. Like I mentioned, it's a very rare indication. But it's a follicular neoplasm with heterogeneous spread and skeletal metastasis. Even if it's a solidly calculated for a patient having low back pain, I would still do an FDG PET to rule out other. It's only for follicular. I wouldn't do it for anything else. And of course, if the report comes back as anaplastic or poorly differentiated, yes, an FDG is more important than any other scan.
Okay. Yeah. Now coming to the AJCC 7 to 8 edition, I think we all know about this. I will not go in detail about this. Now the risk stratification we know, management. So now we'll come to the management of well-differentiated thyroid cancer. So we have the 3 options: surgery followed by radioactive iodine and then targeted therapy. Surgery, I think we discussed what is hemithyroid, when do we do total thyroidectomy. And the other surgeries are central compartment dissection, central compartment neck dissection with lateral neck dissection. Which all cases we do all this. A best surgeon is the one who masters in anatomy. We all know These are the landmarks which we have, which are there in our books: Sarnia classification, Friedman classification, Joul's triangle. But do we really go for all this, or these days, or like we don't identify the Joul's triangle and go there, or we don't identify the Sarnia? Are we still doing it, or just identify our superior laryngeal now? How we are all doing?
Sir, madam, I'm using, yeah. Sir, can continue.
No, ma'am, please continue.
No, sir, please.
I have never used these triangles in my life except to answer during my MS and MCH exam.
Correct. That's why, because everyone keeps asking these triangles. So I thought I'll just take your opinion, all of yours. Yeah, tell.
So Sarnia is good for one reason. So there are two types of surgeons. One who are the strap cutters and who are the strap elevators. So when I did my fellowship for a year in Australia. So in Australia, everyone used to divide the sternal thyroid and lift it above the superior pole. That gives you an idea where the superior laryngeal nerve is, and I don't think it's possible to identify it by just retracting the straps. So if it's 1 or 2A, you don't have to worry about it. Of course, if it's 2B, you have to dissect it. And the presence of the recurrent nerve is based on your inferior thyroid artery and your superior parathyroid gland. So once you identify the inferior thyroid artery, I have never seen the nerve in my practice crossing the inferior thyroid artery above it. It's always below it. So it's as you go. If you look at the textbooks, identifying the recurrent nerve, you have the superior approach, you have the lateral approach, you have the inferior approach. There are different ways of doing it, but it's all boils down to what you're comfortable with. So none of these theoretical things matter to me in dissection, but I always strongly urge the sternothyroid dividing technique because it shows the superior laryngeal nerve better. But I've never used Joul's or whatever triangles, the Bayes triangle, Joul's triangle. Every year some new triangle is described. So I don't know if I can rewire my brain to understand all these things. So yeah, I never use any of them.
Yeah. Then other panelists. Even we never use. Only thing is we see the superior pedicles, then identify the pedicles, and then just look for the nerve. I think that's how we go. I think. Ritu.
Yeah, so then usually when we are training the residents, and if somebody is doing a total thyroidectomy, I would definitely like to preserve the superior laryngeal nerve. So I use the Joul's triangle and I teach them that way only, that to please identify the nerve in the Joul's triangle and then ligate the superior pedicle. So that if the patient is undergoing hemi, then it's not that symptomatic. But if the patient is undergoing total thyroidectomy, and we have injured both the sides superior laryngeal, I think the aspiration is a bit of a problem in the post-operative setting.
But the superior, the nerve that goes into the cricothyroid is a motor nerve. It's not a sensory.
Yeah.
Sensory nerve is above. So I don't think aspiration is a problem. I think high-pitched voice and vocal strain is a problem.
Yes,
and I agree with you. We did a study where we looked at patients who had thyroidectomy without. So a lot of people, if you look at literature also, I can show you so many papers where people have not even identified the recurrent nerve, leave alone the superior nerve, and they claim really good results. But we did a study where we found out that a lot of these patients have vocal fatigue, unable to get high-pitched voice. Stroboscopy did not show tensioning of the vocal cord. So I agree with you that you have to use any anatomical landmark. Can be any triangle, can be anything, but you have to use anatomical landmarks to identify the superior laryngeal nerve.
Yeah. So the main thing is you identify the vessels properly at the superior pole of your thyroid, then the anterior branch, the posterior branch, and the medial intercommunicating. And then if you just ligate it, I don't think you will anytime injure the ESBL.
No, the injury is not because of cutting the nerve, but using
stretching.
cautery at the upper pole.
Yeah, and stretching.
It's using cautery at the upper pole because you ligate the artery and then everybody starts buzzing the vein because they don't take it in their right angle and apply clips or harmonic or ties or whatever. The problem is when the vein retracts and it starts feeding everybody just bipolars between the pedicle and the larynx.
Yeah.
That is extremely bad.
No, we always like it. We always the original.
That is the right thing, man.
Yeah.
That is the absolute right.
No, we are all old timers, no? Yeah. Dakshit, anything from your side? Any input?
So the technique which says, so it is basically how you are getting comfortable with the identifying the parathyroids and the recurrent and the ESBL. So strap muscle cutting of the strap muscle, as Deepak said, is usually we cut the strap muscles when we are dealing with the bigger thyroid nodule, and if you are completing the thyroid on the other side, when we know about the position of the extrabranchial supralaryngeal nerve, where it is 1, 2A or 2B. So that side, other side, we may preserve the strap muscle if the thyroid lobe is smaller in size, and once we know the position of the nerve on the other side. Other than that, all these triangles we don't follow. Only thing is the lateral technique where we divide the superior pedicle first, the middle thyroid vein second, and then reflect the whole thyroid nodule medially, and then try to remain very close to the thyroid gland and preserve all the structures which are important to us.
Yeah. So the inferior thyroid artery.
If you look at Leigh Delbridge's technique, Leigh Delbridge is one of the foremost thyroid surgeons. So Leigh Delbridge I also operate, and that's how I was trained by Jonathan and everybody else. You operate from the opposite side, not the same side. You cut the sternothyroid. This is Leigh Delbridge, Randall Weber, everybody's textbook, even the UK textbooks. All of them say to divide the sternothyroid to get an exposure, but that's not a commonly done technique in India, and you have to operate from the opposite side. So these are some fundamental technique changes that is so common in the West, but we don't do in India. So just for the residents to know, I always operate from the opposite side. I don't do it from the same side.
And if it is the right, left side, I stand, and if it is
I change sides.
Yeah.
So if it's left, I stand on right. When I go to the right, I move to the left.
Yeah.
So Delbridge, Randall Weber, everybody's textbook. You look at all the UK textbooks on thyroid. Everybody says stand on the opposite side and divide them. But it's not very accepted in India. We have more volume. We have more experience. So probably our techniques are right. But I don't follow any of the triangles.
Okay. And then
operating from the other side,
its own advantages. But see, what in our experience, when we operate from the other side and when we lean very much onto the operative table, and at some point of time you are not finding the recurrent laryngeal nerve, and then this is the experience when you go to the other side and ask assistant to pull the thyroid to the contralateral side, and the whole view is changed, and then within 1 or 2 minutes you get to see the recurrent laryngeal nerve. So that is usually happens when we have the big thyroid nodule, and when you have to retract with your one hand the thyroid lobe and do the dissection with the other hand, and this sometimes gets difficult in a bigger thyroid nodules. But when you go to the other side, when your assistant is pulling the thyroid and you have both your hands free to dissect the loose areolar tissue and look for the nerve, that really helps when you change the side at the end time when you are not finding the nerve.
I agree with Dakshish. I usually prefer ipsilateral side when it comes to identifying the recurrent laryngeal nerve, because I feel we are more in control because many blood vessels come near the capsule.
No, see what I do.
No, the issue is not which side you are.
I do on the opposite side, but when it comes to the lower pole, I shift to the same side.
Yes.
Like
it doesn't really matter which side you're doing. What matters is that you retract the carotid sheath, because that's what opens up the tracheoesophageal groove. You have to retract the carotid sheath so that it expands the tissue between the trachea and the carotid sheath. And that's why you see your esophagus, your tracheoesophageal groove, and the nerve. So problem for me was if I stand on the same side, there's a retractor coming under me, and it was just difficult. And this was what I was taught in my fellowship. So that's what I follow. But that's besides the point. The question here was whether we follow the triangles, and I don't think
Yeah.
any of us, except Madam, look for teaching purposes.
Yeah.
She follows.
And
that.
then intrathyroid artery identification and recurrent laryngina always start from the base, that is from the down, and then you trace upwards, because sometimes you get the branches. The recurrent laryngina now branch outside. So you need to preserve all these branches. So always at the root of the neck, you identify your recurrent laryngeal and then trace it up. So this is what I follow. I think everyone follows the same, I think, no? Or
Yeah, the recurrent has branches to the esophagus also, so you don't have to be too worried
okay.
or too pedantic about those branches. So it's easily to do from below upwards. That's what I also think.
Okay. Now coming to if the recurrent is not, I mean, a recurrent or non-recurrent right side, now where do you identify it? How do you trace it then? Even though it is.
That's quite simple. I've had many experiences with non-recurrent. It's from the upper pole. That's where it turns and comes down.
Okay.
So if you find a large nerve which is not the answer, and entering into the tracheoesophageal groove and into the inferior constriction, it's quite simple. You'll never, if you're dissecting the upper pole and separating everything with a peanut and a right angle, you're not going to miss that.
Okay.
And of course, the imaging will show a retroesophageal subclavian. I have never seen that in a preoperative scan because we don't do thoracic imaging for routine nodules. But I've seen quite a few, so it's not very difficult.
And Zucker candle tubercle, anyone uses this as a landmark? Or if it is there, you just for recurrent as well as.
Oh yes, ma'am. Of course, of course. Yeah, of course. But I use the superior parathyroid as the landmark for the recurrent entering into the larynx.
Okay.
But the Zucker candle is always, in many cases, it's big. You have to use sharp dissection to remove it. But I'm always very comfortable with the superior parathyroid because you can preserve both the nerve and the parathyroid in the same shot. So that's what I would prefer.
And harmonic scalpel, everyone uses it or?
No.
No.
Okay.
I use it only for MNG, not for malignancy.
Okay.
MNG, what places?
Superior pedicle only.
Superior pedicle. Okay, because huge one.
So if you have the gland ascending a lot, and if the pedicle is going very deep, and I know it's not malignancy, I just chop off whatever is continuing into because it's not malignancy. You don't have to kill yourself to remove every milligram of tissue. So only for the upper pole, nothing else.
Okay.
So what I have fear about using this tool in because in MNG when the lobe is going higher up, it will have a bigger caliber vessel as well. So
harmonic seals all of that. It's not really a problem. It's our fear. It's only our fear. Either ligation or harmonic are okay, or a great clip is okay. But like you said, it's only for MNG. It's not for any other pathology. Only
just for my, what you said is you leave behind some of the tissue as well. You are comfortable with that, leaving behind some of the tissue.
No, I dissect in the avascular space of Reeves, and then I try to see what vessels are there. If I don't, I go higher for the harmonic, and there are two modes of the harmonic: fast and slow. You know, the quick and slow ones. I just slow to. I do 2 times. I do the slow upper, I do the slow lower, and then I use the rapid cutting in between. So I am sure that the vessels are all sealed and does not bleed. But only for MNG and only for which are going high up. Otherwise, I won't touch it.
Okay. Now coming
my
to
philosophy, just one point, madam. Because if my probe is reaching there, or harmonic probe is reaching there, I better clip it with the Liga clip rather than putting the harmonic.
That's absolutely fine, by absolutely fine.
Yes.
I just want to make it quicker. That's all. Absolutely fine. Absolutely fine. And your technique is probably safer in a way that external laryngeal, the supralaryngeal nerve might not get caught up with our harmonic shears. It might be safer also. I agree with you 100%.
Yeah. Now coming to the nerve monitoring. Anyone uses, and when you use, if at all you are prefer to use.
So we have
you have, no, Dakshish bhai?
We have, but I don't use. So do you?
I use in every case. I use in every case because as like say, I have experience of using now monitoring for last say 1.5 year only.
Okay.
And as I'm getting acquainted with that, and people say that you have to use it in every case because you have to go through all the problems of now monitoring, all the troubleshooting you should know. Then only you would better use it in a difficult cases.
You
So at
use on a
present, I'm
continuous mode or intermittent mode?
intermittent mode only, not the continuous mode.
Okay.
But in every cases, right now
Do
if
you
it is a
use
small thyroid
continuous
also,
vagal monitoring, or you just use the muscle monitoring? Because there are two types of continuous modes. Do you use the continuous vagal monitoring, or do you do the continuous muscle monitoring?
no, I did use continuous. It's a intermittent only, and that too because what happens even if you start resetting in the after dividing the strap muscles, it gives in between signals as well. So I start the monitor only when I reach to the targeted area. Otherwise, it is on the mute mode.
Oh, okay, okay. I have Amrita. We don't have the RLN monitoring, so we don't use it. But during my fellowship, we use it regularly. So redo cases, large goiters, and goiters which have aerodigestive tract involvement. These are the three indications that I was taught to use. Otherwise, we don't use it. And you need a special endotracheal tube. And like Dakshish Bhai said, you have to troubleshoot the instrument so that you don't get spurious results from just moving the tube, because movement of the tube will cause signals.
Yeah.
Any movement of the tube, any swallowing by the patient will cause signals. So you have to, and any vagal stimulation also will cause the tube to give signals. So you have to be very careful and all of that. But in Amrita, we don't have RL monitoring, we don't have continuous monitoring. So I'm not the right person to answer this question.
Yeah. No, this is the only thing, loss of signal upon stimulation of the first side RLN. Then you defer the contralateral thyroidectomy as second operation after functional recovery of the ipsilateral. Do you agree for this sentence? Or?
But there's a caveat. The caveat is that your system is well placed and then anatomical continuity of the nerve. So if your anatomical continuity of the nerve is present, then you are anything, then just wait to the contralateral side. But the problem with the rectilineal nerve recovery is it's never predictable. And if you wait for too long a time, the rectilineal joint gets fixed and the cord doesn't move. So it becomes difficult after some time to assess whether the cricoarachnoid joint is fixed or the nerve is fixed. It becomes very difficult. So that's the caveat. So theoretically, if somebody said to me that the nerve is intact, you don't have to repair it, it might wait for a few days. I mean, not a few days, a few weeks. But the concept is correct. If you don't get a signal from the ipsilateral side, you delay the contralateral side for safety's sake.
Now, superior and inferior parathyroids, how exactly you preserve? What are the precautions you take? It is only preserve the parathyroids or the vascular supply as well as the venous, and how do you manage all this?
I think the first and most important thing is to identify the pathogen.
Yeah.
Only if you identify can you preserve the vascular niche. So superiors are very easy to find. You stay extracapsular, you identify the nerve. You don't dissect or bipolar and lateral the thing. And there's always a confusion what supplies a superior pathogen. I still haven't been able to make some papers say superior pathway, some papers say inferior thyroid, I still can't make up my mind which actually supplies the parathyroid tissue. If you say I am superior or inferior, it's very difficult because the bipolar identity extra capsule and deliver the thyroid tissue. So my landmark for the superior parathyroid is the entry point of the rectal luminal nerve. It's salmon colored. It has a leash of blood vessels that go on, and in most instances, the parathyroid will be congested. Don't take that as a bad thing. If it's pale and it doesn't bleed on scratching, then it's a bad thing. What I was taught by Jonathan was that all parathyroids, irrespective of whether they are vascular or not, will be venous congested and they will recover. So superior parathyroid is, close to the entry point of the rectal nerve. Inferior parathyroid is that 1 centimeter or whatever
Inferior ending.
dimensions that have been mentioned, but you never find them there. And if you have a lot of central compartment nodes, it's even more difficult to identify the inferior parathyroid. So I think the superior parathyroid is the most reliably preserved, and that's at the entry point of the nerve. That's the easiest way to identify it. And if it's venous congested, don't worry, it will recover. But if it starts bleeding arterially, then we have to replant it in the sternum or the staph muscle.
Yeah. Any other points to add on? Ritu, that's it.
No, same subcapsular dissection and meticulous dissection and easy to identify the superior parathyroid glands. That's what I feel.
Now coming to the neck dissection. When do you do central compartment neck dissection? When do you do central compartment with lateral neck dissection?
So when we have done a preoperative sonography and there are no lateral neck nodes, then we don't do a lateral neck dissection. And however, if we have a Bethesda category 5 or 6 nodule, then I would always prefer to do a central compartment clearance because it is very difficult to go in back again and then remove the central compartment lymph nodes. In case in the postoperative scan, if there is uptake in the central gland, that would be difficult. So always preferable to remove the central compartment nodes at a time we are doing a hemithyroidectomy in level 4, 5, 6 category Bethesda category lesions.
Okay.
So my question is, do you do berry picking or do you do carotid to carotid in a facial sheet like how we do a normal neck dissection? Because I've never been able to do that. It's always been berry.
Yeah, it is never very happy with doing that central compartment neck dissection because the recurrent laryngeal nerve and the parathyroid glands are the maximum at risk in that area. So ideally, it is best to do the carotid to carotid, but as Sir said, we try to remove as many nodes as keep the recurrent laryngeal nerve bare and try to identify the parathyroid and try to remove all the tissue rest in the tracheoesophageal carotid area.
These are all the
speaking,
thyroid, for
few
thyroid only it
surgeons-
was done. This is a central compartment. Other side I have not taken. This is all other various cases. So I think the only thing is with recurrent laryngeal in the central compartment because you're scared of RLN and parathyroids also, inferior especially. So that's the only thing.
it is so many people what they do after doing the thyroidectomy they just palpate the central compartment. So palpation many a times it's not a proper technique. It should be an exploration where you need to go along with the you need to open up the recurrent laryngeal nerve downwards and then look for the nodes. Most of the time we have already preserved the superior parathyroid and it is only the inferior parathyroid which is at risk. But palpation without opening the planes of the recurrent laryngeal nerve, many a times it will miss the node. So it is better to open up the sheath and then do palpation, and then most of the surgeons we do berry picking.
I don't think it's the fascia along with the fat and the lymph nodes. We need to take it out. I think that's the thing. And the neck dissection is what neck dissection you do? What type?
So
Functional neck dissection.
Yes.
2, 3, 4 clearance.
Usually it is level 2.
One important thing for the training is that please, whenever you have N plus disease in a thyroid, specifically ask the ultrasonologist to look at level 6 and level 5. Level 6 we need other imaging, but level 5 the posterior triangle should also be looked at. And most of the lateral lymph nodes in a thyroid malignancy are retrojugular. It is not between the carotid sheath and the larynx. I don't know how many of you have done thyroid with large neck nodes, but a lot of the neck nodes are retrojugular. And we have to look at level. You have to dissect under the jugular vein, under the carotid to fish these nodes out. So it's not like a normal neck dissection where you just peel off the fibrofatty facial layer and just take it over medially and then cut it off. That's not how it works.
Yeah.
And you also have to remember low level 4 nodes, which may be around the transverse cervical or the subclavian that you have to remove. And please always ask for level 5 ultrasonography because that's where most of the nodes are.
Yes. Usually we go for complete neck dissection, like modified radical neck dissection. And sometimes when you find the neck, the node involving any of these structures, we sacrifice them. You can see, I mean, some, I don't think here we have that. Okay.
One important thing is to look for the what do I forget the lower most part in the level 4 neck dissection when you are removing the nodes very much down for the chyle leak, because that is the place when we have done the thyroidectomy as well, and the lowest level 4 neck dissection on left side. Sometimes happen on the right side also, but be careful to look for the chyle leak after like giving the Valsalva maneuver or compression on the abdomen, and it has to be tackled there and then. Otherwise, it may create problem later on.
Yeah, well taken. Now, minimally invasive thyroid, we'll not talk about this. Like any experience of the panelist, because I don't have this experience. Deepak?
So I have seen a lot of these cases. I have not done any of them. But in a malignancy, everything depends upon the size.
Yeah.
And what the patient needs. You can't do a 4 centimeter or a 5 centimeter nodule, which is, so usually it's 2 to 3 centimeters is the upper limit on what you can do by Baba or axillary or whatever approach you want to do. And you can't do it for, I can't see your screen. It's just showing black. Ma'am, can you share your screen again?
It is now?
I can't see, ma'am. It's all black.
Ritu, you can see?
Yes, ma'am, I can see.
Yes, ma'am, we can see.
Let me, okay, that's fine.
Yeah,
So,
indication is nodule less than 3 centimeter intrathyroidal.
Yeah, it's usually 2 to 3, and there should be no extra thyroidal extension to the strap or to the soft tissues of the neck. Those are the 2 most important things that we need to take care of. Then there was a paper in 2019 which looked at the tumor volume, but that wasn't very significant. So the only 2 things are extrathyroidal extension and nodules between 2 and 3 centimeters in size that can be removed. And then you have to combine that with neck dissection. But for what? You give a large axillary incision, you dissect in the suprapectoral plane, you cause a lot of fibrosis. It really doesn't matter because the most important thing in a thyroid scar is where you place it. The closer you place it to the clavicle and the suprasternal notch, the worse your hypertrophic scar and keloid is going to be. You have to place it slightly above. And then if you use collagen sheets and if you use steroid injections, if you use Vanicza cream, the scars become almost imperceptible. But you have to plan your scar for a future salvage neck dissection or whatever. So the placement of a scar in thyroidectomy is a whole new topic. But Baba is good. People have been doing it. But I really don't think that there is any superlative benefit comparing these minimal invasive techniques. It's not been proven as yet. So in our country, in our context, I think a neck scar is fairly okay.
They are not minimally invasive, they are maximally invasive, but
maximally invasive. Correct, by maximally invasive
and remote access.
And I've done and seen overseas the transvestibular approach. It is totally hideous. It's really hideous.
I did 2 cases, then I stopped doing that transvestibular.
Yeah, from somewhere to somewhere you go and it is really bad. So I don't think unless there's level one evidence to suggest that these techniques are better, I think still for the Indian population that comes to our hospitals, transcervical approach is sufficient.
Okay. Now, some interesting, other cases where the invasion is there. If the recurrent laryngeal now is through the tumor, what you do? You sacrifice the nerve?
It depends upon the preoperative vocal cord status.
Yeah. No, in this patient had, I think, palsy pre-op also. But one patient.
Then you divide it.
One patient never had the palsy, but on table, it was going through, the nerve was going through the tumor. I could not, dissect the tumor off the nerve. If at all I had done, I would have left tumor on the nerve. And so had to sacrifice.
So if the patient has preoperative nerve palsy, you divide the nerve. But if the patient has no nerve palsy, you try to preserve the nerve as much as possible. I am not saying oncologically compromised, but if it's working, you try to preserve it as much as possible. Otherwise, resect it. But there are a lot of people who ask me whether they should reconstruct the nerve by putting a nerve graft. That doesn't work.
I don't know. I've done two Hansa. Here you can see stitching into where it was entering into the cricothyroid. The volume of the cord is okay.
So that's the only thing that you can expect. You can expect the vocal cord not to denervate, and you can expect some tension in the vocal cord because
that's all.
The problem with the recurrent nerve is there is no topographical arrangement of the adductors and abductors. So whatever nerve graft or substitution you do, it will not replace adductors to adductors, abductors to abductors. All you will get is a tense vocal cord. That's all.
Yeah.
So you'll be able to prevent hoarseness, but you can't get movement.
Correct. Yeah.
So the preoperative function of the vocal cord is very important to decide whether we want to sacrifice the nerve or not, as you said, madam. But there are a few cases which have been reported in which a non-functioning nerve, there is a 5 to 10% chance that it may be functioning if you are able to remove the macroscopic all tumor around the nerve. So technically, we should not have an R plus resection. It should be an R0 resection macroscopically. And if you can preserve the nerve, okay. Otherwise, then the nerve goes.
Yeah. And then if the trachea is involved, if the larynx is involved, I think just 2 sentences you can give. Any one of you, your opinion.
If larynx is involved, laryngectomy or partial laryngectomy. Trachea is involved, resection, end-to-end anastomosis. That's all.
Yeah. So I think post-operative.
One question: if you have to preserve some amount of thyroid tissue to preserve the recurrent laryngeal nerve, it can be taken care by radioiodine uptake.
That's what I want. Now you're coming in. You're pitching in.
Okay.
Now post-operative follow-up. This is very important. So now we have done the surgery. So Ritu, what you will do, and then Kiran will take over.
Yeah, Dr. Kiran's opinion is important, but I think that we need to see whether we have done a hemithyroidectomy or a total thyroidectomy.
No, we'll talk about total.
So we have done a total thyroidectomy. So the patient has to be kept off any thyroid supplement for around 4 weeks for the TSH levels to rise above 30.
Yeah.
Then that would be a good candidate for undergoing a radioactive iodine diagnostic scan.
Okay.
And the patient, I think, if there is followed up with serial thyroglobulin assays, and if there is no very low risk patients and there's no uptake or minimum less than, I think, 5%, then the patient is observed annually.
Basically, if it's a low,
you can pitch in. Yeah.
If according to ATA, if it's a low risk, and if the TG is more than 5 to 10, then we need to do iodine scan because there will be thyroid tissue left out. So it's mainly ablation. It won't be a therapy. It's in low risk this thing, but it also helps in follow-up, a TG follow-up. So a low risk with TG more than 5, 10, iodine scan and therapy is indicated if there is a remnant thyroid tissue. And any stage, if the TG is more than 10, 30, radioiodine ablation therapy is indicated, ma'am. So intermediate risk, high risk, it is indicated. If high risk patient, if the post-op TG is less than one also therapy is iodine scan and therapy is indicated. So only increased TG in low risk we can consider, will consider for this thing. So
Now, can I go back to the question you
yeah,
said that if we leave behind disease
yeah.
on the recurrent nerve,
Mm-hmm.
in a functioning nerve, non-functioning, there's no point, obviously. In a functioning nerve, do we have evidence to say that we can preserve vocal cord function, leaving macroscopic disease on the recurrent nerve by giving radioactive iodine? I have never read any of such papers.
No, not many, sir, but sometimes in private practice we get a lot of remnant thyroid tissue. But still,
But that will be in the tracheoesophageal group. Have you got any patient where they say that did they say that it's either in the Berry's ligament or T groove or nerve entry point? Have you had any experience with patients who had disease over the nerve that was cut? The tumor was cut off, and there is disease over the nerve. Did you have any experience with ablating such patients and preserving vocal cord function?
So
basically, that would be a great thing to do.
No. So basically, or if thyroid tissue is the thyroid tissue will be taken care by radioiodine therapy. But as we have not followed up with a vocal cord this thing, I'm not sure whether there was a vocal cord palsy. But theoretically, whatever amount of thyroid tissue left can be taken care of radioiodine therapy, sir. So
in those cases, do you follow dosimetric ablation or empirical ablation?
No, sir. Basically, if there is if there is a lymphatic, if it's only a low to intermediate risk without lymphatic metastasis, we do 30 to 50 millicurie this thing, sir. So we don't do dosimetry regularly, and anything with lymphatic mets, we go up to 100 MCI. And if there is a pulmonary metastasis,
if the nerve is involved by the tumor, you still go to 100, obviously.
Yes, sir. We go until 100. So if it goes to intermediate risk, sir, any extra thyroidal extension, size more than 4 centimeter, 3 to 4 centimeter, lymph node, then we go up to 100 MCI. Sir. Intermediate risk with extra thyroidal extension will go up to 100 MCI. A low risk with raised TG, 30 to 50 MCI.
Oh, okay. Thank you.
Yes.
I had a question for Dr. Kiran. What happens if the histopath is poorly differentiated thyroid carcinoma? And what is your this on radioactive iodine scan for these patients?
So we need to do both iodine scan and FDG PET CT. If there is uptake in FDG, then there is all lesions shows uptake FDG uptake, then it won't be iodine avid. So then anyway, we need to do a whole body iodine scan also. But generally, FDG avid lesions don't take iodine uptake, so we don't do iodine therapy. Then it will go to chemotherapy or anything. But we have one more drug called FAPI, fibroblast activated protein inhibitor, which express in FAP receptors. So that is used for therapy in few centers in AIMS basically. So, and they have shown good responses. Poorly differentiated and also medullary thyroid CF. They are trying FAPI therapy, FAPI PET CT and FAPI therapy.
Okay, thank you.
Okay, now I think this is how we plan our follow-up. Low-risk patients 6 months with suppressed thyroglobulin and thyroid function test and a neck ultrasound at 12 to 24 months. Whereas high risk every 6 months for the first 2 years with thyroglobulin, thyroid function and serial. And then depending on what you get, then your follow-up will be planned. So it's a dynamic.
We also look at thyroglobulin antibody, man.
Yeah.
Thyroglobulin antibody also is important.
Okay. Yeah, thyroid antibody, depending on the risk, trend in thyroid, presence of thyroid antibody, depending on that, your further follow-up will be decided. And it's a dynamic risk stratification. It is not that status quo, like you need to upgrade your risk stratification. Then this is the clinical outcome and management implication. Whenever you get a response, excellent response, clinical incomplete response, structural incomplete response, interdeterminate. I think that's given in the book. Jatinshaw, I think everyone can just see that. Now coming to the targeted therapy, I think we all refer to our medical oncologist. When we refer, before going for this, in some scenarios where we have recurrent lymph node coming up in level 5, as you said, so how do we plan now? We have done total thyroid with neck dissection, but again, the lymph node is back in neck or in mediastinum. How we plan?
Ma'am, lymph node metastasis does not respond to targeted therapy as solid metastasis. So any lymph node metastasis that is operable should be operated. Now, the role of targeted therapy, lenvatinib or sorafenib or whatever, is only for progressive metastatic lesions that are symptomatic. We don't give these to asymptomatic metastatic lesions. So, if any lesion is operable or if any mets like in the spine can be treated with radiotherapy, we do that. But for a DTC, there are so many complications, hand, foot, whatever disease, mouth disease, whatever, there are so many complications. And you don't know when to stop, and you need periodic imaging to see the progress. So it's not that easy decision to make. So my suggestion would be any lymph node disease that can be operated can be operated. But if you see a progressive metastatic lesion, then we start them on TKI or other inhibitors.
If the skeletal metastasis is there, follicular carcinoma presenting with skeletal metastasis, how do you do?
I would give them EBRT.
No, like first you treat the skeletal metastasis and go for thyroid surgery, or do the thyroid surgery and go for skeletal metastasis?
Do thyroid surgery, give RAI, and then follow that up by EBRT if there is impending fracture.
Unless until, yeah, spine impending fracture. Okay. And then carotid artery involvement?
Carotid artery involvement is not an indication for TKI or anything like that. In those patients, if you have an R plus resection, people give RT, but the role of RT in EBRT and thyroid malignancy is very poor, very, very bad results. You don't get any cure or disease remission whatsoever. It's just a last ditch attempt. In those cases, if the disease is progressing, I might consider for a TKI.
Manoj, good morning, Dr. Manoj. I think we are finishing. Can I just ask my pathologist to give 2 minutes just for the histopathology?
Because they said that unless we start on time, this live surgery session will be delayed.
Yeah, just 2 minutes.
Okay.
Dr. Suchita? Hi, Manoj.
Hi.
Suchita? If she's there, she'll, yeah. You can start, Suchita. Hello.
So I'll just run through the new WHO classification of 2022 updates. So these are the changes they have done. So the terms colloid nodules, multinodular goiter, adenomatous goiter, and multinodular hyperplasia has been they have been replaced by follicular nodular disease, as they have found out that individual nodules, most of them they are monoclonal, and it's impossible to distinguish between non-neoplastic and follicular adenomas on the basis of morphology alone. Now, we have another entity under the benign thyroid neoplasms, that is follicular adenoma with papillary architecture, which was previously termed as papillary hypoplastic nodule. Now, these lesions have a papillary architecture but lack nuclear features of papillary thyroid carcinoma. And we have another category called as low-risk follicular cell-derived thyroid neoplasms, which includes NIFTIP, tumors of uncertain malignant potential, and hyalinizing trabecular tumors. Now, they are rendered in light of strict diagnostic criteria, these entities clinically behave in more or less benign fashion and do not require aggressive treatment modalities. Now we have follicular thyroid carcinomas. We have three categories: minimally invasive, encapsulated angio-invasive, and widely invasive FTC. These tumors are RAS driven, and this remains same as in the previous classification. However, the follicular variant of papillary thyroid carcinoma, we have two categories: infiltrative and encapsulated variants. Now, these are also RAS driven, and whereas infiltrative ones are BRAF driven. Now, similar to the follicular carcinomas, the encapsulated follicular variant of papillary carcinomas, they have proposed to subdivide them as minimally invasive, encapsulated angio-invasive, or widely invasive. Now, the term HERTL, the end of a famous misnomer. Now, this HERTL is replaced by oncocytic because HERTL HERTL derives its name from Carl Hertel, who described the parafollicular C cells in the canine thyroid gland rather than oncocytic cells of the thyroid. Now, it's important to subtype PTCs. In the new classification, they have focused on subtyping the PTCs because BRAF-driven PTCs have worse outcomes compared to RAS-driven, and there is overrepresentation of V600E driver mutations in specific PTC subtypes. No longer it's recommended to simply refer to PTCs measuring less than 1 centimeter as papillary microcarcinoma without any additional subtype information. So we should subtype even the papillary microcarcinomas. Now we had a variant called as Cribriform morular variant, which is now a separate entity because this tumor is they've now found out that it is of uncertain histogenesis. Now, there is another entity, intermediate entity called as differentiated high-grade thyroid carcinoma, which is between poorly differentiated and the well-differentiated tumors, which have more necrosis and mitosis. So these are the changes now they have done in the new WHO classification. Thank you.
Thank you so much, Dr. Suchita. That was really informative. And
thank you. Thank you all the panelists. Over to Dr. Manoj.
Thank you.
Yeah. Manoj.
Hi, Deepak.
Can I speak for a minute?
Please.
Yeah. For the audience and everybody, this is a man whom I hugely admire because there's an element of crusader in him, in whatever he does. He loves being unpopular at times and controversial because of that. He runs into quite a few skirmishes. But whatever it is, he is one man whom I really admire because these are people who have a clarity about the cause and also about the effect. I personally am also one of them. And this particular topic of auditory nerve spectrum disorder, something which I felt a lot of ENT surgeons are not at all aware. And then we keep on crying that we are not in a part of the cochlear implant program, this thing. Unless we go into the depths of audiology and realize we are only surgeons delivering a certain thing, I think this topic is my favorite topic and I wanted Manoj to do it. And I'm very sure that he will do justice to this. And by the way, Manoj, I've spoken to Janki. He won't mind a 15-minute intrusion into his time because he came all the way from Dubai.
No, that's what I was actually feeling very bad for Janki.
No. Again, let me tell you, to be fair to Bharti Papa, she started at 9:08. So that's why we kept quite till 10:38.
Bharti, I know, is always very correct. So she never actually exceeds any time. I've seen her.
So from whatever point you start, it will be 1.5 hours. Don't worry, I'll talk to Janki. And like you, most of them are kind to me despite their rules.
Thank you so much. Thank you.
Bye.
Thank you, sir. Thank you, Deepak, sir. We welcome the next panelist and the moderators, Dr. Manoj Manikot, sir. Welcome, sir. And thank you, Bharti, madam, for the wonderful deliberation. And thank you to all the panelists from the previous speaker talking on the very nice clinical pearls there, which can be a useful tips for all the doctors listening today. Manoj sir, without wasting much time, it's over to you and you, the panelists.
So thanks again, Deepak. Thanks, Micro Labs, for yeah. Can I go to my presentation, please?
Yes, that's all. Yes.
Okay. So thanks a lot, everyone. And like Deepak said, this is some of the things that are actually less understood. It is one of them is not very common, other is very common, but we still feel that there is no coherence among many ENTs about what to do with this. So I have chosen this panel of very, very knowledgeable people, and I have told them that we will restrict ourselves to what is the most important thing. So, of course, you would know them all. Dr. Shalabh Sharma is the chief ENT surgeon at Gagaram Hospital. Many years of experience, trained in England. He's got a lot of surgeries to his credit, more than 1,000 cochlear implants. And he and I actually started off doing implants together. Soumitra, the other very young person, also many implants, started the first program in Gujarat. Brilliant surgeon, Monish Grover. You will, I mean, if you are in India, you would know him. He's written many books. He's got a classification to his name, professor at SMS Jaipur. And Preetham, of course, the brilliant academician from AIIMS Bhubaneswar, who is also a great friend of mine. All these people are top-notch academics. So also Raghunandan, who's one of the few guys with a special qualification in otolaryngology from England, works in MERF, Chennai, and is one of the most knowledgeable persons I ever met. So before much ado, we will go over to the topics in idiopathic sudden sensory hearing loss. This terminology is very new. We will talk about each of them as time goes by. So we have 5 presentations. One by Preetham on diagnosis, by investigation relevance by Raghunandan, and steroids, how much or often by Monish, intratemanic medication by Shalabh, and surgical options by Soumitra Shah. So I will be sharing the presentation from my screen. So all of you would restrict yourself to 5 minutes or less. And to Preetham. Preetham, you will, everybody else, will you please mute your screens, including me, and you are going to be talking on idiopathic sudden sensory hearing loss. Dr. Preetham Chapati, over to you, please.
Thank you, Dr. Manoj. I'll just start as soon as the presentation moves on.
You can see it?
Unfortunately, no. I can just see your slide.
You're not able to see the presentation. Is anybody? Did you see my earlier slide? No?
Yes, I'm able to see the topics are being displayed.
Topics for ISS actually is what we can see right now.
You're not able to see the
click on it, sir. Can you click on it again?
Wait a minute. I will. Okay, so I think I will start all over again. I will not use a hyperlink. So I will. Are you able to see it now?
We can see you.
Oh my.
Yeah.
Right.
I think you'll have to share the screen.
I will go over directly and run your presentation from the thing. So Preetham. So let me share the screen. No. Are you now able to see it now?
Yes.
Now?
We can see your screen. Yeah, you'll have to open up my PPT.
Okay, 1 second.
Somehow Preetham's presentation is not visible.
Very thing. Let me share it once again. Let me do it once again.
Maybe it's because of Preetham.
Okay, I will share it once again. Is it okay now?
Perfect.
Yeah. Yes, sir. Perfect.
Yeah,
great.
Good.
Okay, great. So we are good to go now. So I'll be very, very brief in what we are presenting as guided by Dr. Manoj. So I'll be talking about imaging in auditory neuropathy. So are we starting with this, sir? Auditory neuropathy spectrum disorder? Or
I'm sorry. No.
Yeah.
I think I had created a hyperlink. So, okay. Now is it okay?
Yes, sir. Yeah, it's perfect.
Is it okay now?
Yeah, perfect, sir. You just have to do the slideshow.
Now we are seeing Preetham.
Lucky you.
Okay now?
Yeah, you just have to
The slideshow,
run
perfect.
it in the slideshow.
It's all good.
Is it okay?
It's all good.
All
Yeah,
good.
perfect.
Fine.
Perfect. Okay. So we're going to talk about diagnosis of the sudden sensory neural hearing loss, which is more often than not idiopathic in nature. So we tend to remember it with the threes. It's a sudden hearing loss, which is rapid in onset and usually occurs over a period of 3 days or 72 hours, where there is a subjective sensation of hearing impairment in one or both the ears. It's usually considered that there should be a 30 decibel loss in the bone conduction levels at least 3 consecutive frequencies, which is usually easier if you have a previous audiometry report available with you. But otherwise, if considering that the opposite ear is normal, it's always compared to the opposite ear or the contralateral side. And then there is no readily identifiable cause in spite of a thorough investigation, which is again a little bit controversial because the investigations are numerous and sometimes the main disease shows up even 6 months down the lane. So that is something which is a little bit of a gray area. Next, please.
Yeah.
Yeah. So there's always an importance of acknowledging the fact that this hearing loss is something which is new. So there are 4 categories which are considered here. So one is very certain, where the patient has a previous audiometry report with him, and then you can clearly show that there has been a loss which has happened. Certain, when the patient doesn't have any prior otological history, but he's very, very sure that he has or she has a hearing loss. Fairly certain, the patient has had some long-standing hearing problems and reports that this particular episode, the sensory neural hearing loss or the hearing loss has become subjectively poorer. So this is when they have any prior otological condition, and then this is just worse and with time. And uncertain is where the clinician personally feels that there is some pre-existing hearing loss, but the hearing loss was never documented, or we are not getting the exact information that we want to anticipate. And one of the easiest way or a nice way for the patient to really examine this is the hum test. So you can just press the next. So if the hum test is something where you ask the patient to just hum a song, and if he hears them well in both the ears, then it's mostly conductive. And if it's just less on one side, then the patient knows that there is something bad there, and he or she could be suffering from a sensory neural hearing loss. Next, please. So these are all the numerous causes that are commonly associated with sensory neural hearing loss. And when we meet that, the other potential causes have to be ruled out. Next and next. So we need to rule out these all pathologies that can occur. So this is either through history, either through investigations, or either through blood work that you need to do. But you need to rule out these as a cause of the sensory neural hearing loss. Next, please. Yeah. So you would it's a diagnosis of exclusion. Next, please. So there are specific etiological factors that you need to consider depending on whether the patient had prior history of any disease or doesn't have any prior history which is suggestive of any infection. But this will be touched upon by the rest of the speakers, and I would just stop it here. Thank you.
So thank you so much, Pritham. So the next topic would be by Raghunandan, and he'll be talking about what the investigations and relevance in sudden sensory hearing loss. Raghu,
Yes, thank you very much, Dr. Manoj. It's always been a pleasure to be conversing with you, brainstorming regarding neurotology. And today we are in the midst of a panel of neurotologists pan-India from different elite institutions. So I thought it would be great for us to start from the basics. And in fact, Dr. Pritham has actually given us a very nice prelude to what actually idiopathic sudden sensory neural hearing loss means. And in today's world, I think we are seeing more of this. And in fact, it's very important not only for ENT surgeons, but also the medical fraternity and also general public to understand this is an absolute otological emergency. Okay, next, please. Right, so the first investigation, I think sitting in a busy clinic, some of us are trying to bypass the basic audiological test, isn't it? Tuning fork test. And this is taught to the medical students, in fact, postgraduates, and it's always important for the exams. But I think we lackadaisically kind of relax and reassess our interpretation based on audiometries. Remember, audiometric evaluation is only as good as the audiologist. So I think we should rely on ourselves more than others. And in fact, that's exactly what this clinical practice guideline from the American Academy of Otolaryngology, written by Sujana, and team had actually emphasized, in fact, please do the first clinical investigation, which is the tuning fork test. And if suppose you pick up a false negative Rene, that's exactly what is pointed out here. If the sound is heard better by bone conduction or Weber test, to the opposite side. So you should have a warning bell in your mind to say, oh, possibly this is sensory neural and it's just not an AOM or a conductive hearing loss. So it's always recommended that, in a clinical setting, use a 512 tuning fork and perform the proper Rene, Weber and absolute bone conduction test. Next slide, please. So this is, in fact, a patient who is currently admitted under me in the hospital, young lady who came with sudden hearing loss 5 days ago. So one side profound loss, the other side is near normal hearing. And of course, we are going to be talking about the medical management of this. But essentially, this is what we see day in and day out. And unfortunately, it was 5 days late because they went to a general practitioner who gave her 5 days of antibiotics. And then she has ended up in our ENT segment. So that's really unfortunate. So as Preetham had really explained in detail, there are quite a lot of etiological factors. And in fact, the investigation should be dependent upon what the etiology is. So broadly, to keep in mind, it is possibly viral, or is a vascular problem, or it's either autoimmune, hematological, or a central nervous problem. So if it's a sensory neural hearing loss, we always keep these 5 broad differential diagnoses in our mind, and we need to evaluate these things further based upon the etiology. Next slide. So, of course, we always do an audiological test battery, which will include the basic Puton audiometry, the impedance audiometry. We also perform an OAE to rule out any middle ear disease, and ABR, which will also show the performance of the cochlear threshold. It's always mandatory for us to do an MRI. I think many a time general physicians do a CT brain, and then they send the patient to us. CT doesn't show anything at all. And even a plain MRI without contrast doesn't really pick up an intracanalicular retrocochlear pathology. So it's important to remember that if you have a unilateral sudden sensory neural hearing loss patient, always think of doing an MRI to rule out a retrocochlear pathology. Next slide. Incidentally, sometimes we do find abnormalities, something like this, an IP2, a Mondini deformity with a large vestibular aqueduct. So this will be classically a child who's had some kind of a fluctuating hearing loss, suddenly tripped and fell, had a head injury, and then end up profound loss. So obviously, when you do imaging, this kind of cases, if you do a CT, it would pick up a large vestibular aqueduct. Possibly 10% of these patients who have Pendred syndrome end up with sudden hearing loss. So this is a differential diagnosis as well. Next slide, please. And in older patients, sometimes hearing loss may be the only symptom which they've been presenting for many years, but suddenly now maybe there is a small acoustic neuroma which is ruptured and they end up with a profound loss. So it's mandatory for us to look for an MRI T1 weighted image with contrast to pick up any such lesion, but they may be usually smaller than this. Next slide, please. And incidentally, we may also pick up some vascular lesions, and we have to have a good radiologist, neuroradiologist with us who can actually identify these. Otherwise, they would say the MRI scan is normal. But in fact, this is a posterior circulatory stroke, and there is an anterior inferior cerebral artery infarction. So you need to pick up those areas where the actually infarction is setting in, because otherwise you're wasting time giving them steroids, but patient should be under a neuro care. Next slide. And this is the last one. Don't look only at the inner ear, always look at the rest of the brain. And here, in fact, you can pick up multiple sclerosis, and possibly that is actually manifesting in the auditory brain. Next slide. So, in fact, if it is bilateral sensory neural loss, we have got to think of a few more things. Always think systemic. Viral, very unlikely that viral causes bilateral profound loss at the same time. It may be of asymmetrical hearing loss. But one common incidence that we are looking up nowadays is autoimmune hearing loss. And this is where you actually have recurrent bouts of hearing loss. Patient comes, has steroids, get better, go home, come back again. And also think about other syndromes related to this and systemic causes and central causes like diabetes, wherein there can be a small vessel ischemic disease leading to neuropathy. Next slide, please. So essentially, to take home message from the investigations part is primarily do a tuning fork test, do a complete audiological test battery. Don't rely on one particular investigation. Take a detailed history, look at the MRI scan with contrast, rule out any organic pathology, do a full blood panel to identify different etiologies, which was described earlier. And finally, also do an autoimmune screen if everything else above is not. Next slide, please. So this is from our experience in having essentially identified the reasons behind intratympanic injections for sudden hearing loss, but we'll think about this later when it comes to management. Thank you.
Thanks so much, Raghu. See, what is so important in both these papers is that one, the hum test and the tuning fork. Both these are so important. Don't wait for sending a patient to audiology. I think this is something that all of you must take home from this thing. So Monish will now talk about how steroids are given. Now, steroids are the mainstay of treatment in sudden SNHL. So Monish, over to you. And here you are on your presentation.
Thank you. And thank you, Dr. Manoj and Dr. Deepak Haldipur sir especially. And it's, so as Dr. Manoj mentioned, we have already discussed the preview and the investigations required. We're going towards the management part, and systemic steroids, as you just mentioned, are the mainstay. Can I have the next slide, please? And I want you to play that video if you could.
और पहला सवाल अवनी का है। उनकी माताजी को दोनों कानों से बहुत कम सुनाई दे रहा है। डॉक्टर्स ने ऑपरेशन की सलाह दे दी है। तो क्या उनकी माताजी के कान ठीक हो सकते हैं ऑपरेशन के बगैर?
अवनी के माताजी के ही नहीं, पूरी देश की माताओं के कान ठीक हो जाएंगे। एक तो ईयर ग्रिड वटी ले ले और ईयर ग्रिड डोप कान में डालने, नहीं तो सुदर्शन एक पौधा होता उसका, अथवा जो ये जो लहसुन होता है उसके भी कूट करके उसका रस एक बूंद 2 बूंद कान के अंदर डाल देते हैं। और ईयर ग्रिड बहुत जबरदस्त है। अनुलोम विलोम जो कर रहे हैं मेरे साथ है हमारे सैनिक भाई, ये करें। और जो है कर्णपुर भी हम करा देते हैं, बड़ा जबरदस्त होता है। कान का एक पॉइंट भी दबाए। और आंख की प्रॉब्लम है तो आई ग्रिड और ये आंख का पॉइंट और दृष्टि आंखों में आई ड्रॉप डाला देते और अक्षी तर्पण करा देते हैं। कान और आंख की समस्या रह नहीं सकती अवनी से लेकर के किसी भी। और इसके
Thank you. So the reason I put up this video is because, this particular thing like hearing loss, it has so many options. Can I have the next slide, please?
और पहला सवाल
So there are so many treatment options which are mentioned even in the literature, right? And people do still use it. And it's because we don't really understand this entity very well that people like the previous video actually go about talking other options for treatment of sudden SNHL or in fact SNHL. The next slide, please. Now, there are multiple papers in PubMed if you really look for the treatment options or the guidelines for sudden SNHL. And this is, I thought was one of the best papers I could find, which was the clinical practice guidelines, which came out from American Academy in 2019. Let's just have a look at the management options which it mentions. Next slide, please. Now, these are the various recommendations which this paper actually makes. Now, if you look at the point number 8, initial corticosteroids. Now, we expect this would be the mainstay, and this is what we usually follow. American Academy, however, mentions the strength of this to be only an option, not even a recommendation, which actually came as a surprise to me. But this paper actually mentions initial corticosteroids as just an option. Interestingly, point number 10, that is intratympanic steroids for salvage therapy. Sorry, can you just go back? Intratympanic steroids for salvage therapy, that's point number 10, right? It comes as the main recommendation now. Instead of the initial corticosteroids, intratympanic steroids, but that's for salvage therapy, which comes in. So for us, if you look at this as a wholesome thing, the primary therapy is only one, and that is initial corticosteroids. As a salvage therapy, the intratympanic steroids then come in. Importantly, point number 11, clinicians should not routinely prescribe antivirals, thrombolytics, vasodilators, or vasoactive substances to patients with sudden SNHL. This is a strong recommendation against this thing, right? So that's what we need to, nothing else which is required really. Can we go to the next slide, please? Well, let's look at the systemic steroids, which I'm supposed to talk about. It still remains the mainstay. It is, considered this idiopathic sudden SNHL is probably the most important otologic emergency which we have. And ideally, the treatment should be started as early as possible. Within the first 2 weeks is what we expect. And I would be really happy if the patient comes to me within the first 3 to 5 days, but at least 2 weeks is the time which I expect that they should be with me. The salt and dosage. Now, I personally prefer prednisolone, and the paper which, clinical guidelines by American Academy mentioned the prednisolone of dose of 1 mg per kg per day is the best. For the younger colleagues who are attending this, we use things like prednisolone, methylpred, deflazacort, everything, right? The papers usually mention only prednisolone and methylprednisolone. If you're using this, just remember that the dose which you need to calculate, 5 mg of prednisolone is equivalent to 4 mg of methylprednisolone, which is equivalent to 6 milligram of deflazacort. So you calculate 1 mg per kg per day for prednisolone, and accordingly, maybe you can take up whether you want to go methylpred or if you want to go for deflazacort, then 5:4:6 what you need to follow. For people who give dexamethasone, I don't think in our country we use that a lot. American Academy mentions that 10 milligram per day of dexamethasone is what is important. Next slide, please. Now, dose division, we all know steroids have to be taken after meals. That is important. However, many of us actually, if I were to give prednisolone, if I were to give it as 30 milligram BD dosage, that's probably not the best way to go about it. It should be undivided dosage. So it has to be a full OD dosage of 60 milligrams in an adult male, if you're looking at a 60 kg adult male, not like 20 mg 3 times a day or 30 mg twice a day. That's not the best way to give steroids. Duration 7 to 14 days full dose and then taper down over the same duration. When do you need to modify it? Obviously, if you have severe reactions like insomnia, but do keep on monitoring for hyperglycemia and hypertension in susceptible patients. We all know that we need to do that, right? Okay, next slide, please. Now, if you look at, can you just click once more? The influence of steroid therapy, how much does it really influence is what we need to understand. Now, if you look at this paper, 2022, right? There was a statistical improvement of hearing with in all the frequencies if the initial dose of prednisolone was above 50 milligrams, right? If you start with a lower dose, for initial dose below 50 milligram, at higher frequencies, the improvement remains statistically insignificant, right? So remember this, when the full dose is what you really want, otherwise the improvement will be less than optimum. Next, please. And the last thing, how much the duration actually makes a difference. If the patient is started within the first week, people say the literature says it's almost 87% who really improve. Within 2 weeks, if it's 2 weeks now, it's 52% only. And beyond 3 months, it's less than 10% that you expect any kind of recovery happening in these. That's how important this autologic emergency treatment is. Next, please. And thank you. And I hope I could make a few points about the steroids which we need to use.
I think it's perfect, Manish. I don't think many people write steroids at the right dose. I think you've been succinctly clear about what should be done for and how much steroids that you need to give for sudden SNHL. Now we'll go to Shalab, who will be discussing about intratympanic steroid therapy. Shalab, will you please come on? And I'm going to be sharing your screen. So there you are.
Hi, good morning, everyone.
You can see the screen, Shalab.
I can see the screen, yeah. Next.
You're able to see your presentation?
Yeah, I can. Go ahead. Just go to the next slide.
Okay.
So the route of action of the intratympanic steroid is basically the steroids. We insert them into the middle ear space, and then through the round window membrane and the oval window, the annular ligament, there is some absorption of the steroid that takes place, and the inner ear perilymph then fills up with the steroid. The communication pathway between the scala and the organ of Corti and the spiral ganglion, so ultimately it reaches the entire neural system, and we are then expecting to see recovery in our patients. Next. Now, the intratympanic versus the IV delivery of, so, some patients we used to admit and keep them and give them 1000 milligram methylpred once a day for 5 days, but now the entire focus, I think from my side at least, has shifted to intratympanic, and this paper very clearly shows that the steroid concentration that we achieve in perilymph is approximately 88 times higher than what we get with IV methylpred or IV steroids. So if you are able to achieve much higher concentrations with intratympanic steroids, then definitely that's the route that I would choose. Also, interestingly, the plasma concentration after an IV dose is 40 times higher as compared to intratympanic. So intratympanic is safer also because you don't really have any, you don't have enough steroid in the system to cause any systemic side effects. So when do we use the intratympanic drug therapy? So ideally it should be, at least in my opinion, the earlier the better. we get patients within the first 3 days of the onset, I would start them on intratympanic steroid. And there is a little bit of controversy in terms of whether to give a combination of intratympanic as with oral, but I would choose to go this route. The oral steroid also at approximately 1 mg per kg, 60, 70, depending on the weight of the patient, milligrams a day of prednisolone, and intratympanic steroid. What I would recommend, what I give is dexamethasone, and it's almost on a daily basis, right? And I'll explain to you later why. So when we go to this slide, you can see that many different concentrations of dexa and methylpred have been given here. Now, interestingly, in India, the only dexamethasone we get is 8 mg in 2 ml, as far as I'm aware. So that's about 4 mg per ml concentration. And the papers that you read from abroad are usually at a concentration of 20 mg per ml or 20 mg in 2 ml maybe. And so there are much higher concentrations available there, and there they give the injections maybe on an alternate day. But here, because the dosage that is available to us is weaker, the concentration is weaker, I usually ask them to have it every day. Obviously, there's a Sunday in the middle, there'll be some other days when they can't make it or I'm too busy. So about 4 to 5 days a week is what I recommend. Coming to methylprednisolone, I was using a lot of methylpred initially, but since the last year or so, I've shifted to dexa because I found that methylpred usually ended up causing a lot of pain to the patient. It was quite painful, and I thought that and I used to give them, in fact, ketorolac and crocin about an hour and a half before the injection, but they would still have pain. So I have now preferred the dexa. Maybe because I'm using methylpred also in the concentration of 125 mg per 2 ml. So that's a stronger dose. Maybe that was the reason. But as you can see, the intratympanic steroids are safe and effective. And like I said, the safety comes from the fact that there is barely any systemic presence of the steroid after an intratympanic dose. Next, yeah. So contraindications to, there are so many, but I haven't had any patient where I've not been able to inject. We have had small kids also who have come in, and they've also been compliant enough to actually take the intratympanic steroid injections, and luckily the kids, most of them have recovered nicely. The complications that are there depends on, I think, again, the concentration of the steroid we are using. Sometimes it matters what brand we use. Some of them seem to hurt more, some less. But usually with dexa, I have not had any problem. I have never needed to give analgesics to the patients after the injection. And very rarely persistent tympanic membrane perforation. Haven't really seen that. And giddiness usually only in the winter in Delhi when the vial is cold, maybe. But usually hand it over to the patient and ask them to keep it in their in the palm for about a few minutes, and then we take it out, and then usually it doesn't cause a problem. Next. The clinical advantage of intratympanic, like I said, no systemic side effects, very much targeted delivery, 88 times more concentration in the cochlear fluid, and 260 times, I think, more if you adjust for dosage. Low morbidity, well, almost no morbidity, I think. Avoids the first pass metabolism, so it stays for a long time. Reduced volume of the drug required, so much smaller doses. Very easy to perform in the OPD, and much lower cost to the patient than an admission and IV steroids. So the papers, you can see, Slattery concluded that 4 intratympanic injections of methylpred improved the speech discrimination scores as well as the pure tone averages for a subset of sudden SN loss patients that failed to benefit from oral steroids. So these are, the US, they talk a lot about salvage therapy. Next. And you can see this, Filippo, the paper says that the mean audiometry recorded after the first line approach demonstrated a significant therapeutic action of short dose intratympanic steroid therapy for a moderate loss with a flat audiogram shape. Next slide. And in this paper, you can see that dexamethasone effectively improved hearing in patients. So there are so many papers out there which do give us the fact that they do bring about an improvement in intratympanic steroids, but a lot of them are now on salvage. And I think here, in at least my circumstances, most of the patients are primary patients, not salvaged. not salvage patients. Next. In the United Kingdom, the National Institute of Health has recommended steroids as a first-line treatment. It's left it up to the doctors and the physicians to decide between oral steroids or intratympanic or a combination of both. The American Academy, Monish has just shown us that they speak more. They don't really have a strong recommendation for steroids in the first 2 weeks, and basically they talk about salvage therapy if you don't recover in the first 2 weeks, after 2 weeks. But I think here we practice a little more active medicine maybe, and I would prefer to give the intratympanic steroids right in the beginning. Thank you.
Thanks so much, Shalab. I think you have a big point that the methylprednisolone definitely causes more pain. We have had the experience too. It also produces more perforations, according to us. Yeah. We tend to use it as salvage, but like you said, no, people vary, and you can't. We really don't have any evidence, strong evidence to either of these what we're doing. Now, Soumitra will be presenting a topic which is very close to his heart and which, I'm sorry, this is not a presentation, so I will open Soumitra's presentation on idiopathic sudden sensory hearing loss. So he is one of the very few of us who has actually been doing intratympanic cochlear implants for sudden sensory hearing loss. So Soumitra, is over to you.
Good morning, sir. Thank you so much. I know it's a little controversial, but I think it's something which needs to be discussed, and then it's left to the surgeon and the patient to decide what they want to do. So the next slide, please. Next. So we know what single-sided deafness is. So we define that as a condition where an individual has a non-functioning hearing in one ear and receives no clinical benefit from amplification in that ear, with the contralateral ear processing normal function. Now, the previous slide, please. The key factor here is that the poor or the bad ear has not and will not receive benefit when traditional acoustic amplification applied. The good ear must have pure tone average that is 20 decibel or better across the pure tone range. So the next slide, please. And when we see these people, patients with unilateral hearing loss, where we've tried treatment with intratympanic steroids or systemic steroids, and if they've not worked, they do have their share of complaints. There is a limited sound field orientation. They have people have been complaining of reduced speech understanding and noise. There is the issue of tinnitus. Some complain of reduced performance at work. There are a lot of females who have social isolation and psychological issues. So next slide, please. And if you look at the treatment options when it comes to us, I think the majority what we do is once we've failed all our treatment options with steroids, we offer them nothing, and most people are okay with them, do nothing at all. If you look at the options available, that you have the contralateral routing of signals, which is no longer an option. Next, we have bone anchored devices next, which will include the Baha from Cochlear, the Ponto, and now we have the next and the Medel bone bridge. And recently, at least in the Western world, what a lot of people are doing is electrical stimulation through cochlear implants. So these are the options available. Next slide, please. If you look at bone anchored devices, the principle of that is they're using bone conduction. The sound is conducted naturally through the bone directly to the cochlea, independent of the outer and the middle ear. This is a principle used by the Baha system. And therefore, implantable bone condition is an effective hearing solution for people with single-sided deafness by transferring the sound signals received on the deaf side directly to the hearing ear. Next slide. So the Baha system generally offers you three types. There's the Baha attract system, which transmits the sound vibrations to the inner ear through a magnetic connection between the sound processor and the implant. The benefit being that there is no skin penetrating abutment, providing a good aesthetic outcome with no real wound care. The Baha connect system is something where you have a abutment which is placed surgically, which connects the sound processor to the implant. Major benefit being efficient transmission of vibrations, providing maximum amplification. For small children with anosia, microtia, there's also the option of the Baha soft band. There's a flexible headband to hold the sound processor, which can then transmit the vibrations. Thank you. The next slide. So the principle is that the sound processor picks up the sound on the deaf side and sends it via bone conduction to the contralateral cochlea, overcoming the head shadow effect, which helps in giving improved speech understanding and 360-degree sound awareness. Next. If you compare the Baha Attract and the Baha Connect, the Baha Attract offers maximum discretion. Obviously, there's no wound care. There's a minimal risk of any infections, maximum ease of wearing. There's less risk of implant loss. And they're compatible with MRI up to 1.5 Teslas. The Baha Connect, on the other hand, gives you a maximum performance. But there is the issue of soft tissue conditions with diabetic patients, with less vascular skin, patients who undergone radiotherapy, chance of necrosis, you won't want them. Obviously, there's maximum retention and they're compatible with MRIs up to 3 Teslas. Next. So as a Baha Connect is something which will give to patients with single-sided deafness with a large transscreen attenuation with candidates who have progressive hearing loss in the better year. The Baha Attract on the other hand would be, the next slide, would be for patients with single-sided deafness with low transcranial attenuation and a normal functioning other ear. Next. But there are disadvantages of bone anchored hearing aids, and you are basically using only the contralateral hearing cochlea. You're not utilizing the peripheral auditory pathways on both sides. So binaural hearing is never possible. And if the patient is complaining of tinnitus, there's absolutely no effect on that symptom with a bone anchored hearing device. Next, please. Very similar to what Baha is, there's something known as a bone bridge, which is by Medel, which is the bone conduction implants where they're implanted into the bone and completely under skin. And you have an audio processor which helps the implant with a magnet and send sound signals to the implant inside. Next. Next, I'll skip this recipe because the principles of the bone bridge and the Baha are the same, but the advantages with a bone bridge are there's intact skin, so it's cosmetically very appealing. The implants position completely invisibly. The audio processors are very discreet and small and can be comfortably concealed under hair, so they're barely visible and there's very high cosmetic appeal. It's a pretty straightforward surgery, doesn't require too many skills. When you compare with other bone-anchored hearing devices, these kinds of intact skin implants are associated with extremely low rate of skin complications, and there's no occlusion of the ear canal. So those are the advantages the bone bridge offers. Next. And then we come to a point where could you have a situation where a cochlear implant through electrical stimulation activate the deaf side and provide a true binaural hearing experience? Next. And we've had the we had the opportunity in the last 12 years to operate on 9 of these patients in the age range of 45 to 62. The etiology was the same in all in unilateral idiopathic sudden SN loss. And the main complaints of these patients were problems in listening in noisy environments, issues with sound localization, and tinnitus. Next. All of these patients were given a Baha trial for a week. They refused it, which can sound as a loudspeaker, and with adequate counseling and consent, we did a cochlear implant in all of these patients using a standard posterior tympanotomy approach. Next. As I said, we did a round window insertion in all of these cases. We used all the 3 companies. Next. And 1 year post switch on all of these patients, we were very surprised to know that they've been regular cochlear implant users with high compliance. They've described their sound experience of listening as a clear sound, are able to converse in noisy environments, are able to use the telephone with the implanted ear. Next. Most of all of these patients had an issue of tinnitus, and that is why they probably took the choice of getting an implant done. And all of them have actually shown a significant reduction in their tinnitus post CI. Next. So the benefits of using a cochlear implant, there's improvement in sound localization, obviously better hearing performance, suppression of tinnitus, an improved quality of life, and high compliance rate in all of these patients. Next. So the experience world was still really short. The subjective reports of CI users highlights the potential advantage of bilateral simulation in making binaural hearing available. There's a lot of literature available, especially from the European countries and Germany in general, where they've been advocating cochlear implants for single-sided deafness. There are questions that still remain though. Next. And the jury is out on whether you should do something, whether you should really do something. If you are doing something surgically, whether you're doing a cochlear implant or a bone bridge or a Baha, and it's basically up to the patient and the surgeon. Next. But I think the take-home message here really is that when you're seeing these patients with unilateral hearing loss, you need to treat the symptom. You need to see what the complaints are. If the patient is complaining of tinnitus, using a bone-anchored hearing aid is not going to really help you. These are very subjective decisions need to be taken by the patient and the surgeon together, and you need very highly motivated patients to offer these treatment choices. Thank you so much.
So thanks so much, Soumitra, and thanks all the panelists for being so good in telling exactly what is needed. So we will go back to our presentation that we did and ask you some questions which are relevant at this point of time. So I'll be sharing my screen now. This will be my screen. And to all the panelists, Oh, sorry. This is an ANSD screen. Okay. So, intracranial steroid, Shalab, this question is for you. When you give a person, are you able to see my screen?
Yeah.
No.
I'm here, yeah. I can see you and Dr. Shalab.
Now?
Yes, now you can. Now we can see.
Okay. So, Shalab, this question is first to you and then to the others. When a patient gets a prescription for your intrathecal steroid, will you just stop giving intrathecal steroid? Yes or no?
No, not at all.
You continue to give it?
Yeah, if there's a small perforation, then you can either choose to, change the point and let this one heal and you start injecting through a separate point. Or if you only a couple of 1 or 2 more injections left, then through the same point also and they just leave it.
Manish?
Yeah, I think I'll agree with it. In fact, a perforation would really help me. I don't need to puncture again and again. I may use
There are some people who use a grommet to put in the intrathecal steroid. Preetham, have you ever done it? You're muted, Preetham.
Yeah, I'm sorry. I haven't done it, but this is something that people advise for those who want to self-administer it. So they tend to ask the patient to go home. So the compliance seems to be better.
Even microvix work on the same principle.
Yeah,
So.
microvix, yes.
Fine. We do this in MRF at some points, especially for people with minias, advanced minias presenting with acute hearing loss. We put in a grommet, probably some kind of an additional benefit as well, because they need more amount of steroids to be instilled over a long period of time.
Okay. With minias and sudden SNHL, you would use a grommet. That's very interesting. Now, Raghu, this question is also for you. Now, because you teach and train a lot of people across the country, and you understand that there's a lot of changes in the way, because what has been said so far, everybody kind of agrees to what has to be done. You have to diagnose it using certain methods, you have to treat it according to certain protocols, shouldn't give steroids, shouldn't give antivirals and vitamins. What would you think should be done to change the treatment protocol? Do you think the Association of ENT Surgeons, AOI, or IOHNS should do something in this regard? What do you think?
It is definitely the need of the hour. I think we need to blow our horns regarding this hidden entity, and we need to actually highlight that this is a real medical emergency, and that needs to be driven down to the doorsteps of general population and the general practitioners. Because unless they pick up, and also if the patients don't realize, we are tending to get patients who are coming late, isn't it? We are not the first referral points for patients to walk in saying, I've just lost my hearing. So it's always almost delayed, and that's the reason that we are not getting the best of outcomes, because that window period of 72 hours is lapsed. So I think from the Association of the Indian Academy and the AOI as well, we should actually publicize this. We need to advertise. We need to get into the papers, press, media, and highlight this. And possibly in one particular day, we need to convey the information across the fraternity as well to take it up as an absolute emergency, which needs to be addressed at the right point.
I had once made a small post and given it to people, which I don't
saw that. Yeah, that was lovely.
Yeah. So, Monish and Preetham, you being teachers in institutions, are your all students following the same protocol even after they finish? Yes or no?
Yes.
And I hope so, because we do tell them about not to really miss out on any patient who simply complains of an ear block. Sometimes even us, patient says just an ear block and you don't get an audiometry done. You think it may just be a glue ear, which actually turns out to be an SNHL later on. And I'm sure they all know by now the importance of getting an MRI done. So I do think follow it now. So
Regarding MRI, Shalab,
can I say something? Yeah. I think one is that we have to take the American Academy guidelines with a large pinch of salt, for the simple reason that in the US, it is almost impossible for a person who had developed a sudden sensorineural hearing loss to reach an otolaryngologist within the first 72 hours. It is just impossible. The only thing a person can do is go to emergency, wait for 4 to 6 hours, and at best be seen by emergency care physician, who, if they give a reference onwards for a ENT, likely even with an emergency, it's very unlikely they'll get an appointment for the next 2 weeks. So their guidelines are dependent on the system, where in India, a guy can, so many patients would just call me up, get my number and just say, doc, we have this problem. And I'll say, okay, just come over, we'll get the test and we'll start and most probably the patient will be started on the intratympanic steroid the same day. So
Which is very important. In fact, this is the only emergency where they'll get an early appointment in my hospital. I completely agree with you. Soumitra,
I have one more point to make, if you don't mind. Yeah. So regarding this 30 decibel, I always had this. I feel that it's sort of a limit, which sort of limits your as a clinician of when you advise an MRI. So if you look at the other reports of what we were following previously, is that if you have just difference in three frequencies of 15 decibel, considering asymmetric hearing loss, or even 10 decibel in three frequencies, or 15 decibel in bone conduction level in two frequencies, you would go on and advise an MRI. Now, why this is important is if you have a vestibular schwannoma, these patients tend to develop multiple episodes of sudden sensorineural hearing loss. So if you have a lower threshold to get an MRI done and not really wait for 30 decibel loss as there in the guidelines, there's a better chance of you detecting VS.
And MRI with contrast, which is something I think
MRI with contrast.
You brought it up in the presentation so well. It is absolutely important to have an MRI with contrast, which is being missed, and so too the CT scanning for less loss should be condemned.
It's also, I think some physicians have this habit of starting with steroids, and if they see an improvement, then not getting the MRI done, thinking that
that's really not done. Yeah.
Worst thing possible.
We all used to do that in the beginning, but of course we are all changed. Now, to you people, and Shalab, obviously, this question doesn't relate to you. You don't. You always tend to go with intratechnic, which is definitely not a bad thing to do. But one of the things, Shalab, I want to tell you is that we should not be increasing the cost to the patient, which is why what you're doing is so important. To do it as an OP, to admit them, take them to theatre, and put them whole theatre charges is simply not justifiable at this point in time. Is what is my view. Again, there might be people who might think different. Now, to others, Monish, Preetham, Regu, when do you give up? I mean, patient comes to you after a month, has had a hearing loss, has been getting vitamins, antibiotics, whatever, ginkgo biloba and all that, and of course your Patanjali yoga, or whatever. And 1 month. And what do you say that, okay, I'm not going to give you steroids now? Will you do that?
No, for me, the time limit which I have set for myself is around 6 weeks, and I don't go beyond that. And just for the sake of it, I follow what Dr. Shalab does. I would usually start my treatment even the initial treatment on intratympanic steroids.
Yeah, same here. I do exactly the same. And Raghu, how is it in Murph?
I think timeline is one important thing, but we also need to look at the patient. If it's a young patient, there's no comorbidities. There's a better chance that we all know that there are gray years and green years. So I think the cutoff would be 4 to 6 weeks maximum. But I would really try that even if the patient comes in late, because maybe the younger people with no comorbidities have a better chance, especially children. So if it's an old patient with diabetes, comorbidities, presbycusis, now suddenly lost residual hearing, then I won't really be very keen to try this.
Give anything at all.
Yes.
Preetham, would you agree? And
so for me, I'll be a little bit differing here, because as Dr. Monish put that in the slides very well, he said that the improvement obviously is less, but people tend to improve in 3 months. And if you look at also the literature, there have been reports of people improving at even 6 months, but that's very, very less. So I would still keep it at 3 months.
Without treatment, I would feel, no?
Even without treatment. But for me, if they're coming till 3 months, I would tell them it's a bad prognosis, but yet try a treatment. I would definitely try a salvage treatment till 3 months.
You would try intratechnic.
I would agree with Preetham, sir. I would also till 3 months. I would not lose hope. I will try.
I completely agree. Till 3 months, even I give intratechnic steroids, so that's what is given. But at the time, we must all understand that there's a real risk of avascular necrosis, fever, and all this. So older people to start high dose steroids after 1 month, I think, is really not justifiable. I would not do it. So that is something that we need to understand for the beginning. I'm sure all of you would agree with that.
Can I ask here that whether you continue oral steroids after intratympanic when the patient gets discharged after the intratympanic course? Do you continue them on a longer tapering dose of steroids?
I don't. It is either oral steroid and then fails intratympanic. I would go by that. But I'm sure Shalab would have something different to say.
5 days, 5 days of the full dosage, 1 mg per this thing, and intratympanic. And in 5 days' time, if I'm not seeing an improvement at all on the odometry, then I would taper off the steroids within the next 5 days and finish it off. The oral steroids. The intratympanic, I would just continue for at least some more days and give it a better try. That's how I would do it.
So this is the last question for you guys, and we are almost at the end of our 45 minutes for this session. So we'll give you 2 minutes to answer this. One thing each. Brad, prognostic factors. Raghu, just give 1 point.
Diabetes, old age.
So they don't get better?
In our experience, yes. There has always been some comorbidities influencing the recovery rate. Yes.
Vestibular symptoms.
Yeah.
Vertigo.
Completely.
Vertigo and tinnitus.
Vestibular symptoms do very badly. Soumitra?
Time when they come to us. What time do they reach us?
Shalab?
Well, the severity of deafness, if you have a dead ear, no response at all, then the chances of recovery are much less. And if you have a partial deafness, then obviously the chances are better.
Manish?
As if anything is left. I mean, maybe the age of the patient. The more the age, I think the results probably go down.
I think they are very much. This question is so important. So if they are of advanced age, Manish is right. Very profound deafness. There's very little chance for them to improve. Soumitra said. What did you say? I'm sorry, I forgot. Preetham said. Vestibular symptoms again very bad. Raghu said about diabetes.
Yes.
And Soumitra, I missed your point.
Duration.
Duration. Longer duration. That is absolutely right. So now we are going to be dealing with topics for ANSD, 5 minutes each. And Shalab will be soon going about his presentation on how to diagnose. So, Shalab, auditory nerve spectrum disorder, and your presentation is going to be shared now. Over to you.
So when we talk about the auditory the ANSD, the site of lesion can be in the initial inner hair cells in the synaptic junction, and then beyond that would be at the synapse or the spiral ganglion, or then onwards onto the nerve with the myelin sheath, and it could be a physiological problem or a pathological problem, or in fact auditory nerve hypoplasia also, which would cause ANSD. And to diagnose this, we need to look at the clinical features that the patient presents with, and then what are the, if any, if there's any chance. And if there are any, comorbidities or indicators of ill health early in the beginning. So we look at hearing loss, and what's more important than hearing loss is also the speech and language delay and problems with sound localization, tinnitus, and essentially also speech discrimination, wherein you can have these kids who can hear sound, they respond to sound stimuli provided by the parents to check for hearing, because the parents are always checking, but they never go on to develop meaningful speech because they can't understand what they're hearing. The markers at birth are obviously prematurity, very, very low birth weight, which can always lead to a transient ANSD. There may be some, myelin issues right in the beginning, but later on they could improve over the first 2 years of life. Prolonged NICU stay, anoxia, hypoxia during birth, metabolic acidosis, seizures, hyperbilirubinemia, all of these risk factors which would increase the chances of a child or a baby having auditory neuropathy spectrum disorder. Genetic mutations, of course, and then diabetic neuropathy, Guillain-Barré syndrome in the older patients. Next. The test battery should be a psychophysical evaluation along with objective testing. We do behavioral auditory tests, which are basically the speech recognition test, and also very important, the speech discrimination in quiet and noise, because usually in these patients they may have speech have a speech reception threshold but have very poor speech discrimination scores. Supraliminal testing, evaluation of the language skills, the overall development, the global cognitive and motor development in children, which is delayed in quite a few of them, and the psychological profiles for kids also, and then for the adults too. And in terms of the objective testing, we have the BERA, the ECOG, the cochlear microphonics, the otoacoustic emissions, and then the auditory steady state response ASSRs, and the cortical auditory evoked potentials, the CAPs. These are the ones that we have to look for. And next slide. In an audiometry, you may find that there is a fluctuant hearing thresholds, and hearing fatigue is present. And that's why if some of these kids with ANSD or with thin nerves, when you do an implant later on, you find that initially they seem to respond well, but after a little long time of usage, they start developing a little bit of auditory fatigue. Poor speech discrimination abilities, that is hallmark for this disease. Background noise further deteriorates speech discrimination, and the tympanometry and the stapedius reflex cannot really be relied upon unless you take all the tests in totality. Next. The otoacoustic emissions usually should be absent. They are present in the beginning at birth, but usually over a period of time they tend to disappear. So if you have a 3-year-old child or 2-year-old suspected ANSD without an OAE present, that doesn't mean anything because they might have been present at the time of birth. Luckily, most of the patients, at least born in hospitals, have a OAE noted on their discharge summaries. So an intact or present otoacoustic emissions along with a markedly abnormal ABR response is also typically diagnostic of ANSD disorder. And the reason for the no ABR is the altered temporal synchrony of the auditory brainstem pathway. And the auditory nerve and the brainstem discharges are not precisely time locked, and hence that the short duration components are also cancelled in the averaging process. And cases of recovering of ABR synchronization newborns with ANSD has been described. So that must be the myelination, that if the myelination does improve after birth, then some of them may tend to improve. Next, yeah. The cochlear microphonics are seen polarity dependent, occurring before wave 1 of the ABR, and they are preserved in the ANSD, and the absence of the distal waveforms in the ABR tell us that there is a problem in the neural pathway. The transtympanic ECOG cannot really be relied upon in the help with diagnosis of ANSD. ASSRs are present in ASD subjects, and they are produced because the phase locking to the microphonic and the neurophonic responses does take place. And but the cortical auditory evoked potentials are observed in about 1/3, or are abnormal in about 1/3 of these children with ANSD. About 2/3 of them have you can see the CAPs also. So the differential diagnosis for ANSD would be a sharply sloping high frequency hearing loss of cochlear origin, wherein you would expect that again the children will hear the sound, they'll have the speech reception threshold, but they'll have very poor speech discrimination. So you have to be very careful that that is not the case in these kids. Make a distinction between auditory neuropathy from brainstem neuropathy. The brainstem neuropathy would require a neurologist to be involved in the treatment of these patients for whatever reason they have that problem. And then central auditory processing disorders, which the CAPs may help in helping diagnose for us. Thank you.
So Shalabh, that was a very, very clear presentation. Of course, I would agree with some viewers that it's a little bit too technical, but for information of most of you, we must understand that what you do from a primary level is important thing is to find out if the patient has got a very poor speech discrimination score and an absent BERA. Wouldn't you agree, Shalabh?
Yeah. Child seems to be hearing sound, but
not understanding. So this is, and one of the important things that I want to tell the audience is that those markers that Shalabh mentioned, hyperbilirubinemia, so you should be, if you are seeing a child with a deafness, you should be able to write down those markers so that you understand that these things are important to find out whether they have a problem or not. You suspect this earlier. So Soumitra will now talk about how to differentiate between presynaptic and postsynaptic ANSD, and that is the next presentation. This is important because there's a lot of difference between how you treat both these conditions. So over to you, Soumitra.
Yes, so thank you. As fast and as
you can see.
Soumitra, I think your side connection is a bit of a problem.
My side is okay.
Yeah, I think Soumitra's side is not.
Soumitra, you're able to see? He is frozen. Are you able to see, Soumitra?
Can you listen to me, sir? Yeah, can I have the next slide? Yeah. So auditory neuropathy spectrum disorder refers to a range of hearing dysfunction characterized by compromised signal processing on the auditory nerves or by a deficient transmission of this signal to the auditory nerve by the presynaptic inner ear cells. Diagnosis in part based on evidence of altered neural processing such as abnormal ABRs, with a reduced or absent wave-5, despite evidence of preserved outer hair cells, such as normal OAs and cochlear microphonics. And these affected subjects present important speech discrimination difficulties, particularly in background noise, that are out of proportion compared to their pure tone detection threshold. Next slide, sir. Now, the clinical and pathophysiological features of auditory neuropathy are addressed using audiological tests, psychoacoustical tests, and electrophysiological measures. They're distinguished between the sites of abnormal function along the auditory nerve. Now, this is important because the management changes depending on the site where the problem is. Now, these sites could include presynaptic disorders affecting the inner hair cells and the rhythm synapses. It could be postsynaptic disorders affecting the unmyelinated auditory nerve dendrites, the postsynaptic disorders affecting the auditory ganglion cells and their myelinated axons, or central neural pathways affecting the auditory brainstem. Next. Now, the objective measures of cochlear hair cells and auditory nerve function commonly for the hair cells, what we use as autoacoustic emissions, the cochlear microphonics, and inner hair cell summating potentials for the auditory nerve. Next, sir. Auditory nerve brainstem pathways are the compound action potentials, the auditory brainstem reflex, and the acoustic medial muscle reflex. Next. Now, the diagnosis of auditory neuropathy relies on objective neurophysiological measures of cochlear hair cells and auditory nerve functions, imaging of the auditory nerve and the brainstem, and behavioral audiological measures. Typical criteria for auditory neuropathy is a mismatch between preserved preneural activity, which is the cochlear microphonics and the OEs, and absent auditory brainstem potential. These are objective criteria for auditory neuropathy. Next. The genetic as well as environmental factors, there are 13 known genes that cause ANSD. Between 1.2 and 8.4% of those with hearing loss children have ANSD. Most common causes in children include hyperbilirubinemia, thiamine deficiency, and hypoxia. For adults, it's noise-induced and age-related auditory neuropathy. Next. There are a lot of potential genetic causes of ANSD which have been reported, and the distinction between these various lesion sites is essential when studying the genetic causes, since the impact on hearing outcome differs and may also explain the variability in cochlear implantation outcomes, which Monish will address. In a case of a presynaptic or inner hair cell synapse disorder, cochlear implant is going to work much better compared to a postsynaptic lesion, which is involving the supraganglion cells or the more ascendant axons. Next. Now, this slide will tell you that these are the potential areas, presynaptic and postsynaptic terminal synapses, where the lesions might occur, which I'm going to elaborate in the next few slides. Next. So presynaptic synaptopathy, if you look at the genes, there's the AUTOF gene, the CABP2, the SLC178. Now, of particular mention for AUTOF is something that these children have. This is a genetic condition which is stimulated by temperature. So when they're in normal environments, these children hear normal. Whenever the temperatures go up, they develop a severe to profound hearing loss, which is quite interesting. Next. The mechanism of auditory neuropathy at the presynaptic level occur at mainly two sites. It's either the cochlear inner hair cell dysfunction or loss, or at the level of the inner hair cell ribbon synapses. Next. So presynaptic, if you look at the cochlear inner hair cells, if you're looking at patients, these are children who have had hypoxia, and it's known by literature that in hypoxia, the inner hair cells are affected more than the outer hair cells. So we'll have patients who have a normal cochlear microphonic, abnormal summating potential, which indicates an absence of inner hair cells, absent compound action potentials, and abnormal ABRs. Next. If you look at a synaptic disorder, next, as a previous. If you look at patients with inner hair cell ribbon synapses, there is a deficiency of the neurotransmitter relays from the ribbon synapses, which causes deafness. Most common is genetics, like the AUTOF gene. You will have a normal summating potential indicating normal inner hair cell function, but abnormal compound action potential and abnormal ABRs. Next. So postsynaptic synaptopathies, again, there are a lot of genes. There's the OPA1 gene mutation, the ROR1 gene mutation, and etc. I'm not going to reflect on the genetic causes more. Next. The mechanisms at the postsynaptic levels occur at a few sites. It could be the dendritic nerve terminals, the axonal neuropathies, there could be auditory ganglion cell disorders, myelin disorders, hyperplasia of the nerve, or auditory nerve conduction disorders. Next. Now, if there's a pathology which affects the dendritic nerve terminals, it results in a pattern of objective measures very similar to those seen in the inner ribbon synapse disorders. So they'll have a normal inner hair cell function, which will be a normal cochlear microphonic, a normal summating potential, but abnormal compound action potentials and abnormal ABRs. And the most common cause of this would be an OPA1 gene mutation. In adults, it's presbycusis, where there's a reduced size and number of the dendrites. Noise trauma could cause swelling of the dendrites, leading to these kind of audiological values. Next. Axonal neuropathies affect the reduced auditory nerve potentials and reduced absent the compound action potentials in the ABR. Most common causes would be Friedreich's ataxia, which is a hereditary degenerative disorder leading to loss of peripheral and cranial nerve fibers. It could be peripheral neuropathies and the Chiari-Merry-tooth disease type 2. Next. Next, sir. The ganglion cell disorders, and this is very commonly previous. Yeah, the ganglion cells, there are about 25,000 bipolar auditory neural ganglion cells, and their viability is susceptible to a number of adverse metabolic factors, most commonly being hyperbilirubinemia. So children with kernicterus, they'll have normal summating potentials consistent with normal inner hair cell functions. So if you do a OA for a child who's had jaundice at birth, you will find a normal OA, but they'll have absent compound action potentials and absent ABR. So very, very important when you look at the history for these children. If they're past the OA screening, that does not necessarily mean that they are listening. Next up, there could be myelin disorders where the auditory neuropathy may reflect the attenuation of synchronous neural discharges due to demyelination. Most commonly seen is the Charcot-Marie-Tooth disease 1, which shows normal cochlear microphonics and summating potentials, but abnormal waveforms in the ABR and abnormal compound action potentials. Next. We know hypoplasia of the auditory nerve. It could be unilateral or bilateral. Again, you will have normal summating potentials, which will reflect normal inner hair cell function, but absent ABRs and absent compound action potentials. Next. You have conduction disorders in the brainstem, which could be due to acoustic neuromas, meningiomas, or multiple sclerosis. Again, in these cases, you will have normal cochlear microphonics, summating potentials, and also normal compound action potentials, but abnormal ABRs. Next. There's a lot of literature which is available, and there's also this study which says that the N100 values difference in amplitude and latency may suggest the presynaptic or the postsynaptic site of lesion. Next. This is a very great article. Next. And this probably is the best article. This is a lot of references that I have spoken today. I've taken from this article, which completely explains the entire mechanism and helps us try and find the site of lesion for presynaptic and postsynaptic neuropathy. Next. Now, the perspective of talking about all this and finding out all this is that if you have qualitative or quantitative deficits to a spiral ganglion or cochlear nerve, you have a poor outcome with cochlear implants. If you have a genetic lesion that's affecting the synapse, that can be easily bypassed by a CI, and the outcomes are on par with an individual with a genetic lesion affecting the inner hair cell. So it's very important to find out the site of lesion, because your intervention and the prognosis of the intervention is based on that. Next. So individuals thought to have the presynaptic form of auditory neuropathy have consistently shown good cochlear implant outcomes, reflecting the fact that direct electrical stimulation up to the level of the spiral ganglion bypasses the peripheral sensory system. Patients with postsynaptic auditory neuropathy, however, have shown a range of cochlear implant outcomes from very good to very poor, which again depends on the site of the lesion. Next. So to conclude, again, to synopsize again what I said, you need to find out the site of lesion, where it's presynaptic or postsynaptic, put it into perspective. Next. Because if you are looking at any lesion which involves the presynaptic hair cells or the ribbon synapses or the postsynaptic unmanaged dendrites, you are going to have an excellent result with the cochlear implant, because all of these are bypassed by the cochlear implant. However, For a cochlear implant to work optimally, you need a good post-synaptic myelin axon, you need a good cochlear nucleus. So any lesion which is proximal to the cochlear nucleus, you're not going to have a good outcome with a cochlear implant. Thank you so much.
So, Samitra, that was quite an extensive presentation. For people who really do not know intricacies, it may be slightly difficult to understand, but the baseline, what you said is important, that if you have a presynaptic, good outcomes, postsynaptic, poor outcomes, and there are various ways and methods to find it out. And Dr. Preetham now will be talking about how imaging will help you to find out these important questions that Soumitra put across. So over to Preetham and imaging in ANSD.
Okay, thank you, sir. So the next slide, please. Yeah, great. So ANSD was always about diagnosis, but now it's about outcomes. And one of the main factor that can you place it twice more, please? So the main thing that has helped us is the technology and the radiology, which has helped us identify and learn more about it. And in addition to the audiological test, we have radiology, which is extremely important. Next, please. So when we started off, it was always thought of that we should just do a CT of the ear. It's like doing just an NCCT brain. Then people went on and thought, next please, that we would want an MR done, and then let's do a screening CT of the brain. Next please, and next. And then people went on to do the MRI of the brain. So these are the investigations that usually were done randomly and then according to personal preferences. Next, please. So when I looked at the literature, so starting from the initial study, almost the first study that was there in literature, which specifically looked at the imaging characters, that's out there in 2010, and also the recent paper from the PGI Institute from India. So in both these, if you look at the results, it clearly states and clearly points out that the MR was able to identify the defects better than the CT. So it's very clearly evident based on the numbers. And what next, or what other factors that they looked at is, one is the cochlear nerve, which is very clearly known now of whether it's hypoplastic, whether it's present, whether it's absent, but also the other brain factors or the other brain pathologies that they could detect on the MRI, like the prominent temporal horns and Chiari malformations, white matter changes. All these things were detected on the MRI and were corroborated to be present with auditory neuropathy. Next, please. So the CT definitely had a role, one in identifying malformations because it was easy for us. Next, please. And then when you went on when you went on to the older generation of the MRI, where 1.5 Tesla MRs were there, then CT definitely helped us in identifying the internal auditory canal, where if it's hypoplastic, it is dilated, and if it's duplicated. So the most important was the narrow one, less than 2 millimeter, where you knew that the nerve was in a problem. Next, please. And then you would go on, and in these sort of narrow IACs, the MR would not be able to show you the nerve, and you would go on and look at the cochlear aperture or the bony cochlear nerve canal, if it's absent, if it's present, if it is small, to know whether the nerve is present or not. And that's where CT helped us. But next, please. But with the advent of 3 Tesla MRI, the role of CT has further come down, and you are able to delineate the whole nerve very well, even in a narrow internal auditory canal, and you could trace it right from the cochlea to the very proximal auditory radiation. So that's something which is very, very vital. Next, please. So the guidelines also now speak about, especially for neonates. So if a neonate is born, then and you're suspecting an ANSD, or you've made a diagnosis of ANSD, you need to image them immediately. And they have sort of agreed on that 3 months is the age from the point of diagnosis is when you need to go and get the MRI done. And this is sort of been implemented in the guidelines. It is this guideline is basically not telling you that it has to be followed, but it's a very important guideline that the clinician has to consider and try to follow. It's something which is desirable. Next, please. So these are certain common things that you would see, like prominent extraaxial CSF, cerebellar hypoplasia, then hydrocephalus. Next, please. Yeah, and then you could see leukomalacia, which shows a white matter injury. Then you would see posterior fossa, like Dandy Walker variants. You would see hypoplasia of corpus callosum and pons. Next, please. But what is important is based on these things, there was also the newer developments, like a diffusion tensor imaging, which sort of looks at the hydrogen in the tissue, and they found 2 important things. Can you just press it once more, please? Is that when they looked at the brain, the right temporal lobe cortical thickness was smaller in children, and also there was increase in medial diffusivity, which again suggests to you that there was a white matter injury which was there, which was reported as normal on an MRI, which was evaluated by experienced radiologists. So this definitely has a role where this corroborated with the improvement also. So that's something which is very vital, and I want to stress upon. Next, please. So I'm putting forward two reports, which again shows you the importance of MRI. So they have identified a demyelinating disorder, and you can see that there are hyperintensities and hypointense areas on T1 and T2 images, and these are suggestive of a demyelinating disorder. And as they gave treatment, this improved, and so did the hearing improve. So you have one audiological profile which improves, and which is again very much related to the radiology that you have done. The next one, please. So the next slide is also talking about this, where again, neuroborreliosis, they saw that the hyperintensities decreased and the patient also improved. So there was some sort of repair or some sort of modulation in the myelin loss that was there, and then the patient improved. So this is also equally important for us. Next, please. So the take-home message from my side is that MRI of the inner ear and brain with contrast is the investigation of choice as of now. If there is any contraindication to it, then a thin slice CT comes into play. It should be done as soon as the diagnosis is made, be it an adult, be it a child. It is helpful both in diagnosis and follow-up, because even in follow-up, if the patient improves and you're able to correlate it with the audiological improvement, then it always helps. And functional MRI and PET imaging, even though in the nascent stages, they're not into routine practice, but they definitely have a lot of potential, and we might see them coming into routine practice in the time ahead. Thank you.
Thanks so much, Pritham. See, what he said was so important. See, all of us, in fact, in this group, when we see a child, the first test that we do will be an MR. And that is important. So in the very beginning, you'll have to understand which of those patients are not going to be doing well, which of them are going to be doing well. Now, Raghunandanan will be talking about something very, very important. He's going to be talking about what are the advanced techniques. Suppose you find and then you want to know what to do with it. You need to send this patient out for some extra testing, which Raghu will now be talking about.
So as we've been discussing, auditory neuropathy spectrum disorder is in fact an enigma for many clinicians. We are not able to arrive at this diagnosis right away. And in fact, it's much more a nemesis for audiologists, for them to actually interpret the findings and arrive at the diagnosis in such a way that we can actually plan ahead and get a correct plan for managing the hearing loss. We do get small children who have some kind of residual hearing. They are able to manifest hearing perception, but do not develop adequate speech and language. So in fact, they are in the gray zone between candidacy for cochlear implantation, and they don't get a maximal benefit from conventional hearing aid amplification. So these may be the patients who actually would deserve and preempt to receive a cochlear implant even before they actually go really profoundly hearing lost. So that's exactly where we are. So we are really in a gray zone. And the only way forward is to actually have more advanced audiological testing to confirm if ANSD is presently there, how severe it is, what kind of manifestation of ANSD is actually reflecting on the electrophysiological testing that we do. And we can't just rely on one particular test. In fact, it's an audiological test battery that we are looking for. And my presentation will actually show you what are the additional tests, advanced tests that are available today clinically to get a better perception of the neuropathy that we are talking about. So we all know that ANSD itself is an audiological diagnosis. We all know OEs are present, but ABRs are abnormal because this is primarily a problem of desynchrony. So there is no proper relay of signals across the postsynaptic tract. And possibly the activity within the cochlea does not correspond to the activity going up the auditory pathway. And we all know the reason for this is possibly the way that we test, because normally we do a ABR, it is through a click stimulus, which stimulates the entire cochlea. And that particular click stimulus doesn't have time-locked connection to the transmission across the synapse. And this synchronization also is quite doubtful in patients, because obviously we do get very young children less than 1 year. Sometimes it may be by nature that their arborization or the peripheral synaptic pathway connecting to the central auditory centers is not fully arborized. So obviously there is a critical age for arborization. And are we too early in diagnosing ANSD in some of these children? So that's again a question. So we need to look at the synchrony across the entire relay system of the auditory pathway, rather than just saying OE is present and PERA is absent. And that's why actually we have some more tests which have come up in advanced audiology today. Next slide, please. So it's important for us to understand why we need to evaluate the speech perception and speech discrimination of patients with auditory neuropathy, because we all know hearing is different from listening. Obviously, patients with ANST will have good hearing, some of them do, with very normal audiograms, but their speech discrimination and listening quality is very poor. In fact, somehow in audiology, among our clinical practice here, very few audiologists are very keen to perform speech audiometric tests. I think that should be emphasized among the audiologists, and obviously, except for the tertiary referral centers, many of them are not even trained in performing special tests for speech discrimination. So this paper from W.H. Hall, a famous electrophysiologist, who's actually a special audiologist who has written 3 books on auditory physiology, says how different it is for hearing perception versus hearing discrimination. So you can actually see that there is a different quality of hearing thresholds noted on a PTA, but definitely these patients have very poor speech discrimination. Next slide, please. So I am sure Dr. Shalabhat actually highlighted all the different subjective and objective audiological tests that are available. All those subjective are from the perception and the patient's response, which are psychophysical. And objective testing is through psychoelectric responses. These are all electrical signals which are triggering the auditory brain, and responses are synced from there on. So we've all talked about the basic tests, including OEEs, ABRs, ECOG-Gs, cochlear microphonics, etc., including ASSRs. ASSRs have slowly kind of weaned away from clinical practice because apparently in ANST per se, we cannot really identify frequency-specific hearing thresholds because the manifestation of the responses may not be symmetrical in all the frequencies. Also, we do talk about stapedial reflexes to assess the function of the middle ear threshold for response to stapedial reflex contraction. And we actually are using more and more of higher auditory center assessments, which includes the mid-latency responses and the late-latency responses. In fact, Soumitra mentioned about N100, which is actually a mid-latency response. And now we are even going beyond that to look at P300, which is actually a late-latency response, which connects to the limbic system and the auditory cortex. And this is exactly where we are today. We are in a confluence of emergence of audiological and imaging technology. And that's where we have developed newer systems like fMRI, NIRS, and advanced electrophysiological testing to identify how we are able to trigger the auditory brain and see a response on imaging. And today, a newer research is looking into optical stimulation of the cochlea to see how the auditory brain reacts to optical stimulation. And this study is going on in the University of Cambridge with Manohar Bans. Very interesting papers have come out in literature. So what I'll highlight is what practically we do in the clinic today. One interesting new development that we've been trying out in the last couple of years is a preoperative intracochlear ECAP testing. This is very similar to a transtympanic EABR, or in fact, we would put a golf club electrode in the round window and give a signal to trigger electrical response through the cochlea into the auditory system and record the response from the brainstem. And in fact, we, instead of placing the electrode on the round window, are able to insert a small electrode into the cochlea and perform intraoperative electrical testing under GA to confirm whether the postsynaptic ANST is going to be overcome through an electrical signal. If that shows very good responses like what we see here, this is an ART, a neural response showing a positive compound action potential through electrical stimulation, definitely a cochlear implant is going to work 100%. And that's an objective measure which is being more frequently studied in the Western world. And in fact, we are comparing transtympanic EABR with ECAP testing today. Can we move on to the next slide, please? So that's a new advanced audiological measure that we are looking for. And in fact, the other important test is the compound action potential, which we record from the auditory cortex. Can we have the slide, Dr. Manoj? I think we lost our slides.
Yeah, we can only see Raghu now.
So I just want to show you a few more slides wherein we have studied cortical auditory evoked potential. In fact, this is possibly the best test that we have clinically to assess the auditory brain. In fact, it's the window to the brain. It's a simple ECAP potential. It has a P1 positive, negative wave and a positive wave, and it shows robust response from the higher auditory cortex. And previously, this was developed for assessment of the benefit of hearing aids as such. So we actually put an aided signal into the brain, and we can record the output from the cortical auditory brain using the CAP potentials. Now, in children, especially with ANST, this is not only a diagnostic test, but it's also a prognostic indicator. So if we are able to perform a cochlear implant and we are possibly not getting adequate speech and language development post implantation, but the child is able to perceive hearing, then we are in a dilemma. So are we sure that the cochlear implant is working or not? And that is where we actually have the cortical auditory potentials helping us to identify the benefit of implantation, and also it's a good prognosticator of the auditory cortex. Next slide, please. So this is actually from one of our studies in which we have actually had a child who had ANSD pre-implantation. There was no CAEPs that was recorded, and there are three waves: ma, ga, and ta. These are on the low frequency, mid frequency, and high frequencies. And this child underwent a cochlear implantation, and immediately we can actually see within the next 3 months, good amount of P1 wave has come up to show that the synchrony is very good, and the child is receiving perception through the cochlear implant to the auditory brain. Next slide, please. Next slide. Yeah. So, in fact, we published this, and we were fortunate not only to perform the study in cochlear implants, but we have also seen this response to succeed in auditory brainstem implantees. So, the basic synchrony up to the brainstem and beyond is now being able to calibrate through cortical auditory evoked potential. So, the take-home point today is primarily to say ANSD patients will require CAEPs as one of the important diagnostic and prognostic tools for their performance post-implantation. Next slide. Next slide, please. Yeah. So this is in fact a child who had ANSD who received a cochlear implant, and he was having very good auditory perception, but his speech and language skill wasn't appropriate. So in fact, we did a post-operative ECAP. We performed an ESRT. We also performed an EABR. And using this CAP machine, we were able to assess the central auditory cognition and attention. So basically, we were able to correlate his behavioral thresholds with electrophysiology, multimodal electrophysiology, to in fact confirm that the optimal stimulation through the cochlear implant is receiving his auditory brain. And that's one of the important take-home points today. Thank you for your patience. Manoj is muted.
Dr. Manoj, you are muted. We can't hear you.
Maybe I'm sorry. So I lost power in between. So Monish will be talking. So this is more or less comprehensive what we need to do. And Monish now will be talking about cochlear implantation. So we'll probably take 5-6 minutes more. And because all of you have said that, and we don't want to be delaying Jani Gramin anymore. So just 12:06, we have time to 12:15. So Monish, will you quickly go through your presentation on cochlear implants in ANSD?
Thank you so much. For all those who are attending this, it seems too technical. And, the only way to really understand ANSD is to, study it a bit, attend these kind of panel discussions when you have a person like Dr. Deepak Haldipur making this happen, a teacher, in all suited up and with a tie, strict teacher out there like Dr. Manoj, and all the panelists like good school students wearing white shirts. And this is what you want to learn ANSD if you really want to. May I have the next slide, please? Yeah, thank you. Now, cochlear implants, when do you really go about? We all know that, it's not the best of the diseases to be dealt with, but we do have it now, and it's like almost 8 to 10% of patients with hearing loss actually have ANSD. Now, the first thing is obviously go ahead with the hearing aid trial. It is a must. If I see a child without ANSD with profound SNHL, the hearing aid trials for 3 months, 6 months, which we used to have, is no more mandatory, right? We actually would like to implant as early as possible. With ANSD, hearing aid trial is, however, a must, and with much more stringent protocols, good follow-ups, and good audiological assessments, because many of these kids may do really well with hearing aids. But if the hearing aid trial starts failing, you think that there's no significant improvement, don't really keep on waiting. That's important, because you would need a CI in these kids if they're not doing well with hearing aids, and an early CI is what would actually make a difference. However, because it's this hearing aid trial and a good follow-up is very important, the average age of CI, even in pediatric patients, is way higher if they have ANSD all over the world, because the audiological process, the hearing aid trials take a lot more time than what would otherwise happen. Have the next slide, please. How do you do a cochlear implant? It's surgically no different, right? You do a standard posterior tympanotomy, go about, put an implant in, and that's it. There's nothing surgically which makes any difference out there. Next, please. Now, the thing which is important, however, the factors which affect your outcomes. One, remember your children with ANSD would always do better than adults with ANSD. That's a known rule in ANSDs. Now, when Soumitra mentioned about presynaptic and postsynaptic, and he did mention it in his slides, presynaptics do better than postsynaptics. And one of the best ways which I find is, if you were to do an ECOG, the summating potentials, if they are absent, that would mean you're dealing with a presynaptic thing. Postsynaptic summating potentials are present. So if you have an absent summating potential, you should be happier dealing with, and the CI would probably be way better in these patients. The third thing is MRI, which Preetham mentioned, right? The thickness of the cochlear nerves, any lesion in the central auditory pathway actually determine a lot. Your results may actually be affected by this whole thing in MRI. So hearing aid trial must, children, presynaptic, good cochlear nerve, no central auditory pathway is what we are looking for if you're dealing initial cases of ANSD implanting. Next slide, please. I think just to end with this, this big review which came out 2023 itself. Can you click once again, sir? It's a 15-year review on 260 children. That's a big study. Can you click once more, sir? Dr. Manoj? Yeah, thank you. Yeah. Just to conclude, I'm going to read this. This review of ANSD management over a 15-year period reveals that hearing aids are not a viable option to develop speech and language for most infants and children with ANSD. So we need to remember this. Hearing trial is a must, but majority will not, be okay with it. This finding confirms previous reports suggest that while hearing aid trials are warranted, children must be tracked closely so as to avoid delays in decision making. CI constitutes the major, if not the only, rehabilitative intervention that allows for speech perception in patients who do not benefit from conventional amplification. So importantly, this is what you need. Even if you have ANSD, don't worry, because the treatment usually would lie with the CI, and that's what you need to remember. Thank you.
So Manish, that was very quick, and thanks a lot. And we said what absolutely was necessary. So we probably will take about 2 more minutes to ask just a few questions, which will allow Janagram to start on time. I really apologize for the slight delay. A few things that I need to ask, just a few things, and after that we'll hand over to the next team. Now, what do you do to increase the ANSD pickup in your area? For example, Preetham, in your area, it's slightly Bhubaneswar, that side, that part of the country. What would you say?
So, yeah, considering an Indian scenario with the sheer numbers that we have, I think we should include automated ABR in our routine hearing screening of high-risk babies. At least that's the initial step to go forward.
Oh, so message to everybody, automated ABR. Everybody agrees? Does anybody have anything to say? No.
Just remember those risk factors which Peter mentioned. High-risk babies especially go for automated.
Yes, high-risk babies do imaging.
Jaundice babies, because they always will be present, but they still need to do screening ABR.
Yeah.
Speech discrimination, I think we handled a lot of it in our questions, so we will skip that. So this 18-year-old boy with a 40% discrimination is coming to you. What of these two options would you think are most important? You can start with Manish.
For me, learning the cued speech is a good option, right? Since many men, he may not even understand everything by speech reading, and understanding speech sounds will be helped by cued speech.
However, yeah, please, yeah.
Start considering CI, right? 40% is a bad score to have even now. Don't meeting, and I would start considering CI very soon.
Soumitra?
So I would consider CI. It would improve the signal noise ratio a lot. I would consider CI.
Shalab?
You mean after the investigations, right? After all the
everything. So examination, university, everything confirms CI, ANSD.
I'm assuming the aided responses will also show the same poor speech discrimination, and if they do, then definitely an implant.
So, if you have, is this because are we diagnosing more cases of ANSD because increased awareness, Or do you think, what do you think is the future of intervention in this condition? Quickly, because we just have 1 more minute to go.
I think it's just increased awareness.
Increase awareness.
Just awareness.
Yeah.
More people know about it, right? Nowadays. Earlier, we used to implant the children and get better. Raghu, that's what
Yeah,
you
I think we are having more diagnostic investigations today. So I think we are diagnosing more. It has been there ever since, but we are picking it up more.
Have
And
a
we're
doubt. All
intervening.
the centers that don't have investigation should send it to centers like what Raghu mentioned.
Referrals, yes, correct.
So the delay should be avoided, like Monish is doing.
The awareness towards cochlear implantation should come in.
So, which of these is the most controversial statement? Soumitra.
The last one, sir. If you pick them early, if you identify them early, if you do the proper treatment, you will get a good outcome. Obviously, started.
Yeah, that's the last one. Yeah.
Brainstem implants, Raghu?
It's controversial, gray zone. Yes, we have done a few patients with ANSD, but outcomes, it's too early. We can't really comment on that. It's an option.
So for me, in the first one, which is progressive, is something that I would not agree upon, because we know that many of them are also hyperbilirubinemia and many other things are non-progressive. And they might actually improve.
With you being the moderator, all these four are controversial. You can which one is more controversial.
I think we are now at 12:15. I must thank you a lot, because both these conditions, idiopathic sensory nerve loss and ANSD, are very controversial. Most people do not know what to do. You have all put up very succinctly and clearly. There has been not much of controversy. You put in the proper guidelines and backed up your presentation by certain papers. I thank you all. We could not have had a better panel than this ever. You did all the hard work. I just had to tell you, kind of coordinate with you guys. Thank you so much. And thank you, the webinar team, Micro, and everybody here for helping us do it. Thanks.
Thank you.
Thank you.
Echo message is that only 5% of the kids get help with hearing aids. So 95% are basically CI candidates. So always to keep in mind.
Yeah. So Trustwell Hospitals, Dr. Krishna Kumar. I'm sorry if you also a little bit of your...
Sir, it was pleasure hearing. We have more than 780 doctors logged in, and everyone, we're getting lots of appreciation messages and they're doing beautiful clinical pearls, things made easy. These are the comments which I'm getting it, sir. Thank you, sir. Thank you for moderating, and thank you, Manish, sir. Thank you, Preetham, sir. Thank you, Salab, sir. Everyone, thank you for wonderful session there. We'll get back to you, sir, for many more such events. Thank you, sir. Thank you very much. And I think we'll move to...
Manish.
Yes.
Preetham, Raghu, thanks so much.
Thank you all.
It's always a pleasure.
Panel with all of you. Thank you.
Thank you, Manoj sir, from Trustwell Hospitals and the Microlabs team for conducting such an excellent session on SNHL and auditory neuropathy. We are really enlightened by the amount of information that was shared in the last 1.5 hours. Probably that much we have not even learned over our post-graduation. Thank you. Thank you.
And thanks once again to Deepak, who wanted me to do this. And apologies to Janaki Raman, my friend, who I'm intruding on for the last 15 minutes. So, Janaki, over to you. Thank you, guys.
Thank you, sir. Thank you for the presentation. Yeah, that was
Good afternoon.
Yeah, to all the audience there, we just now finished with the sudden SNHL and auditory spectrum from the panel of doctors, starting from Dr. Manoj sir, Dr. Salab sir, Dr. Soumitra, Dr. Manish, Dr. Preetham, and Dr. Raghunandan sir. Thank you very much. And we'll move on to the next the live surgery workshop from none other than Dr. Janaki Raman sir, which will be doing a couple of surgeries today. One is a revision endoscopic Sternberg CSF leak. Other is a revision juvenile nasal angiofibroma. To moderate this session, we have our esteemed faculty, Dr. Madhuri Mehta madam, Dr. Lakshmi Satish madam, and Dr. Omkar Deshmukh sir. Thank you and welcome all of you for this next session. As all of you know, Dr. Janaki Raman sir requests no introduction, but as a formality, I'll just take you through. Dr. Janaki Raman sir is the Managing Director and the Chief Consultant at Royal Pearl Hospital, Trichy, Tamil Nadu. He has been recognized for surgical cells in otology and surgery. He is an international pioneer in endoscopic management of extensive sinonasal and skull-based tumors. Acknowledged for commitment in otology by Tamil Nadu government. He has numerous awards, multiple papers across various national index journals. Also, he has contributed multiple chapters to many books. Also, author of the first exclusive international book on male predominant complex vascular tumor in Indian population, the juvenile nasopharyngeal and angiofibroma. To moderate this session today, we have Dr. Madhuri Mehta, Madam. She is the Director and Head of Department and also Medical Superintendent of NC Jindal Institute of Medical Sciences, ISAR. She has successfully performed over 45,000 major ENT surgeries, including all basic and high-end surgeries in ear, nose, larynx, lateral and anterior skull base, and head and neck surgeries. Specific areas of interest, otology, including facial nerve and cochlear implant. She has been an invited faculty across various national and international forums. Other next speaker, prolific moderator is Dr. Lakshmi Satish, Madam. She's been the director and consultant at the Skin Cosmetic and ENT Care Center, Bengaluru. She has numerous papers to her credit. She has been an ardent speaker at various national and international forums, and she has several merits and awards to her kitty. Also, we have our own Dr. Onkar Deshmukh, sir. He's been the director, Asian Center for ENT, and also the consultant ENT and skull-based surgeon in the. He's having his fellowship in ventral skull-based surgery at Royal Pearl Hospital from Tiruchi. Assistant professor of ENT at SKN Medical College, Pune. He has been also the editor across multiple books, including the famous publication of Time Publications. He has contributed to many chapters and has been the speaker and also chair at various forums. Thank you, and over to Dr. Janaki Raman, sir. Sir, people are waiting for you. Welcome, sir. Thank you very much.
Okay, a very, very good morning. Before I start, I just want the moderators to talk a few words, and then I will start my program, because after this, it's all cases from our center. So I request Dr. Madhuri Mehta, Madam, Dr. Lakshmi, and my own sweet dear Omkar Deshmukh to start off, and then I will talk. Dr. Madhuri Mehta, Madam.
Good afternoon, Dr. Janaki. How are you? How are you?
Good,
so
very good.
It's my pleasure to be watching you perform such great surgery, and we will keep you disturbing in between by asking questions, and I think I'm going to enjoy this whole session. Thank you very much.
Dr. Lakshmi?
Madam, you're muted. Lakshmi, ma'am. Madam, please unmute.
Good afternoon, everybody. Welcome you all for the wonderful surgical session by the eminent Professor Janaki Raman. We're all eagerly waiting to watch your wonderful surgeries. And I think you just returned today from Dubai. You must have had a very hectic day. So we're all keenly waiting to watch your great surgeries. Welcome over to you, sir. Thank you.
Okay.
Good afternoon, sir. I hope I'm audible.
Yeah, very much.
I would like to thank everybody for inviting me here. Most of the times I'm on the other side, generally with sir, operating in the OT, so feels like home away from home. But it's a great pleasure to see you, sir, in your full valor and vigor. We are really eagerly waiting for your surgeries. All the time, as always.
Okay, so here we are. First of all, let me thank a few people before I start. I want to thank personally from my heart Dr. Deepak Haldipur, sir. I call him the K. Balachandar of ENT. I don't know if he's there in the panel. I'm sure he will be there soon, maybe. And he has been with me as a pillar of support for now many years. A very, very nice person, a humble and affable person. I want to thank my friends and maybe my brothers. Dr. Satyaprakash Dubey. Recently, I had been to Bhopal, and it was a brilliant experience. I'm really now feeling the warmth of Dr. Dubey, sir. Of course, Dr. Sanjay Agarwal, sir, special mention to him because, in fact, I went for his son's inauguration, and now I'm getting a very good news that his children are getting married, and I will be there for the marriage as well. I'm congratulating him for that. And of course, I have many friends I have to mention. I want to thank Microlabs for this wonderful opportunity. Okay, without much ado, I will just come to the point straight. We are going to do through 3 cases today. Number 1 is a very interesting case of a 3rd revision Stenberg canal leak, CSF leak. The second is revision JNA. And third, I have started an international group of doctors, and they have requested me to show one septal correction with turbinate. How do I deal with turbinates? And so for them, I posted the 3rd case. So I think I'll be doing it as quickly as possible, at the same time explaining to you about various aspects of this program. So let me start with the first case, that is the Stenberg canal leak. I want to give a little theory about it, and then we will start reading this one. Stenberg canal. So you know that Maximilian Stenberg in 1888 described this particular entity, and he described it because this is the area of the skull base which is the thinnest part of the skull base is the Stenberg canal, and this is nothing but a craniopharyngeal canal remnant, duct remnant. And so when he described it classically as suture line which is lateral to the V2. So we have what is called the lateral recess, which is lateral to the VDN and V2, and lateral to it is the lateral recess. So we have the lateral recess, and if you have a defect which is lateral to the V2, he described that as the Stenberg canal leak. But if a defect is medial to the V2, it is called lateral sphenoidal leak. So that's a lot of difference between both. One is called Stenberg canal leak, second is called lateral sphenoidal leak. Now, Stenberg canal leak, now they say is a misnomer. There's nothing like that, because if you can see, it is a myth. They say it is because of arachnoid protrusions into the sphenoid lateral recess. Well, something about CSF leak. So if you have a patient coming to you with unilateral nasal discharge on bending forward, we had a fantastic panel yesterday by Dr. Shamu Malipatil, and we had very good panelists also who described it. And I just want to say that you have what is called the teapot sign, means you turn and then you bend, it will come like a teapot. So this is the typical the position in which the CSF drops. So we all should know about CSF. Per day, it is around 500 ml production. Circulation is 150 ml, and it contains glucose. If it comes out of the nose, you first test it for glucose, which is more than 1/3 of the blood glucose. That is more than 40 or 50 you will have. Then you should say it is CSF. Now, I also want to say that there's one condition called benign intracranial hypertension, otherwise called BIH. And for this, we have certain criteria. So what is the investigation we do for any case of CSF leak? We always do an MRI. We always do an MRV. So we will always do these two. Why? Because in BIH, what will happen is you might have a stenosis or a clot or a thrombus in the lateral sinus. So I have seen now 4 cases already who have thrombus, and that produces the BIH. So always do a MRV for a patient who has a benign intracranial hypertension. That is point number 1. Number 2, you have what is called the Dandy's criteria. Dandy in 1937, he actually published the criteria, and of course it was modified in 1985, and that's called the modified Dandy's criteria. So in modified that, first of all, when the patient comes, when you're suspecting BIH, ask the patient 2 important things. Do you have pulsatile tinnitus? Pulsatile tinnitus, there are only 3 DDs. Number 1, glomus jugulare. Number 2, atherosclerotic carotid artery. Number 3, benign intracranial hypertension. So if you find there is nothing there in the ear, you put the scope in the ear, patient complains of pulsatile tinnitus, think of BIH. So that is one. Second is blurring of vision. Ask the patient for blurring of vision. If the patient has got papilledema, ask for a fundoscopic examination. If you are good, we do nowadays we do the fundoscopic examination to look for papilledema. And if you have that, then there is a suspicion of BIH. Number 3, constant headache, severe headache. And you have to take an MRI. In the MRI, the first thing you have to see is empty sella. So you look for empty sella. Number 2 is you look for flattening of the globe. Posterior globe will be flattened. Number 3, perioptic cup widening. The fluid will be widened. There will be tortuosity of the optic nerve.
Tortuosity, yes.
And then you will have slit-like ventricles. The ventricles will be slit-like, but there will be dilatation of the Meckel's cave. So these are all the things you have to look for. And then you always look for stenosis in the lateral sinus. This is very, 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 very important. If there is a thrombus there, you can have intracranial hypertension, but that doesn't correspond to a BIH. Because one thing, you might have a patient, I had a patient who presented just with 6 nerve palsy. Just with 6 nerve palsy. Please understand, the patient can present just with facial palsy. Facial palsy, unknown origin, you can have BIH. See that. We have had patients who present with 6 nerve palsy, who have 7th nerve palsy, just isolated. And when you take a MRI, the patient has got a BIH. I just wanted to inform this. So modified Dante's criteria, you should always look for in MRI. I do a combination of a CT cystinogram or a MR cystono, gadolinium enhanced, and an MR. MR is always there. So now Dr. Vishal Nair from Sholapur is going to present this case. And after that, I'm going to read the scan and we will be starting the surgery soon. Any doubts, any questions, you can ask me. Dr. Vishal, over to you.
Thank you.
You can ask me. Dr. Vishal, over to you.
Janki. Janki.
Dr. Vishal, over to you.
The sir is watching, sir.
Janki. Janki.
The sir is washing up right now, sir.
Hello? Hello?
Yes, sir, you're audible.
Yeah, you wanted me here? I was washing up.
Yes, sir, carry on, carry on.
Yeah, Vishal, carry on.
Yes, sir. Good afternoon to all the delegates. Today, Dr. Vishal Nair, fellow at Royal Pearl Group of Hospitals, will be presenting the first case, which is a very interesting case of recurrent spontaneous left lateral wall sphenoid sinus CSF leak. So just to
Hello? Hello?
Yeah.
Can the voice be increased? Voice is not audible.
Vishal, your voice is not as audible. Please, can you talk a little louder? Maybe.
Yeah, I'll do that.
Keep it near.
Yeah. So I'll just give a brief history.
Is it audible now?
Is it audible?
Yes, yes, yes.
Yes, yes.
Yeah. So a 43-year-old female who is a known case of left lateral wall of sphenoid CSF leak presented with left-sided watery nasal discharge for the past 20 days. The patient was operated outside by a left frontotemporal craniotomy with a pericranial flap repair under GA on 12th of August 2022. The patient redeveloped a leak from the left nostril after 10 months. The patient underwent a re-exploration via a frontoparietal craniotomy with a temporal muscle graft and a lumbar drain on 26th of June 2023. Post-surgery, the patient developed left lateral rectus palsy. There is no history of headache, tinnitus, visual blurring, or trauma. There are no comorbidities. So here we can see the picture of the patient where you can see ocular misalignment. Now coming on to the examination, the patient is conscious oriented and showed a scar over the left temporoparietal area. She is afebrile. Left lateral palsy is present. Rest all neurological examination is within normal limits. Endoscopic nasal examination showed left-sided active CSF leak. Rest was within normal limits. On examination of oral cavity, there was trismus with mouth opening of only 2 finger breadths. Ear examination was within normal limits. For investigation, we sent the CSF, the nasal CSF leak for fluid analysis, which showed a sugar of 66 milligrams. That is more than 45 to 50, which proved that it is CSF. On ophthalmological examination, there was a left disc mild temporal pallor and sixth nerve palsy. Rest was within normal limit. She also underwent an MRI and a CT-PNS cysternography. I would like to call upon Sir to present the findings of the CT as well as the MRI. Over to you, sir.
Okay, so I hope you listen to the history. Hello?
Yes, sir.
Hello.
Yeah,
Yes.
there's a lady who has undergone 2 times craniotomy for a lateral sphenoidal leak, 2 times craniotomy. And the patient has already developed a sixth nerve palsy and a mild temporal pallor with V2 palsy also. So she has actually deteriorated, and because the patient had a temporal pallor, we also did a neurosurgical examination, and we also did the pressure analysis. Usually the CSF pressure is less than 20 centimeters of water, otherwise 60 to 180 millimeters of mercury, and it was less than 20, so the patient does not have. Sometimes it can be a little dubious because it's leaking, you cannot find the real pressure. But our surgeon, seeing the MRI, gave a clearance of BIH, so we will not be needing to do a thecoperitoneal shunt, or there's no diversion which is required. This is the brief history. Has got a sixth nerve palsy, fifth nerve, and then that is because, and also a lot of brain gliosis is there because they have gone transcranially through a TEOL craniotomy. So you have any doubts regarding this, you can ask me.
Sir, the CSF leak, especially from the Sternberg canal.
I can't hear you. Can you please talk louder?
Okay, sir. I will just increase the volume. Why is it more common in females, sir? The Sternberg canal leaks. It is said in the literature that female 40 fertile are more susceptible for these kind of leaks. Is there any particular reason why it is more common in the females?
Okay, now let us understand that the bones in the females are controlled by estrogens. You know that osteoporosis is very common. So basically, these defects are more common in females because of the hormonal, preponderance in females. And when it becomes, 40, 45, perimenopausal age, that is the age when the hormones reduce, the estrogen reduces, and the progesterone rises. And that is exactly the perimenopausal age when the women develop this kind of leak. This is also a 45-year-old female and a perimenopausal, and that is why it is common in females.
Is she obese also? He didn't mention
about yeah. She's obese also. So fat female, 40, 45, 3Fs we always call. Very common to find CSF leak.
Okay, thank you.
Anything else?
Hello?
And very important statement I want to make. There is no role for transcranial repair in Sternberg canal leak.
Yes, that is the question what I was going to ask Janki, that it has been taken up by a neurosurgeon, which is, I think, these leaks are to be done through intranasal approach. So what is your take on that?
Yeah. So basically, there is a little bias, surgeon bias. You see, it has been operated in the mecca of neurosurgery. It's not a small center, it's the mecca. I don't want to mention the name, but what I mean to say is there is always a surgeon bias, and the surgeon knows a technique. They want to force that technique on the patient. I think the disease should ask for the technique. That the surgeon should not give the technique. The disease only, for example, if there's a tumor in the petroclival region, the disease should say you do it translab or whatever approach, and the surgeon, just because he knows only that technique, cannot say I will do this approach. I think the main thing today is the MDT, the multidisciplinary team should work. So if there is a CSF leak, the neurosurgeon should sit with the ENT surgeon. He should be open-minded, and this is the way to go, the multidisciplinary team.
Perfectly said. Perfectly said. Okay. Thank you.
Okay, I'm going to start reading the scans now. The first is the contrast. Can you focus on this, please? So let us start reading the scan. This is the septum here, and you can see here, this is the frontal sinus. We always look for the frontal sinus. Why? In case of CSF leak, we look for the frontal sinus. Why? Because if we want a pericranial flap, we have to look for the frontal sinus. We have to do a draft 3. So I always look, but of course, in this case, you don't need it because they have not, luckily, I just have the Hadad flap. So I always look for the frontal sinus. And then there's a septum in the midline. I always look whether the septum is deviated. Can you put all of your phones in the silent mode? Okay, now that's the turbinate, the maxilla. I look for the maxilla, the pneumatization of the maxilla in a case of a clivus, because I have to park the Hadad flap in the maxilla. So the parking of the flap. For that, we look for the maxilla. Then, okay, we are looking at the cribriform plate, which is normal. You can see here the sphenoid sinus. Always remember that in a CT scan, HRCT, you'll find at the region of the leak. Sometimes, mostly, you will find that is because of the reaction, and that will give you a little clue whether you have a leak at that site. So always look for that in the MRI and the CT. In this case, you can find clearly the there's definite fluid inside in the sphenoid sinus, and you can clearly see the defect here. This is a defect. Can you all appreciate the defect here very clearly? You can see this defect.
Can you please zoom those images, sir?
Yes.
See the defect here? Very, very beautifully seen, and there's a lot of gliosis here. That's because that's the path. You can see here also the craniotomy. Can you see the craniotomy here, please?
Yes, sir, we can.
And they have gone here like a subtemporal approach and gone here, but they have failed to, and they, I think, have pressed the superior orbital fissure. That's why the 6th nerve is gone. And the 5th nerve also is gone, because they have tried to push it, and then that is the reason. Now, we will go on to the MRI. MRI, what should you look for? In the MRI, you should always look for empty sella. Where is the axial cuts? Always look for the axial cuts for flattening of the globe. The first thing you should look for is, of course, we don't have the T2 here. I have that on the DICOM, but anyway, you can see the flattening on it's not that there's no tortuosity of the optic nerve, there's no empty sella. So it's a clear-cut case of a Steinberg canal leak. Now, I always request the juniors, I always say, surgery is brain surgery. It's not hand surgery. Hand is just execution tools. You should plan the surgery before you operate. This is very, very important. Whether it's mastoid, whether it is anything, I always ask my residents to write down the steps before they operate. This is the training I have given. Omkar knows about it, I'm sure. And you can see the steps which I have already written here. Now zoom in to the steps. So I'll just follow the steps beforehand. Put the lights on if you want. Put the lights on, white lights on. This is the left Steinberg canal leak revision, third revision, the steps. The first would be right lateralization of the inferior turbinate and the middle turbinate. You will see, I'll just follow the steps. Number 2, the opening of the sphenoid sinus wide on the right side, not left side. Then I'll do a right Hadad flap. Of course, I can use fat fascia also, but this is a third revision, so I don't want to take any chances. I'm going to take a nasal septal flap. Now I will do a left modified Denker's because it's lateral and there's a lot of gliosis. I don't want to play around with the brain. So I will take a castidose flap with a septectomy. So castidose is a reverse Hadad flap. And then I will do a drilling of the posterior wall of the maxillary sinus and ligate the SPA DPA, and I'll push it. I'll expose the pterygoid wedge and start drilling the pterygoid wedge. Before that, I will do an anterior posterior ethmoidectomy with sphenoidotomy. I'll do a trans-pterygoid approach, and then I'll expose this leak site very beautifully, and then I will delineate it, and I will close it with fat fascia, of course, with the flap and tissue glue. That's it. So I have clearly written down my 10 steps, and I'm just going to follow these 10. My hand is just going to follow the 10 steps, and that's all I'm going to do. So any doubts, any questions?
The point to be noted is the flap to be used is on the right Hadad, because the trans-pterygoid approach will might compromise the flap on that side.
Absolutely. Very, very good point. Very good point. I have to use the other side Hadad, not the same side Hadad. Are you getting the endoscopic picture, please?
Yes, sir.
Indeed.
Are you getting the endoscopic picture, Dr. Madhuri, madam?
Yes, sir, we are getting, sir.
Okay, now the first step, as I wrote in my planning, is I'm lateralizing the inferior turbinate. You see, I use my belly of the instrument to lateralize, and I have to suck the nasopharynx. The CSF has collected very well. She's actually dribbling CSF. The second step, so I'm being helped by Dr. Satya and Dr. Shiva. Dr. Shiva is a very, very brilliant student. I've been training him, and you can see that's the middle turbinate. So I'm just going to lateralize the middle turbinate. Beautifully seen superior turbinate. Can you all appreciate the superior turbinate, please?
Yes,
Yeah.
indeed,
Yes, sir. Yes, sir. It's just coming into view.
Now, once I get the superior turbinate, you see the sphenodos. Can you see the sphenodos, all of you?
Yes, sir.
Yeah, I'm just going to push the superior turbinate also. Here, I don't need a cavity and a half. It's not required. So what I will do now is I'm just going to lateralize this to visualize the Hadad flap. Now, what I will do is, you see here, that's the sphenodos. Step number 2, which I wrote, that is the sphenodos. Can you all appreciate it, please? Yeah, now what I will do is I'll take my Blakeslee forceps gently inside, and I open the sphenodos like this. You can see here how nicely can you all appreciate the sphenodos, please? Sphenoid, which is
Yes, sir.
widened.
indeed.
Now, the next step is to widen the sphenoid very, very nicely. I am having Dr. Bala Murugan, who is the anesthetist. You know Dr. Bala, he is now as well known as me because of his fantastic anesthetic techniques. I'm feeling so comfortable when I operate here. Of course, this time when I went to, Dubai, again, there was a lady anesthetist who gave fantastic anesthesia. So I am blessed to work with anesthetists like that. So that's a little bit of the posterior ethmoids. So you can see that the sphenoid has been opened widely. Can you see that, please, all of you?
Yes, sir.
Yes, sir. We're doing a posterior ethmoidectomy and
Little bit, not much. No.
yeah.
Now give me the infiltration. Now I am going in for the nasoseptal flap. So for that, you see here, what I will do is, this is just saline. Please understand, we never infiltrate xylocaine with adrenaline. Why? Because it's a very vascular area, and you never know, it's full of blood vessels, the septum, and you never know whether it's being absorbed, how much is being absorbed. We have had casualties with, xylocaine with adrenaline. We have seen, we have heard. So we generally don't want to create any problems with respect to infiltration inside the nose. The ear is different. Vascularity is less, but the nose is extraordinarily vascular. And so I don't infiltrate xylocaine with adrenaline. And in fact, it will raise the pulse rate. Now the pulse rate is around 80. Now the next step is to make the incision on the septum. You can see here, I'm making that incision on the septum very, very nicely. And we will do what is called the three-handed technique. See how Shiva is bringing his, now Satya will go behind me. Everything is protocolized here in Royal Pearl. Now I have my own elevator. This is made by me. And you can see here that I'm going to use this elevator. So the first movement is a backward movement, not like this, not the upward movement, but the backward movement. Okay, so that is the first movement. The second movement is the up-down movement. You can see here, that's the up-down movement. And within a matter of a minute, we'll be able to rise. See how we're doing the three-handed technique. Satya is actually bringing the suction. And you know what Shiva is doing? Shiva is irrigating. So that's it. So we have almost done. No, don't.
But many places we have seen cauteries and cobbleters being used to take Hadad flaps. But at Royal Pearl, generally it's a cold knife dissection. And most, pertinent explanation is the take-up of Hadad is much easier when it is dissected with cold knife. Cold
Absolutely.
steel.
Fully agree with you. Because the edges of the flap will not be disturbed at all. That's a nice, very nice point made by Omkar. We always use the cold steel instruments. Of course, some people use. In fact, Gustav Hadad himself uses the unipolar only. If you have seen till now, I have not brought my scope outside at all. Everything is because of three people working in synchrony. I think that's very important. Teamwork. Again and again, I always insist. The teamwork is the most important thing in skull-based surgery. And if you have that teamwork, believe me, it is like, it's like cakewalk. Now, here we are. I have now done my, see, that's the floor here.
A small square there.
Can you see the floor, please?
Yes, sir. Indeed.
Okay. Now, this is the first time I'm using Savlon. Now
what's the blood pressure and the pulse rate, sir, at this moment?
What? Blood pressure?
And pulse rate. And the heart rate.
The heart rate is 80. The blood pressure is 120, 70.
Would you want it to come down during the next course of the disease?
If I really want it, I'll ask him.
Okay.
So, at the moment, I'm not finding anything difficult. So, I will not ask him right now. But when he himself will assess. This is bleeding, so he will. So, it's like a sort of, a marriage. So, the wife knows when the husband will get angry. Very good. So, he is the husband, I am the wife. Take it out. Take it. See how many people do from reverse. They come from behind. There are many ways to bell a cat. I do it from anterior to posterior because I'm so used to the septum, septal correction technique. See how nicely we're able to do that. Give me a knife now. See how wonderfully. The most important thing is the breadth of the flap. This 1 millimeter extra. See that 1 millimeter extra. Shilpi always says that. Get that 1 millimeter extra. I love her statement and I follow that. I learned it from her, in fact. See, I don't mind learning from my own fellows. So here, that 1 or 2 millimeter extra, which actually gave me, will actually help me in increasing the, width of the flap. I'm using a little bit of the floor. Now, give me elevator. Now you see, I'm going in for 400. See that? These are all things which have again, I say, I protocolized it. So here we are. Whenever I elevate the floor, you can see here what happened. Now I have given the scope to Satya, who is holding it. So these are all the techniques which help you in making your life very simple. See, the floor elevation is not easy. In a nasal flap, believe me, when you have elevated, you will know that the floor is a difficult part to elevate. And for that, see how the conversion of that two-handed into the four-handed. See how he has gone into the tunnel. And he's showing me that beautifully. Thanks, Satya. You're doing a great job. Give me a scissors. Now what I will do, see how much extra I have got now.
The paddle is wider. Yeah.
Now that is very important because you never know. The leak site might be very broad, right?
Yeah.
So for that, I will include at least 50% of the floor of the
nasal cavity on the.
That's all. Beautiful. Now you can see how it took a few minutes, but then work the strain. And now I have got the wider. It's actually a little extended nasoseptal flap. Can you all appreciate it, please?
Yes.
Any questions which are coming? I am ready to take it. Scissors. Dr. Madhuri Madam, Dr. Omkar, any questions which are coming online, please feel free to ask it.
Yes.
Dr. Janaki, can you please ask the external camera fellow to see the arrangement of the three surgeons, the three hands?
Yeah. External camera, please. External camera.
Once
now,
they can just show.
Yeah. I'll be showing that when I do the four-handed.
Okay.
Now,
sir.
you have to rise it till the, see that? Can you see here? What is this? This is the pharyngeal nerve. This is the palatovaginal canal. This is the palatovaginal canal. You have to rise this till the level of the palatovaginal canal, my dear friends. Very, very important. Okay, that's beautiful. I have not made this final cut here. Anyway, I'll do that later. Now, this is the right side. Now, give me a pack. Then, finished. So, I have completed 3 steps which I wrote in my paper. 3 steps done. I finished this side. I'm going to pack this side. Dr. Madhuri Madam, feel free to add comments. You are such a wonderful surgeon. I've seen you. Dr. Amit keeps talking about you. This time also we were talking about you in Dubai. Okay, give me a scissors now. Now I'm going in for the endoscopic modified Denker's technique. So what do I do now? Before that, what I will do, I'll do a little modification of the written statement there. What I will do, I had done this last, but now I'm going to do it slightly earlier. I'm preponing that step because it becomes easy when I have the inferior turbinate. Give me a debrider now. So what am I doing now? I'm now going in for, no, just give me a debrider. Now I'm going in for anterior posterior ethmorectomy slightly earlier. I'm just preponing that. I don't want to remove the uncinate. That's in the sense, anyway, I'm going to do that when I do the medial maxillectomy. Any doubts? Dr. Madhuri Madam is there or not? She's left. Everybody is so silent. Okay.
Yes, sir.
No questions, is it? Dr. Lakshmi?
Yes, sir.
Any questions, please put it forward.
Okay, sir. Sure.
If you make it very interactive, it will be good.
Okay, sir.
Sir, can I interrupt?
Of course.
Yes, sir. In case if we don't have a Hadad or like we were lucky to have a Hadad in this case because it was operated by a neurosurgeon 2 times a year. So what are the other options that you would consider intranasal or otherwise?
Wonderful question, Dr. Omkar. So the other options are, number one, I will think of a lateral nasal wall flap. So I will think of a lateral nasal wall. If it is going to be the third revision, if it's going to be a primary case, then I would think about the fat fascia. But if it is going to be a revision case, I will always try to use a pedicle flap.
Pedicle flap, yes.
So the lateral nasal wall flap, usually nobody touches the lateral nasal. That's the meningocele already. You can see that very clearly there. You can see the CSF also coming out.
Yes, sir. You can appreciate.
Okay. Now see pack. So the lateral nasal wall flap. Well, you might ask me another question. In case there is no lateral nasal wall flap, which is very, very rare, what will you do? Debrider. Debrider is not working, my dear. Quick. In case you don't have the lateral nasal wall flap, then the next option for me would be a fat fascia, a free flap fascia, but I will do a multi-layer fascia. I will use inlay, onlay, interlay fascia. So I'll make sure, see, fascia acts by producing severe fibrosis. So yes. I would then go in for a, put it on a drill mode, forward mode, please. That's a posterior ethmoplatery. Can you see here?
About that inferior turbinate, because
Dr. Janki?
inferior turbinate itself can be used as a flap. I mean, in situations where Hadad flap is not available or otherwise.
Yeah, agreed.
Yeah.
See, I'm using this in forward mode, huh?
Yes, so that you might chip out the bone conveniently.
Okay, right.
Can you please tell the landmark, sir?
Now, you can see here, I have done an anterior posterior ethmoidectomy, and you can see here that the skull base, give me the ball probe. Ball probe is there. I'll show them. So I'm not bothered about the frontal because that's not in the view. This is the sphenoid sinus. This is the posterior ethmoidal artery here. Can you see the posterior ethmoidal artery here very clearly?
Yes, sir.
Yeah. Beautiful, beautiful. That's the posterior ethmoidal artery. That is the posterior fovea here. And I have not dissected here. That's the maxillary sinus axillary ostium. Any doubts so far?
All fine, sir.
Okay, cobblator. Now I'm going in for the endoscopic modified Denkers. Of course, I can do it to the medial maxillectomy, but I feel that I want to do a definite job. So I want to take this. Tanni. No, Tanni. Now you can see here. That's okay. No, only on the TV. Yeah.
We are losing transmission when you use the cobblator, sir. Actually.
Come again, Dr. Omkar.
We are losing transmission in between when you use the cobblator, but that's okay, sir. Carry.
Why? What happened? Why? Scissors. Oh, there's some electrical disturbance, huh?
Looks like that.
Usually we lose it only when you use diathermy.
Cautery, yeah.
So I'm cutting off the inferior turbinate.
Yeah.
So one thing you should always remember, my dear friend, is many people are confused between skull-based surgery and rhinology. In fact, they want to be maximally conservative and give good results. They don't want to disturb the nose. I have seen many people who say, oh my God, you're cutting this. In skull-based surgery, we should be minimally invasive to the brain. Very, please understand that very clearly. It is not a question of cobblator. So I use the EVAC 70. You can see that I use the EVAC 70 here. So what is the next step?
The exposure of the Denkers be the same when you're dealing with.
Yeah, correct. I'll tell that. Yeah. Okay, can you see that I've exposed the anterior piriform aperture, please?
Yes, sir.
Now, my exposure in this Denker will not be much. It will not be like a JNA. I'm just going to do... Who is that?
ಮೇಲ್ಗಡೆ ಮೇಲೆ ಆಮೇಲೆ ಇದು ಪಜಲ್ಸ್ ಎಲ್ಲ ಇದೆಯಲ್ಲ.
Okay, hold. Okay, can you hear me? There's some disturbance. Yes, drill. Now you can turn to the external camera to see how 3 surgeons work. Now you see how 3 surgeons are working now. See how beautiful. This is a tandem. Can you see here? See how 3 surgeons are working? Hello?
Yes, we can appreciate, sir. Carry on.
On my front is Satya. On my right is Shiva, who is irrigating. I'm standing in the center. I'm holding the suction and the drill. Okay, I'm going to start now.
Okay.
Hey.
Fourth time.
Okay. Ma, this work alama. Drill faster. Drill faster.
Like the fine diamond.
No, but it's okay.
Dr. Janki?
Yeah.
Your surgical field is so clean. Beautiful surgery.
Madam, your voice is breaking, madam.
Okay, let me go close to the
Hello?
Hello?
So she's
Can you hear it?
appreciating surgical field, sir.
What?
She's appreciating your surgical field. She says it's very
Oh,
clean.
thank you, Dr. Madhuri madam. It's actually mutual. We both appreciate each other. Your surgeries I've seen, it's so beautiful. It's seen in your books also. So happy. Huh?
Hello.
Yeah.
Now, am I audible, Janaki?
I don't know why your voice is actually breaking. I don't know why.
Okay. Okay. Let me check.
You have to talk to the audiovisual team. Can you, Dinesh? Dinesh is my close friend. He will set it right.
Okay. Okay.
Mr. Dinesh. Huh? Madam is using laptop.
So while we are at it, can you tell us the landmarks of drilling here, sir?
Okay, see, we have what is called 3 osteotomies, boss. Some people use mallet and gooch. I generally don't use it because I have to make a controlled osteotomy. See, for a JNA, I would have. See, if the JNA is going towards the cheek, then I'll go lateral. If the JNA is going towards cavernous sinus, I'll go higher. If it's going towards parapharyngeal space, I'll go lower. So this is a mid-size osteotomy. I'm doing a very controlled osteotomy. This will not produce any ALR collapse or something. If you go high, then it will produce ALR collapse. You can see the nasolacrimal duct. Can you see the nasolacrimal duct here, please?
Yes, sir, we can appreciate.
Beautifully seen. You see the anterior, the canal for the nasolacrimal duct. All of you, can you see this very clearly?
Yes, sir.
Clearly seen. Very clearly seen.
Give me a Blexley. Now, we can do 2 things with the nasolacrimal duct. One is either we can actually cut it, or what we can do is we can actually do what is called transposition of the nasolacrimal duct. So, I will show you. Give me a scissors. Scissors, no, not this. So, I'm going to transect it here.
Clean cut. Yes, sir.
We can do anything. I mean, nothing happens actually.
Yeah.
People are scared about it. No, I don't think you need to be scared about it. Now, see what I've done now. I have already completed the exposure beautifully. Can you all appreciate that, please?
Yes, sir.
Hey, irrigator. Blexley seriya kudu.
So it is about the exposure that is, which is the key to any surgery in skull base.
Absolutely.
The more posterior we go,
Suction. Oblator.
Yeah.
Oblator. Wait, no. So you have a little. Hey, nalla suction kuduma. You have a little bleeding. Don't worry about that. That's a small vessel there. Give me a cobblator, please. That's the posterior wall. Can you all appreciate the posterior wall of the maxillary sinus? Very beautifully there.
Very nicely seen.
Nicely seen.
Okay. Now, I just cobblated that area.
Yeah.
What I'm going to do now is I'm going to use my debrider to remove all this now. Give me a debrider. So you see, everything is planned, what instrument to be used in which step. There is no confusion at all among our team. And in case of emergency management also, we have a block more. Only thing we can't control is this block. Block. Okay, now having done that, now I have to do.
You're saying something, sir. In case of emergency, you have standby.
In case of emergencies, we usually have protocol-based emergency management. So we always have in which step we might have a problem. So we identify the step and we prepare ourselves, our team, for emergency management. So this is very, very important because the pilots, they prepare themselves for emergencies. The same way we prepare ourselves for emergencies, and we don't want anything to, if it goes wrong, it can go wrong. Usually it doesn't. It can, but if it does, what precaution, what instrument, what kind of, emergency management. This is very important for juniors, youngsters, in fact, anywhere in the world.
What emergency do you anticipate, sir, here in this patient?
So, number one, I will tell you what can go wrong in every step now. Let me tell you the complications which can happen in every step. Okay. Now, see, I cut this area, right? So you can have a bleed. So the coblation should be ready here. So that is one small emergency management, coblation. So number one. Number two, you see, in every step you have a little bit of here and there, you can have a little complication. So see that I'm trying to manage that with a coblation. That's the sphenopalatine artery here.
Dr. Janaki?
Yeah.
Can you share with us what steps you have, planned in your mind in advance?
What is it?
What steps are you planned in your mind in advance?
I've already written.
Yeah, ma'am. That was already displayed on the screen, ma'am.
Okay, yes, okay.
You are not there for that?
For 2 minutes, I was not there.
Okay, I have already planned the 10 steps, and I already wrote that and I showed it to the audience.
Oh, thank you.
I've already shown every step to the audience. What I am doing now is just what I have written.
Okay.
So that's a partial resection of the. So in this model, I have what complication I can have. I've already ligated the sphenopalatine artery, so I don't expect a complication. So these are the things you should already plan. Again and again, I say, emergency management for every surgeon is very, very, very important. And if you don't do that, your surgery can go for a 6. Now, give me a next step is castidose flap, right? Cobblator. So I have written already all the steps. So my staff knows exactly what step I'm going to do. So there's no confusion. There's no, hiccups in every step. So you see here, what I will do now is I'll bring that. Very good, very good.
You are devascularizing the area around the sphenoid on the left side, and this is in preparation for the transpterygoid approach.
Absolutely. Now, see what I'm trying to do? I'm elevating the flap reverse. This is nothing but the castidose flap.
On the left side, yes.
Yeah.
Suture ready.
So what is the complication I can encounter? I can encounter a tear. Of course, I will not bother about it because this is going to be sutured onto the other side. So all these are pre-planned. All these steps are pre-planned. Okay, now I'm going to open up the posterior septum.
So for the sake of, the viewers, this flap will be preserved and rotated over the posterior part of the remnant septum and sutured on the other side.
Exactly.
Yeah.
Now give me a elevator now. Now I'm going in for the posterior
septectomy.
Septectomy. Always posterior septectomy is done at where? At the bony cartilaginous junction. That is exactly where we do the posterior septectomy. Okay, right? That's the flap on the other side. Give me a scissors, a thick scissors, please. So you see, it's like a smooth sailing. Wait, hold this. Now, many people use a Lux forceps here. I strongly deprecate the use of the Lux forceps because if you use a Lux, there's every chance that you can have a meningocele there. You can produce a big meningocele. So don't do that. That's very, 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 very important that you don't. Can you see the posterior septectomy now? All of you, please.
Yes, sir. Very beautiful.
Yes, very clear.
Okay, so that's it. So I have done most of my work now. And what I'm going to do is I'm going to suture this flap. Give me a shift the next patient. We have 3 cases today.
Suction, please.
Can you see this, please, all of you, how it's covering the anterior part? My dear friends.
Yes, sir, we can appreciate.
This is called Castidose flap. Give me the suture.
And it will have a great role in preventing crusting in the post-operative time.
Yeah, it will prevent the crusting in the post-operative period. Yeah. See again how I am suturing. You need to see this. Very, very important, my dear friends. Because many people, they struggle to suture. So that's the first one I took. And now I'm going to take this. See how I'm holding the needle. Can you see the endoscopic picture, please?
Indeed, sir, yes.
See how I'm holding the needle? Go inside. Go from anterior to posterior. Go.
One minute. Doesn't hold it.
எப்படி எடுக்கணும்? ஓகேயா? போயிடுச்சா?
இல்ல லூப்ல இருக்கு. இதை வெளியேடுங்க. சிவா வெளியேடுங்க.
Take it out.
Yeah.
It might take a while here, but it helps in long term, definitely.
Yeah, on long term, patients are very comfortable. They will not have crusting. And believe me, these are small things but make a lot of difference in your surgery.
Yes, sir. I mean, we have had patients in an attempt to remove those crusts in post-operative period. They have strained and caused CSF leaks in pituitary. In pituitary surgeries sometimes.
Yes.
So it's very important to have the mucosally covered. Any bone.
Give me a scissors now. See how nicely we have covered the complete.
Yeah.
Can you see that very clearly, my dear friend?
Yes,
okay.
sir.
We can appreciate. Yes.
Now, having done that, so I have done most of my job here. Give me. Now I'm going to start. Hey, be careful when you go through this. Don't disturb this. Be careful. Give me a free as elevator. I'm done mostly. I'm just going to do that. See how nice exposure we have. Can you see that?
Yes, sir. Okay.
Now hold. Now I'm going for 4-handed. Drill, please. Now I'm going to do a triple osteotomy like we do for the
pituitary surgery.
இல்லனா flap வந்துரும் கையோட. Whenever I go inside, pinch the suction. Okay, ready. My drill is not working properly.
So he is doing the superior osteotomy and the lateral also on the left side.
This is the shoulder osteotomy.
Yeah.
And the first one is called the planar osteotomy.
Suction's not working.
My suction is working, but the thing is my drill is not very powerful. I don't know why the drill is not very powerful.
Not normal.
Very, very bad drill. Hmm.
The keel has been, yeah.
Can you see the rostrum coming out, please, all of you?
Yes, sir.
This is the
Phenoidal
septum, right?
Yeah.
Agreed?
Yes.
Yes, sir.
Now, what I have to do is to take a irrigate. Do I irrigate?
That is the sphenoid mucosa that you're taking off. Yeah.
Whenever we take sphenoid mucosa, we should irrigate. Very, very important. Because sphenoid mucosa is very vascular. Never use angle telescopes. What?
We are using warm saline for irrigation, right?
Yeah, exactly. Warm saline for irrigation. You see how nicely the mucosa is coming out,
Yes,
and
sir.
Shiva is irrigating nicely.
Some part of the
Yeah. You can even take it as a flap. Of course, in this case, I'm not drill. See how beautifully we can see the sphenoid sinus now. All of you can see that very clearly now, my dear friends.
Beautiful exposure, sir.
இல்ல மேல ஒண்ணுமே இல்ல ஒண்ணும் இல்ல அது பக்கத்துலயே போகாது. We are not working up. We are only working down, not up. No, give me out.
Satya is holding, sir.
See, yeah, Satya is holding.
Great
And
job.
thank you, Omke. You did it at one time.
Yeah, and we know how it. I mean, it gets fogged.
You know, I'm a little. You know how I get a little fanatic about holding and all. I wanted the right view and things like that.
But that's how precision is up. I mean, achieved. So that's great, sir.
I always say we train pilots, not auto rickshaw drivers. Everything is by protocol.
Drilling the intersphenoidal septum.
Yeah, the reason why I'm doing the floor of the sphenoid is because I want a flat area for this Hadad flap to come.
Yeah.
Sir, what complication can be expected at this stage, sir?
At this stage, you will have bleeding, and the treatment is irrigation.
Okay.
So this is the bleeding you will encounter. This is natural for sphenoid mucosa to bleed, and the treatment for this is just irrigation.
If the intersphenoid septum is attached to the optic nerve or any other important structure.
See, basically the best instrument to take off the intersphenoidal septum is the drill.
Yeah.
Okay.
So don't pluck it with a Blackesley. So that is to prevent the complication. So I always use the drill, or you have another forceps called silk cut forceps.
Okay, sir.
That is by Karl Storz again. Wonderful instrument, and it will cut through the bone. I have seen people using a Lux forceps and Blackesley to pluck. All that is extremely dangerous. You might cause a carotid artery rupture or an optic nerve injury, because this intersphenoidal septum is usually going and hitching against the medial opticocarotid recess.
All right.
Give me a drill. Drill. See, many people might think, hey, I'm not able to see the leak. Leak will not be seen now. It is far lateral. Drill. Now, no. You can't coagulate this area. If there is a venous bleed, don't try to coagulate. You will not be able to coagulate. Don't coagulate on a venous bleed. You cannot do it. You have to use Surgicel. That's it. So I've got it beautifully. A flat surface here.
Yeah.
That's it. Now I'm going to keep a pack here. Saline pack, ribbon pack, please. Let's see. Saline ribbon pack. Now, I'm going to pack it and I'm going for the trans-pterygoid approach now. So this is all the steps which we have already written. I just executed the steps which I have written. So that's it. That's the sphenoid sinus. Yeah. Yeah. Okay, come on. Okay, now the next step is coblation. The next step is Satya wants me to coblate this area. Tanni. Because he says that there's a little bleeding, which is fogging his scope. Right. Now let me go for the trans-pterygoid approach. Okay, another 10 minutes or 15 minutes, I'm done. You can see the, I'm going to do only a limited exposure of the trans-pterygoid. It depends on how much lateral see, you have what is called the VR line. The VR line is the Vidian rotundum line. So if you have, there are three types, type 1, type 2, type 3. Type 3 is very deep. Whereas if it is type 1, then it is not very deep. So this looks like a type 2 VR line. See how everything is looking completely like an anatomy textbook. Very, very important for you to perform surgery. Okay, like an anatomy textbook. Hold from the other side. Be careful about the flap. Okay, here we are. Now I'm going in for the, go inside, my dear friend. Now I'm going in for the trans-pterygoid approach. For that, I'm drilling the. Now in this step, I will encounter bleeding. I might encounter bleeding. What is the treatment for that? The treatment for that is coblation, have coblation. So all these are the ones which you are ready.
We might encounter sphenopalatine or descending palatine bleed in this area, which are both terminal branches of the internal maxillary artery.
Correct.
So, yeah, so those can be, I mean, they are amicable. The bleeding can be stopped by coplator.
So you must be using clips now? Clips or direct bipolar?
Both. I can use clips or I can use coblation, but I prefer using clips.
Okay.
Clips he would use when, the bleeder is far, little more lateral, like.
No, whatever. It's always better for clips. The reason is,
yes,
you will not have postoperative bleeding.
Yeah.
But of course, as you say, Omkar,
yes, sir.
bigger the artery, the clips are better. Smaller artery can be coblated.
Yeah.
Yes, this artery is quite thick and the clips nicely place this, no chance of bleeding later on.
Yes, ma'am.
Yeah. That's the designing paradigm. You can see how beautifully the designing paradigm is seen. Now,
yes.
So when I use the cobblator on an artery, first use the blue. Don't use the yellow.
No.
Always use the blue. Now you can see the artery going down. Can you see that clearly?
Yes.
Yes, sir. We get disturbance when you use yellow.
Oh, sorry.
No issues. Yeah, carry on, sir. We are just updating you.
See here.
Yes.
See here I can cobblate because it's a small artery.
Oh.
That's the median.
Kindly focus on Vidian.
Yeah.
Sir.
I will do that. I'll show you. I'll show you.
Okay.
Once you're done with the coblation, sir, you can show us with some cold instrument. Yeah. Coblation is a good device to deal with intranasal, mucosal segment as well as the fat in that area.
Exactly.
So, yeah.
Irrigate. Now, here we are. What I'm going to do is to push the contents of the. This is the pterygopalatine fossa. Can you see here, my dear friends?
So, can you orient us once again?
I will orient you. 1 second. Oh, oblator.
Oh.
Now,
Is it the proximal spinopalatine, sir, or is it the IMAX?
which one?
The
No,
one
no, IMAX doesn't come in the pterygopalatine fossa. It comes only in the infratemporal fossa. So this is still the pterygopalatine. See, how do you differentiate between pterygopalatine fossa and infratemporal fossa? The lateral pterygoid plate.
Yes, sir.
Give me an elevator. So this is the lateral pterygoid plate. This is the V2 here. If you draw a line here, then this is the level of the pterygomaxillary fissure. This is the infratemporal fossa. This is pterygopalatine fossa. You understand or not? Now that's the sphenoid. Come out. Now there is a sphenoid sinus here. Can you see the sphenoid sinus here, all of you? Now
Yes, absolutely.
Now I'll orient you to the whole anatomy now.
Yes.
Okay.
I'll orient you to the whole anatomy. This is the pterygoid wedge. This is called the pterygoid wedge.
Yes.
Okay.
That is
This is the pterygoid.
the two plates. Yes.
So how do you define the pterygoid wedge? Pterygoid wedge is defined as the trifurcation of the medial pterygoid plate. This is Professor Daniel Prevedelo's definition.
Okay.
There's a go closer. Go closer. See, there's a little clival leak here. You can see here. There's a small clival leak. Give me a coblation. Of course, I should not use, but I'll try. I'm very close to the. This is a clival. Carotid. Yeah, no problem. Usually it doesn't stop. Give me a drill. So again, you can use bone wax. Drill without irrigation. Don't irrigate. Oh, stop the drill irrigation.
Or surgical.
Clival bleed. See that?
Yes.
Can you see that?
Yes, sir.
Beautiful.
Super.
This is paraclival carotid. Paraclival carotid. Sella is here. Come out. This is the optic nerve here. Give me I'll show them the anatomy. No, you should hold it. Hey, ball probe, please. Now I'm ready, almost ready for the leak site. Now I'm going to show you the anatomy of the sphenoid. That's the sella here. This is optic. This is optic. This is carotid. Can you see the carotid here?
Yes, sir.
Yes or no? Carotid is here. That's the clinoidal carotid. Come out, my dear friend. This is the clinoidal carotid, cavernous carotid, paraclival carotid. That's the paraclival carotid here. That's the clivus. There was a little bleeding, which actually I drilled over it. That's the intersphenoidal septum, very nicely seen, and come out. Now, this is the pterygoid wedge.
Yes.
It goes toward, this is the os, this is called the os sphenoidale. This is called the os sphenoidale. This is the lateral pterygoid plate. This is the medial pterygoid plate. Medial pterygoid plate is here. Okay. And just adjacent, this is the paratovaginal canal here, and this will be the Vidian canal here. Can you see the Vidian here?
Yes, nicely.
Here.
Very beautiful.
And this could be the V2, but of course, the V2 is already gone because it has already been damaged by the neurosurgeon here. You can see this is the pack which has been placed by the neurosurgeon here. Can you see here?
Yes, sir. Yes, we can appreciate.
Can you see or not? Here, see.
Yes.
This is all that pack which has been placed. I don't know how he came from the other side. I really.
Yes, I am also surprised.
Yeah. Now, what I'm going to do is I'm going to drill this area to expose that area of the leak.
Yes.
This is the V2. I'm expecting the leak somewhere here. Okay. So, come, drill. Can you all understand the clear-cut anatomy?
Yes, sir, yes.
Yes,
Now, what I
absolutely.
will do is see here. I'm going straight head-on to the pterygoid wedge. In between, I'm drilling. I will be seeing fat now.
Yes, sir.
I think they have written fat fascia.
Yeah. And they also mentioned some flaps, sir.
No, they have used the temporalis muscle.
Temporalis muscle flap.
That's why patient has trismus also.
Pericranial.
No, for first time pericranial, second time temporoparietal. And what they did was by using the see, many people used a lot of temporalis muscle and lot of pterygoids. And actually, patients present here with trismus. So be careful about using such muscles because they are all muscles of mastication.
Yeah.
And you don't want to produce unnecessary trismus.
So this patient also has only two finger mouth opening.
Yeah. He has got only 2-finger breath, and the anesthetist said, "Hey, idu kudu." Coblation. We have to do a fiber optic intubation.
Oh.
So please understand that. Be careful because the post-operative period also we have to take care. It's not that just intraoperatively you come out and the patient lands. See, the patient is now having 3 nerve palsies. 6th nerve palsy, 5th nerve palsy, trismus. You give a lot of morbidity to the patient, which is not a great thing to do. Come out. Now you can see the material little confused about all that. Let me check. Blexley. Now drill, please. It's a very wide defect as you saw in the CD scan. So my exposure should also be very, very wide. That's a paraclavial carotid. And I expect the median to be somewhere here. Give drill. Hey, irrigate da. So I'm going towards the carotid artery.
Yeah.
That's the drilling of the medial pterygoid plate. I have to make it very smooth because the hadat should come that side, right?
Yeah.
Very, very important. All these are fine points. Why am I taking so much time to actually, drill off all this? Because I need the nasal septal flap to come this side.
And drape it. Yeah.
And drape it completely. Correct. Now let me see where I have to go.
And it should sit without air pockets.
Hello?
Yes.
And it should sit without air pockets. Smooth. Yeah.
What happened to you? I didn't see you in the morning.
No, boss. We had a small bikeathon also in Trustwell in favor of this surgical society. So I had to attend that as well and come join you.
You have become a very big guy.
No. Less academic.
Hello, Dr. Deepak. Hello.
Hello, madam.
How are you?
Absolutely fine.
Nice hearing from you. Nice to have you. He's doing great surgery.
Yeah, that's an understatement. Out of the
Understatement.
world is the word. Yeah.
I don't have words.
Yeah.
No. All that is nothing. We are doing
beautifully
what we have to do for this patient. Now I'm going to show you what the defect is. Believe me, it's going to be really an astounding defect.
Are you drilling along the greater wing, sir?
Yeah, this is the greater wing, right?
Yeah.
Hi, Omkar.
Hi, sir. Good afternoon.
See, this is all dura. This is the fat which they have placed. Shiva, this properly.
First time she went, she had a very small difference.
So is it dry out tissue also with that? Or?
Yeah, that's brain along with it. See, lot of the whole thing is the dura, the brain, everything is like completely exposed.
Yeah.
That's the carotid artery. Go closer.
Yeah.
Now give me the coblation now. Now I'm going to expose the defect now. Be very, 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 very careful. You're right on the brain now. And you don't know what has really happened inside. I don't want a temporal lobe epilepsy. Now I'm using the blue. This is the fat they have used. Can you see?
Yes, sir, we can appreciate.
Fat, white, yellowish fat. You see?
Widen the defects.
See, the whole thing is a defect.
Yes, sir. Now, I mean, sir, CSF is, I mean, we cannot differentiate between the irrigation fluid and CSF.
Oh, you'll get it. See, one thing is best is fluorescent. If you use the fluorescent, no, you will differentiate.
Yes, sir. I was coming to that.
No, but Omkar, the principle is the same. He's trying to define the defect so that he can close it well, no, instead of again pushing some tissue somewhere.
Yes,
yeah,
and
exactly.
this area corresponds to the area where lateral recess would have been if there was a very good pneumatization.
Yes,
and little
sir.
lateral to that.
And
He's anterior to the carotid.
Yes, sir.
Yeah.
We have to get bony margins all along.
Yeah.
Yes, sir.
So it's like a modified Sternberg canal leak repair, much bigger defect with bigger brain herniation.
Yes, sir.
Yeah.
See, they have kept some. Go closer. You see that some suture material. Can you see?
Yeah.
Here.
Something.
They have sutured something.
Probably they have stitched the fat to that edge of the dura or something like that.
That muscle or fascia or something.
They use the temporalis fascia, temporalis muscle.
Maybe to keep it in place.
Yeah, to keep it in place, they have sutured it.
They're
Now
not
look
used
at the
any
defect.
dura patch and all that. Yeah. And hopefully the tissue prolapsing is a dead tissue, not functioning.
Exactly. This is all, the defect, and there's a lot of repair material still.
Yes.
Will you discuss the repair material or you'll go ahead?
No, I will not. Why should I?
But very good case, boss.
Yeah, I told you, sir, it's a beautiful case.
Yeah.
And I would see here, this is the carotid artery. Okay. What is the bleeding from? Where is this bleeding from? This is actually
carotid artery.
very close to the Meckel's cave. See, this is the carotid artery. This is the carotid artery, very close to the Meckel's cave. This is the cavernous sinus here.
Yeah, carotid artery, Meckel's cave. Not the meningeal comes through this one. No, foramen spinocerebellar.
Looks like a venous bleed. Maybe.
No, must be.
Can you see the defect? Complete defect, please now.
Yes.
Beautiful. How is the picture quality, Deepak ji?
Oh, it's very good.
Drill.
What is
Dr.
the blade,
Janaki?
Janki? What is the vessel?
Yeah.
Can we measure the size with the curtain of a scale?
Yeah. Ma, scale kuduma.
To make it flat.
Yeah. Hey, give me a scale. You have that scale, right? We have a paper scale.
Janki, there are three things to this case.
Ah.
Number one, doing it the way you are doing it.
Ah.
Number two, getting such a case to your office.
Ah.
And number three, revising a neurosurgeon skull-based case.
Third time, I mean, second revision.
Yes.
Third revision.
Third revision, yeah, sorry.
That is why we call you Talaiva, no?
Ayyo. Completion. Quick. Sir, you are KB.
No, anyway, what is that area that is bleeding?
Tanni. What, sir?
What is the answer to your question?
What
you
the
asked us
answer?
a question, the bleeder from carotid ka.
Hey, Meckel's cave.
Yeah.
This is the Meckel's cave.
Yeah. That oozer is venous?
Yeah, venous ooze from the Meckel's cave is filled with blood.
Okay.
Venous blood.
Yeah.
Give me now the Rosens. Can you see the defect very nicely?
Nicely.
Yeah.
Wow.
Such a large defect.
Yeah.
Very large defect.
Just flatten the bone on top.
No. What a case.
Yes, sir. Fantastic.
Yeah, man.
How come the CSF leak is not yet seen?
That was my next question now, sir.
Hey, sometimes in this process of coblation, this thing would have stopped.
Yeah.
Because see, even he cannot cut it with a scissor. The way he can remove the projected tissue.
See here, you can see the leak, my dear friend. See here.
Correct.
Hey, give Valsalva. This is a defect, the reconstructive material. See the fat.
Okay. Now you got the plane.
Yes. Now you got a plane. So this whole tissue is the fibrous or the repair layer?
See the fascia. See the fascia.
Oh, yes. Oh, yes.
Fascia we can appreciate.
Is it fascia, the edge of the dura? Fascia.
This is fascia, whitish fascia.
Yeah. Now you got
it. Is it some necrotic part of brain or is it the repair layers you were seeing in the
depth?
This
is the repair layer. I don't want to disturb it. Satya was asking me, are you going to disturb it? Why? I already repaired.
Yes.
Why you have to disturb it? You don't have to. I'm just going to use bipolar on this. Bipolar.
Okay. Yes, absolutely right decision. We should not be disturbing. It is already sitting nicely there.
It is sitting nicely there. Only thing is that if I put bipolar on the temporal lobe, he might develop a little already gliotic brain. I'll find liquid brain only. And he'll develop some problem with the temporal lobe. So what I will do now is on the material, I'm using bipolar so that it will stick nicely.
So, okay, Dr. Janki.
Yeah.
How can you differentiate on any view of the MRI between a gliotic means non-functional or functional part of the brain?
I'll show that.
Okay.
I'll show you that. Hey, you have that, this one?
I think for that we need to look at the vascularity, madam, or?
No, the brain will very beautifully show gliotic changes in T2 and in contrast you can see beautifully.
It will, yes. It will be a hyper intense, more intense than the brain tissue.
Very hyper intense.
Yes.
Correct. Now can you see that very clearly, my dear friends? Very, very nicely. You can see the defect. Exposure is the key again. That's Meckel's cave. And use bipolar. This is something which I want to tell again and again. Many people close CSF leaks with coblation. I have faced my own cases, initial phases, I faced 2 revisions. The reason is coblation gives only 60 to 100 degrees. So the idea of closing this leak is by fibrosis. And fibrosis is caused only when you have a lot of heat. And produces 400 degrees. So even if you have a cribriform leak, just use bipolar. After coblation, you use bipolar. Believe me, the results will be definitely better.
Somebody
Janki, I totally agree with what Professor Kirtane said.
What?
Yesterday's and today's event now, I remember what Kirtane sir exactly said. He said Janki and Satish are in a different stratosphere.
Oh my God. No, sir. No, sir.
The
No,
ease
sir.
and the speed at which you are operating in this area, or I can take both your names together, the way you two guys do.
Give me
Yes, I agree, Deepak. I
Yeah.
agree.
Yeah.
Sir, it's all your blessing, sir.
What? We can give only blessing when we have limited talent. The easiest thing to do is give blessings.
No. Give me fascia. Hey, get the next case ready. Can you see that now? We have used Surgicel to close that.
Fantastic.
See, always remember one thing. When you're using fascia to close a defect, it should be 1/3 more size than the defect.
Yeah.
This is the
yes.
This is the formula.
To err on the larger side.
Yes. It's okay. It's okay. Pudichuko. Suction pudichuko. Pinch suction. Okay.
So this is fascia now?
Facial lata, sir?
Yeah, the facial lata already harvested by Satya.
So
Morning,
now,
Lakshmi Satish.
Hi, Deepak. How are you?
Fine.
so you will not use fat now, sir, right?
Why? Already fat is there, no?
Yes, sir, that's what. So if we have to use the fat, it should be closer to the dura. I mean, already there.
Now you see what I'm doing now. Go inside.
Beautiful.
Was this a high pressure leak, sir?
This is not high pressure.
Okay.
Yeah.
So you're not going to put a lumbar drain?
No, not necessary. Lumbar drain is done only in two conditions. Number one, if you suspect a BIH, high pressure leak. This is not a high pressure leak. Or if you open up the ventricle. No. Yeah, you might have a little bleeding because you're close to the Meckel's cave and you're close to the carotid artery as well. So it's quite a large fascia. Always when you use, the best instrument to do is not ball probe but a J curette. Very, very important. Many people use ball probe. The fascia will come along with your hand.
That's a very relevant point.
Am I right, sir?
Yeah, I use a ball probe, but not with a ball, the blunt end.
Blunt is okay. Give me a Surgicel.
You get those probes which have one blunt end and one ball probe.
Exactly.
Yeah, ball probe is counterproductive.
One more fascia.
One more layer of Surgicel.
One more layer of Surgicel I'm placing. Fascia.
This is a smaller one.
Yeah. Now give me the come here. Shall come. Just do a trial.
It's the Haddad flap.
Pinch panno, pinch panno, pinch panno.
Janki,
Yes, sir.
whenever you see a surgeon operating,
Yes, sir.
the surgeon's hands betray the numbers.
What, sir?
The surgeon's hands
Ah.
betray the numbers. They tell us the number of such cases he has done.
Oh, okay. Ah.
With your movements,
Give
the
me the
ease
picture.
and dexterity with which the graft is placed, the
Yeah.
Haddad is positioned, the speed of drilling on the defect, finding the plane between the fat and the brain. As they say, walking the talk.
Walking the talk. Wow. What a statement. Walking the talk.
Yes.
Wonderful statement.
Is that fascia lata again? One more layer?
This is onlay. That is inlay, this is onlay.
Oh.
Hello,
Yes, madam.
Dr. Janaki.
Yes, sir. Yes, madam.
It seems that the tissue itself is lending the way. It says, okay, come Janaki, we won't bleed. It is so
Yeah.
clean up. It says, okay, keep going ahead, we won't bleed. Such a clean, beautiful surgery, like piece of art.
Yes. Like when Madhuri madam decompresses the labyrinthine
Yeah,
segment of
when you
tissue.
do the ear surgery, this is the same thing I feel.
No, it's all your. Thank you.
No, madam, honestly, at least last 5 years, your evolution as a surgeon has been phenomenal.
Thank you. Thank you. It is all your good friends around.
Especially the osteoplasty madam does.
Yeah.
Phenomenal.
And at the danger of sounding gender biased, Janki, it is 6 times more difficult for a woman to make it in a surgical field.
Yeah.
Compared
Correct.
to a man. Yeah.
My God. No. I feel it is just being in the right time, being with the right people around, teaching and training you.
Yes.
Things are looking, good in our ENT, no?
Fantastic.
Teaching,
Fantastic. I don't know about other
teaching,
fields.
and
Yeah.
absolutely without any expectation, people are teaching, and this is making really great ENT surgeons of the future.
No, because see, there are only 2 qualities which you require to be great. One is madness and one is hunger.
Yes. Yes.
Either come,
Rightly said, Deepak.
Isn't it, Janki or Lakshmi?
Absolutely, sir. Absolutely. And one thing I want to tell you is that it's not only this generation, but actually it is because of the people like Professor Morwani sir, Professor Kirtane sir.
Yeah.
This generation has
Madhavaya
been
sir, Vishwanathan,
Madhavaya
K.K.
sir,
Ramlingam. Yeah.
K.K. Ramlingam sir, all that have made us like this.
Yes.
So it is the next generation will be better than us. So it is like that.
Yes.
So give me this one, tissue glue. So I think we're almost through. And I feel that this guy is not going to leak again.
This is the
Even if it does, area is so well exposed, it can be quickly closed.
I hope it will not leak again.
No, but it will not leak. It will not leak. But no. It will not leak, but if it leaks and he comes to Bangalore, I don't mind doing this case. Because all the donkey's job has been done.
So, what did you spray, sir, just now?
That's fibrin glue.
T-cell.
That is fibrin glue.
Okay.
Yes.
Now you can see that's the repair completely, you can see that exposure, repair. So this is the planning. Again and again, I say it's not the execution, but it is the planning. How we have planned it, the whole temporal lobe exposed, and we have closed it. And this side, we have done the castido, and you see how beautifully the castido is sitting. So this patient is going to be completely free of even crusting. And these are all the things I think which make small things which make a lot of difference. And I really thank Dr. Deepak Haldipur sir for this wonderful opportunity. In fact, I was in Dubai. He said, no, you can do it from Dubai. This is the generosity with which he actually approached. And I'm telling you, we get very hardly friends like this. And you have been a great friend,
Boss,
sir.
no. See, for me,
source of inspiration.
For me, you and Satish have inspired me so much in the last 1 decade. You bring in all the energy, honestly.
Sir,
you guys have been amazing. The amount of inspiration you give all of us. I must be 4 or 5 years older to you, and maybe 9 years or 8 years to Satish. But you guys are such great teachers. You really keep us charged.
Sir, it's all your blessings. Again and again, I say, see, there's no point in having talent without exposing it. And talent without teaching is as good as, it's like, dead talent. I always believe that. I think Satish also does the same. And I also believe in the same, that teaching actually will progress science. And that is the way to go. And the next generation will definitely be better than us. And we want them to be better than us. This is the idea with which we are doing this. Nothing else.
And all of you guys walk the talk. That is what that matters at the end
Are you going to pack the nose, sir?
Yeah. Satya is packing the nose. He'll keep
and how many days he'll keep it?
Gel foam. He'll keep Surgicel gel foam and also nasopore, and that's it. It'll get absorbed. Nasopore we get from Dubai.
Okay.
So it's not available here, but we get it from Dubai.
Roughly in 7 days it will dissolve?
5 days it will go. She'll be able to breathe now itself to the right side. So we'll pack only the left side.
Okay.
So Dr. Janki, how much did it cost, this dissolvable pack? We saw in Singapore also.
Not much, madam. Somewhere around 1,000 rupees.
Oh, really? It is available in India?
It is available.
No, not in India. It is available in Dubai.
Singapore
Malaysia.
also.
I got it when I went to Malaysia this time.
Okay.
And I just got 10 pieces. Now I'm going to Dubai every month, so I'll get from there.
Okay.
There they use only the nasopore. It's beautiful. I
think this is
Indians. They cut this off. I don't know why they have cut this production here.
Okay.
I don't know. We had nasopore in India before, but I don't know why they cut it off here. But it's a beautiful packing material. I love nasopore.
Especially for CSF leak repair.
Something else has come similar to that from a different company. But it's not proven yet. Its efficacy is not proven yet.
You are using that, sir? Are you using that?
No, not at all. I don't know.
Merosil, the problem is when we remove it, the patient is shouting.
And I am addicted. I am addicted to the front boat in shipping. No, either Satish or Janki have to endorse it. Immediately I'll start using. I'm the best copycat in the country.
No. Sir, we learn from each other. It's mutual.
Can you please tell the post-operative protocol for this patient, sir?
Post-operative protocol, the patient is put on bed rest for at least 5 days, head and elevation, soft diet, Foley's catheter for at least 24 to 48 hours. And then the patient will be given antibiotics like Monosef, and then painkillers. And 5 days later, the patient will be discharged.
And anti-epileptics also.
Correct. I was about to ask that.
Anti-epileptics, yes. Levipil, yes. That's right. Yeah.
Wonderful, sir. Excellent demonstration.
One small anecdote I will share, Janki, when all of you are there.
Yeah.
Great.
About 7-8 years back, when we were doing a angiofibroma, Srinivas Murthy told me, why don't we divide the angiofibroma in 2 pieces and deliver? I said, Satish and Janki are not doing it, so no question. Remove it in 1 piece. Next year, you bugger started doing it. Sir, Srinivas Murthy turned and gave me a glaring look. And 1 year before, he had told me, why don't we use coblation for angiofibroma? I said, what nonsense you are speaking. Till date, he has not forgiven me for these two things. He says, for you, it has to come either from Jaipur or Trichy, then only you will sneeze. Shah Rukh Khan's movie Duplicate, I think, was taken on me only, I think. But these two incidents are true. He had told these ideas, but for me, it has to come from Royal Pearl or from JNENT hospital, then only I will.
It's
And
so
immediately
humble of
Pandavan.
you.
So humble of you, Deepak. You always talk high about, the right people,
He
but you
himself
yourself are great.
No, he himself is an example for many
Yes,
ENT
yes.
surgeons. Only thing is that they are not on the podium to tell that, but I am telling you, there are so many people who want to emulate. Even myself, I also think, Dr. Deepak ji is so beautiful, fantastic. See the kind of transition he made, strategic transitions, the way he works with neurosurgeons. I can keep enlisting, then it will take one day for me. So how he works with Madhusudan sir and the team, superb. I love his attitude, the way he embraces all the ENT surgeons around Bangalore itself and also around India. And the way he has maintained his friendship with Dr. Dubey, Dr. Sanjay Agarwal. They said, even if I have a small party, Dr. Deepak used to come for the party. And Dr. Dubey sir!
Sir, happy Friendship Day.
I was just talking to you about you, boss. I was just talking about you. Yeah.
I am listening.
So, see the kind, Dr. Deepak Aldipur sir is a humble person, but I was just talking to you about you, boss. I was just talking about you. Hello? Sanjay sir is also there. See,
Hi, Janki, I endorse it. Dr. Bharti.
Yeah. Who is it?
Bharti.
Bharti.
Bharti madam. Yeah.
I endorse it, whatever you said.
Exactly. Yeah, he works as a team. See, the ultimate thing is how you embrace everybody and work as a team. That's going to be the future. You cannot just say, I am alone, can do. It is not possible. And we have to work towards working as a team. And see, Dr. Dubey sir, he called Dr. Jaikumar Menon. And it was one of the best workshops I've seen. I learned so much from him. It's actually mutual learning.
Yeah.
Yeah, exactly.
And Jaikumar himself is so good in phono.
Oh,
it's another world altogether, isn't it?
Yeah, it's a different world. Whatever he talks is new for us. Whatever he talks is new for us. So we learn from each other.
No, you have given him right advice that like you and Satish are always shouting about sinus. He has to shout about laryngology now. Now he has started.
No, honestly, see, marketing is important.
Yeah.
Only, see, when your mother
not
serves
marketing,
you.
but teaching. See, we should
No,
teach.
boss, what I'm trying to say, we would get food in the hostel also. But your mother gives you the food.
Yeah.
The taste is always different because she'll come and give it with affection.
Yes, exactly.
The hostel fellow will just push the vessel. The cooking may be good. Isn't it?
Exactly. So we have next case, which is a JNA. Very interesting case. Very, very interesting case. We will go to the other theater and we can start the next case. We have 3 cases. After that, there's an international forum which requested me to show a septum with turbinate. How do I deal with turbinate? Hi, boss. How are you? Where are you there? With Dr. Sanjay. Where are you sitting, Dr. Sanjay? He's not able to hear, I think. Yeah. It's okay. Right. We'll go to the next theater.
Okay, sir.
Close it. Yeah. We'll be back. It's okay. Right. We'll go to the next theater.
Okay, sir.
Close it. Yeah. We'll be back.
चले गया
डिले विशाल सब बकवास
वो डिले What delay?
विशाल आइए बैठिए.
कल के केस का किसी को पूछा किसी को तो उठाया नहीं उन्होंने. क्या नाम है उनका? हाँ हाँ, तो फोन नहीं उठा रहे वो. तो फिर उनको फोन बताना पड़ेगा ना कि कल आएंगे कि नहीं आएंगे, फाइनल क्या हो रहा है. मैं करता हूँ उनको. क्या नाम है उनका? मेरे नंबर से लगा कर हकीम कर.
லைட்ஸ் போடுமா, லைட் ஆன் பண்ணு, கருப்பா இருக்கு. மேக் மீ. Yeah, now it's fine. Yes. Hello? Hello, can you hear me?
Sir, it's audible.
Yes, sir. Yes, sir.
इसका कैंसिल सकते फिर, है ना? Okay.
Dr. Omke, Dr. Omkar.
Yes, sir.
Janki, absolutely audible. We are there with you.
Some technical error, it is resolved, sir.
Am I audible?
Yes, you're audible, Janki. We are with you.
I'm going to start the second case. The second case is a very interesting case. So we always talk about angiofibromas. Angiofibromas have very specific pattern of spread. But in our series, we have now done near to around 500 cases, of course, published. This is the highest number in literature. And you know that we have written a book. But we are still doing a lot of research on angiofibroma. And we found out two important things. Number one, see, in cholesteatoma, you will agree that there are two varieties of cholesteatoma. One is a normal cholesteatoma where you are able to remove the cholestoma in one piece. The second one where it is called infiltrative. Where
Invaginating. Invaginating cholesteatoma.
Yeah, infiltrative, invaginative cholesteatomas. So same way, I am going to describe JNAs in two different aspects. This has not been published in literature so far. And I want to publish that JNAs can have two varieties. One is non-infiltrative, second is infiltrative. This is a new classification we are giving to JNA. First time I'm talking about it. First time I'm talking about it in the world. Now, this JNA was operated by one of the very good ENT surgeons. And this ENT surgeon is very well known to me also. And he has actually done many JNAs. But what happened during surgery was there was massive bleeding. And once it bled, then he packed, he called me. I said, sir, no problem. You can send the patient. And the patient is here as, with the packs, with a lot of packs. Now, what is the problem? Why is the surgeon who has already operated on several JNAs, what made it bleed very badly? So I want to tell you that whenever you look at a JNA, look very carefully at two important places. Number one, three important places. Number one is clivus. So you have to look for because the clivus is filled with basilar plexus of veins. This JNA goes inside the clival marrow and it occupies multiple marrow spaces. And that is the first place where we found infiltrative variety. Number two is the pterygoid wedge. In pterygoid wedge, in some you don't find infiltrative varieties, some you have many marrow spaces getting infiltrated. Number three is the greater wing of sphenoid. So these are the three bones. You can very clearly say that it infiltrates. It infiltrates into these three bones. Not all JNAs do that. There are some JNAs which infiltrate, and there are some JNAs which just actually, become rounded, and you can actually pluck it like a ball. So this is my experience of a huge number of cases, and we have done a lot of research on this, and we are now segregating my 500 cases into infiltrative and non-infiltrative variety, and we'll be doing the publication very soon. So, but
so Dr. Janki, one question. Can you know it before?
The best way to know this is a CECT, not an MRI. So many people see an MRI and read that JNA. You cannot find the difference between infiltrative and non-infiltrative variety. So you can go back, and many are experienced in JNAs. Go back to your CECTs and look for these findings. Now, I'm going to ask Dr. Shiva to present this case, and then I will take over. Dr. Shiva is my very, very, very nice resident. He's here, very smart guy, yet not married. So there are so many girls also seeing.
So if I call you three, is Janki, Satyam, Shivam, Sundaram.
No. We have Dr. Shilpi, who has come from Hyderabad just to assist me. She has come from Hyderabad Center, and she has come all the way. And Dr. Vishal was referred to me by Professor Renuka Bradu, madam. And great. He's a brilliant surgeon, and we are training him nicely to go back to Bombay. Now, Shiva, over to you, man.
Oh,
Yeah.
great.
So the girl's note, he's a bachelor, huh? Yeah.
Afternoon, everyone. Today, the second case is of a residual. The second case for today is a residual zonal nasopharyngeal angiofibroma. He's a 16-year-old male. He presented with the bilateral nasal obstruction for 1 year, and he presented with a single episode of bleeding, which was spontaneous, profuse, and which was stopped by nasal packing. And he was admitted in a private hospital. He was evaluated there, and he have undergone CCT PNS there. They have it shows it shown enhancing mass lesion in the right nasopharyngeal region, in the right nasal cavity, and eroding the sphenopalatine foramen and medial pterygoid plate. They have the patient underwent coblation assisted right medial maxillectomy with the posterior septectomy with segmental resection of the tumor on the 20th of July. The histopathology suggestive of nasopharyngeal angiofibroma. Again, the patient presented with bleeding in the emergency department in their hospital on August 1st, and the patient then taken into general anesthesia, and they have achieved the hemostasis and packed the patient, and patient was being referred to us. While receiving the patient was conscious oriented and his vitals were stable. He was afebrile. He has bilateral nasal packing, and no active bleeding was there or no in the antranasal or postnasal. I hand over mic to Janagram sir to proceed with CCTPNS. Thank you.
Hello.
Yes, sir.
So did you hear the history?
Yes.
Patient was operated, and then after some days, the patient presents to you with massive bleeding. So what are the causes with which I myself have had cases like this? After a few days, maybe 20 days, after 30 days, after 10 days, after 7 days, patient presents with massive bleeding. So what are the causes? Number one is residual tumor. Number 2 is secondary hemorrhage. If you use coblation on internal maxillary artery, I have seen many people, they don't clip the artery. So unless you clip the artery, you might have massive bleeding. Coblation may stop it temporarily, but later it'll get released and it'll start bleeding. So again and again, I advise use either bipolar or use clips. The very important fact I want to convey, because after this advent of coblation, I think this is our 15th or 16th case I'm receiving with emergency bleeding, because they have used coblation on the IMAX, and they have temporarily cut off the blood supply, and after 10 days it opens up and it starts bleeding massively. IMAX bleeding is very bad. So this is the second cause. Don't use coblation on major vessels. If you use it, use a proximal clip. This is my advice to you. Number 3, or you can use a bipolar. Now, the third cause of bleeding is pseudoaneurysms. So aneurysms you can have. I've had 2 cases, my personal cases, because I actually removed it from the carotid artery. Please understand, there are a few areas of the carotid which are devoid of periosteum. So very important. You should understand. The cavernous carotid does not have a periosteum on its lateral aspect or anterior aspect, and that is the commonest site where we pluck the JNA from. And if you do that, there's every chance that you can rupture a feeder vessel, and that can bleed later. Number 2 is the periosteum over the paraclavial carotid. You have a beautiful thick periosteum on the medial surface. You can actually peel it off. We have done transfetus approaches to peel that JNA out of the paraclavial carotid. One person I want to mention now in this talk is Professor Renuka Bradu madam, and I really respect her. The reason is because She has got the maximum number of cases which is done in India. There's no doubt about it. She's formed a new classification. I advise you that you go and see the classification. She has gone into the depths of the understanding of a JNA, and that is really commendable that she has done it. Now, I want to bring to notice that I started demonstrating JNAs way back in 2004. My first workshop was, I think, in 2004, and I am sure people remember in Anand, where I did a workshop, we demonstrated three JNAs. So why I'm telling this is because demonstration, doing a surgery is different, but post-operatively, what happens to the patient? Is he having a bleed? Is he having, all this can be done only when you follow up these patients right in your center. So I honestly believe, you see this CT, you will understand. This is the preoperative CT. Preoperative CT taken. The problem in this CT is that it is a small cut CT. I understand. It's maybe a 2 or 3 millimeter cut. But the thing is, I am not able to get the details of the clivus. So you can see here that the surgery has been done very well. Medial maxillectomy has been done by my friend. You can see the artery here, the which has been, coagulated or ligated. I think the clips have also been used on the IMAX. And then, but what is important is, see here, see the pterygoid wedge. Hey, zoom on this, boss. Zoom on this. Can you see this? Hello?
Yes. Yes, sir. Yeah.
See this side. See this side. This is an infiltrative variety. This is an infiltrative variety. And when I go back, this is the JNA. This is the enhancement of the JNA. It is there in the nasopharynx. So residual JNA is one cause. More importantly, see the clivus. See here the clivus. Can you see here? So you should pay attention to these small details when you do a JNA, because you can have recurrence, you can have due to the infiltrative variety. So this is definitely an infiltrative variety. I'm going to show you during the surgery how we are going to do it. And you can see here, the clivus is infiltrated by the tumor. Okay, fine. So we have a residual tumor in the nasopharynx. You have maybe infiltration of the pterygoid wedge here, which we will see, and also the clivus. So these are the three areas where maybe I'm going to encounter bleeding. I always do an MRA in every patient who presents with bleeding post-operatively. In fact, I had a patient recently, I did it from Kerala, and the patient started bleeding after 20 days. And it had gone to one of my friends in Kerala, and the friend is very close to me. He knows my quality. He phoned up to me and asked me, "Sir, it's bleeding." The first thing I told him is, take an MRA. Why do we take an MRA? To rule out pseudoaneurysm. If you have a pseudoaneurysm and if there is a bleeding, it's an emergency. You have to coil it, or you have to stent it, or do whatever. But so that is one. You might have a keratoco-cavernous fistula, and these are emergencies which you have to manage. Apart from this, if you are bleeding from the IMAX, you can pack a little bit weight. But if you have bleeding from the ICA, then you're going to land up with an emergency. And so I always advise, whenever you have a post-operative bleed of a JNA, take an MRA. Number one, MRA. Number two, CECT. MRI. Okay, very, very important. Can you follow up a patient of JNA with MRI? In my opinion, I have written in my book also, you can read it. I don't advise that. The reason is inflammation, fibrosis, all that can enhance in the MRI. It will give you a very, very pseudo picture. In fact, I had, I think at least 6-7 cases. Hey, I had 6 or 7 cases which were reported as residual tumor after 1 year of an MRI. And when I saw it, it was fully enhancing with an MRI. I said, boss, don't even bother about it. Do a CECT. When I did a CECT, there was no tumor. So don't follow the patient with an MRI, especially if it's a vascular tumor. This is our experience. We have written it in the book also. I think we have that. Only thing is we have not, published all this. Okay, so what is my plan? I told you have to write the plan. Dr. Madhuri Mehta asked me last case, what was your plan? I think she didn't watch me. I always write my plan before the surgery. Dr. Om K, are you there? Dr. Om K?
Yes, am I audible, sir?
Yeah, you're audible.
Yeah, sure, sir.
Now you see here, there's a revision JNA, infiltrative type. MRI was normal, no pseudoaneurysm. Step 1 is removal of the pack. I'm going to encounter bleeding maybe if I remove the pack because the pack has been placed very tightly. So it's like a sort of a semi-emergency which we are dealing with here. And note for bleeding and see where the bleeding is from and control that bleeding first. So and understand that no JNA is a simple case. So this is something which some people say simple JNA, complicated JNA. All JNAs are complicated. Please understand, don't underestimate a JNA. Now, next I will do is I will define the medial pterygoid plate. And then I will start drilling the pterygoid wedge. I will define both the sphenoid sinuses and I will start removing the JNA from the nasopharynx by segmental resection. And then we will drill the clivus. So this is my plan, 7 steps to removal of this tumor. And what I'm going to do now is I'm going to remove the pack which has been placed. This is all the pack. And then what I will do is I will just see the IMAX, whether it's bleeding. And then that's the inferior orbital fissure. I will now trace the medial pterygoid plate. I will drill off this medial pterygoid plate here first and get this tumor. If you have tumor, infiltrative tumor in the pterygoid wedge, and then I will go for the nasopharyngeal part of the tumor after defining the sphenoid sinus. And then finally, I will go for the clivus. So I hope I'm very clear about my thought process, Dr. Omke. Dr. Martha, madam is there. Shall I start the surgery?
Yes. So one question, sir.
Yeah.
So, being a revision case, what is the role of external carotid? Like I mean, in this case particularly.
Yeah,
So,
actually, I think you've got a similar thought process as Shilpi Bhatia. Shilpi was telling me, why don't you do the external carotid? I said it's not required. The reason is because, of course, I would like to have a clamp of the external carotid. This is too small for that. So I don't think I will have a problem. But if it is going to be a massive bleeding, then I would think about using a bulldog clamp. Just clamp the external carotid and go ahead. Of course, we have seen magic. This time, I did a JNA in Dubai. Dr. Syed was there, and he is the witness. And what happened was, it was massive, massive supply from Asnic pharyngeal and all this stuff. So I said, we will take a bulldog clamp and clamp it. And then what happened was, we clamped it. It took around 10 minutes for me to do that. And then we proceeded on to the surgery. After the surgery, believe me, Syed will be watching me here, and it started bleeding. After the surgery, 10 minutes after the surgery, I just, Professor Syed came and told me, sir, it's bleeding. I said, don't worry, just ligate it. And just I ligate it, like magic, it stopped. Like magic, it stopped. So if you have a problem with bleeding inside, I would immediately go, either I pack it and send it, or I would ligate the external carotid. So this is what I would do. And it has worked in my hands for years, years and years. That's why we wrote in the book, use a bulldog clamp. Don't ligate it unless you are sure that you have removed the tumor completely. If you have not removed the tumor completely, in due course of time, it might get bleeders from the internal carotid artery. And so generally we don't ligate it unless we are sure that we have completely removed the tumor. Okay? Right?
Yes.
Right. I'm going to wash up now. 2 minutes, I will join you.
All right.
Okay, I'm here. May I know who are all the moderators? Omke, Dr. Madhuri madam is there or she's left?
I'll just check, sir. I'll check.
Micro Labs?
Yes, sir. We are there.
Micro?
Yeah, sir.
Who are all the moderators for this case?
Same, sir. Madhuri madam and Lakshmi madam and
I can't see them. I can't see them.
We'll check with them.
Okay, now here we are. We are going to start this case. Can you see the endoscopic picture? Please take it off. Take this one off. Can you see the packs?
Yes, sir. We can see. Very tightly packed. Oh. Oh.
Antibiotic wash. Second suction ready. What?
Keep pushing. So all the packing material, can you see that?
Yes, sir.
I think this is the first time case like this is being demonstrated in any workshop in the world. Keep irrigating.
Bigger suction.
Keep irrigating. Keep irrigating.
Warm saline.
Now, when there are no landmarks, how do you find landmarks? Very, very important. I want to tell you how to find the landmarks.
Is that the tumor, sir?
This is the tumor.
Yeah.
Keep irrigating.
That is excellent. I asked Ranga to put some hot saline. Hot saline.
Okay, so can you see that now, please, all of you?
Yes, sir.
Now I have got myself oriented now. I have got myself completely oriented. So what are the steps which I'm going to do? Back. Now you see here, this is the vital thing. When there is absolutely no landmarks, what is it that you will get? You will go and get the landmarks with. So the first step I'm going to do is I'm going to find the lamina papracia. So see that. Hey, give me the camera, man. Put the camera here. Where is that guy? Hey, you pack. Where's the camera guy? Why is it gone out? Hello?
Yes, sir, you're audible.
See, the first step is I will get the lamina here. This is the lamina which I'll get here. Hello?
Yes, sir, we are.
And if I follow it straight back, I will go into the posterior ethmoid and then the sphenoid sinus. So there's no landmark at all, absolutely no landmark. So both sides, I will try to define the lamina papracia. This side, I can see the middle turbinate also here. So
Yes,
it's good. And this side, I'm not able to see the middle turbinate. There's a little cells in the ethmoid. The bulla is there. So I will try to find out the anatomy. So the main thing is to get the anatomy. Unless you get the anatomy, don't go and screw around with the JNA. So the first thing is get the lamina on both sides. So you should have a complete strategy. The main thing is how you are forming your strategy to deal with cases like this. Revision. No, I want smaller one. This very big one. Okay. Now, Lee, give me the debrider. Give me the. This is already there. Debrider, please. Quick. Start. Shilpi. Oh. जल्दी आओ भाई सक्शन दो भाई
Ready.
So there is a small stump of the left-sided turbinate. It looks like the.
So you can see here, this is the inferior turbinate here.
Yeah,
there is a stump here of the inferior turbinate.
Yeah.
And this looks like the stump of the middle turbinate here.
Yes, yes.
So what I will do is give me a ball probe first. So I'm going to get into anatomy. The first anatomical landmark which I can easily get is the maxillary sinus. See that?
Yeah.
Debrider ready.
Debrider, please. Debrider, please. So get. At 40. So don't be in a hurry to get the tumor out. You will land up in problems again because you really don't know what the anatomy is. Absolutely, it is distorted anatomy. Come on. Rat 40 debrider blade. Yeah, thank you. Now I'm going to start with the maxillary sinus. Once I get the maxillary sinus, the next step is to get the ethmoids. Can you see the ethmoids, my dear friends?
Yes.
See, Vishal is continuously irrigating for me. Read the problem. Can you see the lamina papyracea, all of you?
Yes, sir, yes.
Is it clear?
Yes, sir, yes. You are into the posterior ethmoids now, right?
Now I am in the posterior ethmoid.
Yes, yes. We can appreciate.
Straight debrider plate. Suction. So the first I told you I'll get a landmark which will be the sphenoid sinus. I need to get the sphenoid sinus or else I really don't know what's happening inside. I don't want to play around. This is the maybe medial maxillectomy done. That's the maxillary sinus. And you can see here that is a polypodal tissue, but don't worry, I'm just going to go for the left side. I'm getting the ethmoids. Block. Now, the first step, again and again, I say, whenever you do revision cases, get the anatomy. Because you are absolutely lost in this anatomy. Where is the JNA? You don't know. So, one important thing I have found in the recent revisions which I have done is that many of the youngsters, they have started using a lot of coblation. And that has produced a lot of recurrences. I think you should use the coblation only when it is required. And just because you have a coblation, don't ever think that, a JNA is not going to bleed. You have to get vascular control.
So the role of coblation is better in management of mucosa during these surgeries rather than...
Role of coblation is? What?
So the role of coblation will be better in management of mucosa rather than...
Exactly. Not don't unnecessarily injudiously use coblation. It is not advisable. And I see nowadays, just because everybody is like, freaking out with the coblation of the JNA and landing up with, I'm now operating almost every day on recurrences, recurrent JNAs. And I attribute that primarily to the use of injurious use of coblation. See the sphenoid sinus. Now I got the sphenoid sinus. Can you all appreciate that? My dear friends.
Yes.
See the first.
All right.
See, that's the sphenoid sinus here. That's the rostrum here. You can see the rostrum.
Yes,
see
sir.
how nicely we got the anatomy that side.
Yeah.
Suction. Now I'm going for the left side. So the left side I got the lamina papracia. This is the sphenoid sinus, very nicely seen. That is the optic nerve, which is very clearly seen. Now I will go for the right side.
Right.
Okay. Okay, that is actually the sphenoid sinus. Debrider. Now here we are. I'm going to do the same thing on this side. A polyp is sitting here. This looks like the remnant of the middle turbinate. This is the maxillary sinus which has been opened up.
Mm.
The idea is to get what? The lamina papracia.
Yeah, both sides.
Both sides lamina.
Yes.
Hey, suction is not suction. Can you see the lamina there? Inside. Why put your upright? Or shall I do 400? I'll do the 400. See, whenever you find a difficulty, you always have 400. And that is so simple to manage. And believe me, that is the future. If you want to become very good skull-based surgeons, you have to learn 400 surgery. Okay, debrider quick. Now here we are. I'm now going to, I don't know where the nasolacrimal duct is. I'll find it last and do the DCR. Okay, I know that is the orbit, very clearly seen. This is the lamina papracia. Absolutely no landmarks.
Uh-huh.
So I know this is the sphenoid sinus here. This is the posterior ethmoid. See this, a little bit you should have a little experience on doing endoscopic sinus surgery. If you have a case like this, irrigate on the scope. This is lamina. What a case, beautiful case. Hey, block. Now give me the drill. Now this is the sphenoid sinus here. This is the rostrum there. And now what I'm going to do is to start drilling the sphenoid sinus. That's the lamina here. Very clearly seen lamina. And Vishal is continuously irrigating for me. Hey, there's a little camera tilt. Clockwise. Yeah, thank you.
Madhuri ma'am, sir was asking about you. You can ask him.
Hello. I can't hear Madhuri ma'am at all.
Yes, I am here, Dr. Janki. I am here watching you.
Oh, thank you, ma'am. This is a wonderful case.
Absolutely divine to watch your surgery. A very complicated case, no?
Yeah, it's not that easy.
Simple. It is not that simple.
Denberg can all leak.
Yes.
Ready.
So now what am I suction? I'm trying to define the planum. So once I get the planum, I'll get the optic nerves. So these are all this is basic rules of skull-based surgery. The same thing happens in pituitary or a craniopharyngioma. So basically, we should know how to get anatomy from nowhere. And you will see in a minute from now, or maybe 10 minutes from now, all the anatomy will be defined. You will see that now.
Okay.
It's the same like how you do the ear. There is no
landmarks visible, and suddenly when you start clearing, everything becomes clear.
No, wait. Yeah, you can shift. Wait, don't intubate. Shift. Okay, so what I've done now is I've defined the sphenoid sinus completely. This is the sphenoid sinus. That's the planum. Party. So you might be wondering how I'm drilling without knowing what I'm doing. No, I know exactly what I'm doing.
Kindly let us know, Janki, how are you doing it?
It's because
what are the landmarks you are keeping in mind? How are you designing all these steps?
I read the scan so well. That scan is running in my mind.
Okay. Great.
The scan is actually running. There's a big solid piece of bone in the middle of the sphenoid sinus.
Oh, okay.
Maybe I will show it to them. See this bone here, right? This bone here. Just pack it. I'll just show it to them because they'll understand what I'm trying to do. These are all the things which many people do not plan. You see exactly. I'll show you what I'm doing here. See here. Show. My dear friend, you don't go out, okay? Right. See here. Hello?
Yes. Show us. Okay.
Yeah. You see this? There's a small cell here which I opened. There's a little mucosa. And that small cell also I was just wondering. And I'm going to define this. And once I define this sphenoid is gone. I will get hold of these sphenoids. And then I'll come down like this and get the medial pterygoid plate and start drilling this wedge. Everything is by science. Everything is planned, completely planned.
Perfectly understood.
Wow. What happened? Why? Drill. Now that's the piece of bone in the center. And that's the cell you saw.
Yes. Okay.
Now can you orient yourself?
You do it for us. Kindly tell us. Then we will be able to visualizing.
Now this is the small cell which you saw on the side.
Yes. Now we can see the piece of bone there.
This is a sphenoid sinus. Now I'm going towards the pterygoid wedge.
Yeah, on the right side. Yeah.
On the right side. See, everything is planned. See, that's the sphenoid sinus. Lateral wall. I got the lateral wall. That's maxillary strut.
Yes.
This is superior fissure.
And down. Okay.
And I have to go down here.
Yeah.
I know there's JNA there, so now I'm not going to do anything. So I'll go on this side and get the same on this side. But note the completely deformed anatomy. Can you
Yeah.
Yes. But now we can know where you are working. Now it is becoming clear.
Yeah, slowly, it's getting into your system now. Now give me the coblation. Now I got the sphenoid completely. Coblation. So I'm going to take off that polypoidal mucosa from the superior aspect. Coblation, please, quick. Blue. I don't want a rain. It's called rain from above. So Shilpi will find it very difficult to show when I have a rain.
Yeah.
Janaki,
that's a
sir,
planar.
I missed it in the beginning. How many years old is the next revision, sir? This one? After how many years is the revision GNA you're doing?
No. How many days, sir? This is done around 10 days back.
That's all.
And the patient, you didn't even listen to the history. Who is it?
Sir, Dr. Lakshmi, sorry, I had gone for lunch.
Actually, I think you didn't listen to the history. The patient actually underwent the JNA surgery, coblation.
Okay.
And then the patient presented with severe bleeding.
Okay.
Severe, massive bleeding.
It was abandoned. Okay.
In the post-op period of the first surgery. Yeah.
Oh.
Yeah.
Immediately the patient was put under anesthesia and packed.
Okay.
And referred.
Oh. So you're the final destination for such difficult cases, sir. Very good.
No. Ennama. 9-5, please. Am I ready? Now that's the anterior wall of the sphenoid sinus on the left side. The remnant middle turbinate. Is the picture quality clear, please? Is the picture quality clear?
It is slightly hazy, not that beautiful, but yes, it's slightly
little bloody. So
no, it's a little bloody. Of
and
course,
slight fog is also there. It
Don't
is
go
not
inside
absolutely
CT.
clear.
Is it? Why is it fogged? If Flexly, the coblation, please. Sorry.
Maybe washing a bit for a few times can make it clear.
Shilpi, can you do that?
So then it will become, the anatomy will become very clear.
Can you increase the brightness or something? Come on. Or make it clearer. How is it now?
Sir, it is better.
Now, can you see here? Hey, Vishal. Hey, ask somebody else to wash me. No, you're fogging too often. Now, see the rostrum here. Can you see the rostrum here, please?
Yes, sir.
Yes,
drill.
yes.
Drill.
Is the patient referred from another city, sir?
Yeah. Another state.
They came by flight. Ambulance, air ambulance.
So you're drilling the rostrum?
Yeah.
Yeah, okay.
Is that Pawan Singhal? Who is that?
Omkar.
Me, sir.
Okay. Okay.
Yes, sir. Yes, sir. I am there.
He is sounding like Pawan Singhal only.
Yeah. His voice looks like Pawan.
His voice is like that.
Hey, this is the keel. See that midline keel. Okay.
Yes.
Coblation. शिल्पी क्या हो रहा है? Now that's the drill. That's the sphenoid which is completely now visualized. Drill.
Plenum, is it plenum now?
No, this is plenum.
इसमें सेक्शन वाले बच चुके हैं।
Okay. Yeah, Sala. Yeah, sorry.
हाँ, इसलिए क्योंकि अब पैसे भर दिए होंगे तो वो लोग रिकॉग्नाइज कर देंगे।
Hey, shift the next case. Almost done. Debrada. Sorry, cobblator. Tani. Okay, so left side, I am very confident I've removed everything. This is the clival part. Okay, now I'm going towards the main area. The area which is
Right pterygoid. Yeah.
that's where the patient had bleeding. Now, what bleeding is this?
Spinopalatal looks like spinopalatal.
No. That's the median artery.
Oh, okay.
Drill.
Right median.
Bexley. Give me a pack. Give me a pack. Huge median artery.
Yeah.
Bipolar ready.
Is it not accessible for cobblator, sir?
No. First, I have to visualize what I'm doing. I can't go and coblate because it can arise directly from the internal carotid artery.
Okay.
So I should be cut, man. You should see and assess, man. There is no point. No, not now. I can't do now. I have to go to some. Whenever there's bleeding, my advice to everybody here is don't go and fight with that bleeding. Just pack it and then go to some other place. So you will gain time. Give me a coblation. Coblation. Now I can see here. What am I doing now? Suction, coblation suction. So what am I trying to do now? I am trying to get the medial pterygoid plate.
Operation webinar. ತಾತನ ಹತ್ರ ಒಂದು ಸ್ವಲ್ಪ ಆದ್ಮೇಲೆ ಆಮೇಲೆ ಬರ್ತೀನಿ. ಇಟ್ಕೊಂಡಿರು, ಇದು ಇಟ್ಕೊಂಡಿರು, ನಿನ್ನ ಹತ್ರನೇ ಇಟ್ಕೊಂಡಿರು.
That's the medial pterygoid plate. Can you see that clearly, my dear friends?
ನೀರು ಕುಡ್ಕೊಂಡು ಹೋಗು ಅಂತ ಹೇಳಿ ನೀರು.
Janki sir, you can plug your coblation with another plug because whenever you are doing coblation, picture is going.
Yeah, when you use the yellow part, it's going, sir, actually. Yellow, yeah. I mean, coblate mode, yeah. Now it's not going. When you use the...
What is the other plug? I don't understand. What other plug?
Please change the coblation power source. I mean, he wants to put it on another plug. Sir, but Dubey sir, it might not help actually.
Okay.
Can you see the pterygoid wedge, all of you?
Yes,
again,
sir.
Picture gone.
See how it's bleeding from the pterygoid wedge, my dear friends.
Yes, sir.
I told you the infiltrative varieties.
Very difficult area.
Very, very tricky. தண்ணி இல்ல drill. Drill, please. Now I'm going to remove this. Okay. Now this is the trickiest part of the surgery. Drill. Go inside. Go inside. Give cobblator. Cobblator. Go inside. Blue. Bipolar. This is the clival part. Clival recess. I told you clival part is going to bleed. That's the clival part. This is actually going into the clivus. Not too much. Just a little. Pack. In the back, it's a very small pack. Power. Good power. Cut. Okay, where is the pterygoid wedge? Yes. Ah. Drill. Ready.
No, it's dilemma. I cannot stand.
Now I'm drilling off the pterygoid wedge. You have any doubts, any questions? Keep talking. Okay.
So we are spellbound, we are watching.
It's not
The
an
way
easy case.
the way you're dealing with the bleed.
Give me Blexley now. Go inside. Drill. Drill.
That's the
It's
tumor.
all residual tumor.
Yeah.
This is the intratemporal fossa. No,
Yeah.
sorry, pterygo part and fossa.
Greater wing, no, sir, we are going to the greater wing.
Oblata. See, completely distorted anatomy.
Yeah.
See, there's a clip already. Can you see the clip here? Here.
Yes, sir. Yes. Yeah. Yes.
We can see the Liga clip.
Give me a drill again. Drill. See, whenever there's bleeding, don't hurry in trying to control that bleeding. Just expose more. Oblata. Whenever there's a carotid bleeding, don't immediately go and try to catch the carotid. Give the cobblator. Just expose proximally and distally. That is very, very important. There's no anatomy, absolutely distorted, completely distorted anatomy. This is now the maxilla.
Yeah, the posterior wall is getting exposed. Yes.
This is the posterior wall.
Yeah. This is fat, right, sir?
No, that's tumor.
That's tumor. That's what, sir. We are not able to make out. That's why I asked.
This is tumor.
No.
Oh, see, there's bleeding. Ma,
Yeah,
na,
yeah.
pudu coblation enama? Why not? Give me bipolar. Bye.
I put switch.
Make it 60. See, when coblation doesn't work, the best is the bipolar.
Yes, sir.
Believe me, this is a wonder tool, bipolar. Okay. Now, coblation.
All the revision surgeries this difficult, sir?
No, not like this, but some are difficult, not all. This one is like, it's infiltrative variety, right? So it will be difficult.
And
See the clip.
probably piecemeal resection in the first stage would have resulted in.
Yeah. A little bit here, a little bit there, then it becomes difficult for us.
Correct.
Yeah, in primary itself it's difficult. Drill.
On the top. First time.
Now, cobblator. Shilpi, can you make it a little bigger? He wants Satya to wash up. Finding it difficult.
What finding? She finding.
Oh. Okay.
Me.
The clip has been put here. Huh?
Get the message.
Give me the ball probe. Now you need see there are two clips. Can you see the two clips which are put?
Yes, sir.
Now what I am trying to do is to go more proximally.
Yeah.
To get the IMAX.
Oh.
See that's the IMAX here. Give me the clip now. Yeah, this is IMAX. No. Why? Now you're happy. Hey, take that out. Take that. Give clip. Population. Yeah. Hey, suction podra. Why are you watching me like this? Both of you. Hey, Siva, நீ watch பண்றியாடா?
Let me put suction from the eye. will not play.
Hmm. Hmm. Give me one more clip. எவ்வளவுமா இருக்கு 9.5 இருக்கா இல்லையே 9.5 இருக்க மாதிரியே தெரியலையம்மா
You don't know where you are, so just be suspended in the air. Now you can do it.
That looks like the V2. தண்ணியே வரலமா
Unlock. 20, 15.
Why on? All residual tumor. Oh, that's a lateral pterygoid plate. You can see here, that's a greater wing of sphenoid. I'm trying to get that plane for me. Yeah, if I take this out, then I'm done, full. So I'm almost done. So that's it. So almost done the whole case. You can see here that this was the problem. Ma suction, ma please. Now you see here that was the problem. The median artery also was a big artery. Drill. LP. Can you change the scope then? Hey, get that scope here, man. Drill. Coblation, please. Ma, pudu scope eduma. பண்ண குடு சக்ஷன் குடுறி மா coblation மா coblation தண்ணி That's V2. I'm not bothered about the V2 and all now. I just want to get out of this without any bleeding. Already the V2 is already gone for the patient. So this is residual again. Okay, now that is the pterygoid wedge. You can see here, I will show you the anatomy now. See, I've drilled here, the pterygoid wedge here. This is the V2 here. You can see here, elevator please, elevator. That's the median here. This is the median here. See, I'll show you the V2. Okay.
Sir, we are watching.
This is the V2. Can you see the V2 here?
Sir, somebody pressing the cobbletter on the other end.
Hello. This is the level of the median.
Yeah.
Drill. And now I'm going to find a big artery in the median, which might bleed. Ready. Now I have to drill between the V2 and the median. So never go along the lateral aspect of the V2. This is very, very important.
Irrigation over.
Irrigation, please. Now that's the pterygoid wedge drilling now. That's the V2 here. That's the median here.
Oh.
It's hazy. I don't know why it's hazy always.
I've done everything.
Is somebody using the cobbletter behind?
Cobbletter, no. Why?
No, the picture was going and coming. Now it's okay.
See, now I'm drilling the pterygoid wedge. Can you see that?
Yes, sir.
This is the lateral pterygoid plate.
Yes, sir.
Now this is around the median.
Yes.
This is the infiltration. Give. See the new scope.
Okay.
Scope தூக்கி போட்டுரு.
That is all residual, sir.
Yeah, it's all residual.
Yeah.
Can you see it going inside the pterygoid?
Yes, sir. We can see it getting out now. Yeah. Yeah.
Sure.
Yeah.
Give me black sleeve. Okay.
Take the butt.
Give me a black sleeve, please. Now I'm just going to take a little bit of it and then show you the anatomy, or maybe later I'll show you. Now you can see here. This is the medial pterygoid plate.
Yeah.
Okay. This is the pterygoid wedge, completely drilled. You can see.
Yes, sir. We can see that healthy
drill. Now I'm going to drill off the medial pterygoid plate completely.
Okay.
See the JNA going inside. Small JNAs are sitting inside. See that?
Yes.
So as long as I am below the median, I'm not
Near the
I'm not
current.
afraid.
Yeah.
So I show the V2 kind. V2
Yeah.
is here, so median should be here. It's all residual. Okay, having done that, now what I'll do is I'll take off this main JNA. That is not an issue, but then the clivus is going to bleed. Give me a elevator. Now I drilled off the pterygoid wedge. Now I'm going to take off by what is called the rolling up maneuver. We have described that. There is a JNA here.
Yes, sir.
Can you see that, my dear friends?
My God, yes, sir.
This is called the rolling up maneuver. Always do the rolling up. பெருசு குடுறா. No, இதோட பெருசு இருக்கு. Now I use my thick Freer's elevator to do this maneuver. No, it was infiltrating into the pterygoid wedge. Did you?
On the other side?
No, not the other side. I've already drilled the pterygoid wedge. No. Yeah. Now you will see. The clivus is infiltrated. You see that? Now, this is too small, man. Give me. This is too small. The problem is it's too not long.
Not long, thick and long. Master elevated.
Give me a black Takahashi. I can take the Takahashi and give a gentle pull, but I'm sure that I'm going to retain the clival part of it. That is going to bleed again. The whole thing you can see here, the nasopharyngeal part, and I could see that in the scan also. No, who is this? Now I use my thick Freer's elevator to do this maneuver.
Super Janki Super.
Me? Don't tell me.
So that was a comment from Dr. Sanjay Agarwal, sir.
Oh, Dr. Sanjay, sir. Now you still see that's actually the nasopharynx. Now the thing is, I have drilled off the pterygoid wedge. I have to now make sure that the clival part is out. That's very, very important. Because according to the scan, there was involvement. See, it now you see this is the pterygoid wedge here.
Yes, sir.
This is the sphenoid sinus here.
Yes.
And you can see here that this is the JNA, residual JNA, and you can see that this is the nasopharynx. None of my instruments are working. No, no.
Look at the friable thing, sir. The remnant looks friable. It's
Yeah, because it's been manipulated, no?
yeah, the grip is not well.
Primary JNAs are far more easier.
Yes.
Not like this. This is like ma வேற லக்ஸ் இருக்காமா வேற லக்ஸ் இருக்கா Well, see, this is going inside the clivus now. I have to take that completely, or else this is going to recur again. See, the idea is to see normal bone after the surgery. This is the main part of the whole procedure. This is not actually friable. It's actually coming out in bits and pieces. Give me a pack.
Sir, is there any role for alternative treatments for this, like radiotherapy or anything?
I always say a person, sorry to tell this, who does not do a complete job only resorts to such things. Number one. Number two is, if you wantonly leave it on the carotid where the patient doesn't give a consent for you to do it from the carotid, then you are justified in leaving. Then you can give. But young patient, why do you want to give radiotherapy? Gamma knife, all that is reserved for people who can't operate this completely. Give. Now drill. Now what I'm going to do is to completely first give me coblation. Now see, that's the clival part. That's the clival part. இல்ல வேணாம் இதே கொடு வேற கொடு இது கொடு பிளக்கஸ்லி குடி தகாஷி இல்ல nothing is holding. Oh, sure. The idea is to make sure that every bit of it is removed. See how it's going inside. All the crevices are being involved. Give me drill. See that again, it's still there. This is the problem with the infiltrative variety. Believe me, we have seen n number of cases like this. Drill. So always take a CECT, read your scan properly for pterygoid wedge, clivus, and also the greater wing of sphenoid. No, I put that scope as this one, man. Don't use that scope. So this is what I saw in the scan also. You see that? Either this is marrow of the clivus or this is residual JNA.
बंद कर दो बेटा, एक मिनट रेस्टोरेंट बैठा
ready.
Go inside. It's all JNA. Little fat also is there, marrow. I know what you're talking. Don't worry. That's the clivus. The clival marrow. Now give me coblation. Can you see that? That's a pterygoid wedge. That's a clivus. Can you all appreciate it, please?
Yes, sir.
Okay.
Yes, sir. Yes, sir. We are watching.
Now I'm going to take off this part, which is the final part of the tumor. What is this? Throat packer. Oh, give me coblation now. Now I'm going to do it like adenoids. I'm going to take off completely the
Mucosa of the nasopharynx also.
yeah. I will not hesitate to take it till the level of the longest capitis. Ma, give me a new coblation, ma. Give me a new coblation, ma. No, give me one more. No problem. I am not able to. Because they're not trusting the water. That is the problem. See, when I use, they should trust the water. They don't do that.
Flush करना मत.
Sure. So please show. Hey, the next case is ready because the foreign group which I started, they wanted to see a septal correction. See here. See how the JNA is going inside. So bloody. Still JNA is there. Give. Takashi. This is all JNA. Is this holding? Not holding, man. Not holding, man. Clean. Now, okay, that is the buccopharyngeal fascia. This is JNA, yes. But that's the fascia. You can see that very nicely. Can you see how I'm removing all that from the nasopharynx?
Yes, sir.
Okay.
Yes, sir. We are watching.
Madhuri madam is there, huh?
She told sir she had to leave at 3 sometime before she left, sir. 10 minutes before.
Okay, lovely. Now I think I have removed it completely. Now coblation. Done. This is just adenoid. புதுசா தண்ணி போடலன்னா திருப்பி இன்னொரு காம்பினேஷன் தான் எடுக்கணும். See how it's all. Water only should be there.
But sometimes this nasopharyngeal area also bleeds very profusely.
Yeah, but if you remove it completely, then it will stop.
Okay.
If you remove this completely, it will stop. Or else it will keep bleeding. See, I have removed it completely. Absolutely completely. See the bone there.
Yes,
Basic occiput base sphenoid bone. I have gone right till that.
Yes.
This is just adenoid. You don't have to do adenoidectomy and all. It will regress. These are all secondary changes because of stasis of pus due to stasis. So I am now very confident that I have removed it completely from the nasopharynx. There's a little bleeding here. Give. Wait. I'll just take that. தண்ணி போடலனா திருப்பி தான் பிளாக் ஆகும். See, again it's blocked. These girls, I'm telling you, are crazy people. Drill. So I'm going to drill off. Yeah. Drill. I'm going to drill off this medial pterygoid plate. Don't irrigate. There's some bleeding point here. Okay.
But your drill and irrigation system is very elegant.
Yeah, this is Karl Stores. It's lovely, actually. The problem now is that the Karl Stores, they're not producing anything because of the semiconductor, something they're telling. Price is not available, this is not available. Massive shortage.
And they have increased price also.
Double. Or maybe huge. That is because I think they're not able to supply.
Even minor repair, they ask lakhs of rupees.
Correct. Now, what are the things you should see at the end of this procedure? Very, very important. You should see the median nerve. So I'm going to show you the median nerve. Then the V2. Okay, now let me show you the anatomy now. Now, lateral anatomy, I'll show you. Dr. Dubey, sir?
Yes, sir.
Now, I'll just show you the anatomy of what we have done. We have removed the tumor 100%. There's no doubt about it.
Yes, no doubt about it.
Now, I'll just show you. Give me the ball probe. I want to show the median. See, this is the V2. See here. Come out. What is it? This is the V2 here. Can you see here?
Yes. Yeah.
Here. This one. Go closer. See that. This V2. Can you see the V2 here clearly? This
Yes,
V2. And this is the median artery. Go closer. Median nerve and artery. Can you see here? Here.
Yes, very clear.
This is median. That is V2. This is the pterygoid wedge which has been. This is the tensor levi palatine muscle. TLP. That's the tensor levi palatine muscle. And this is all adenoids. The adenoid tissue is here. All adenoid tissue. Of course, we can remove that if you want. I will do that last. This is the basi-occiput, basi-sphenoid. This is the clivus. I drilled the clivus completely.
Yes.
This is the sella here. This is the sella. And above is the planum. So we have done a complete job. That's median. I'm just going to put some coblation there. Just to coblate the median artery. So that it doesn't bleed in the post-op period. Go closer. Blue.
The bleeding has come down significantly now.
Yeah, now bleeding is not there now, completely. See, I told you there are 3 reasons, right? One is residual tumor. Second is pseudoaneurysm. Third is opening up of this is a tensor levi palatine muscle. So if you leave behind residual tumor, then you will have bleeding. There's no doubt about it. So here you had massive residual tumor. Do you agree with me?
Yes, sir.
Yes.
So this is just the adenoid which I'm removing. So it doesn't block the airway. Now you see how nicely we have completely just coblate this adenoid part. Wonderful case. Do you agree, sir? Dr. Dubey, sir, nice case.
Yeah. And we
Most
were
difficult
really,
and challenging case.
Yeah, very nice.
And we were Actually, I'm speechless and spellbound by your. I'm seeing the whole case, but I was not able to talk because we were so engrossed in your surgical skill. Excellent demonstration, sir.
Sir, all your blessings, sir.
Most
Okay,
difficult and challenging case, sir. Hearty congratulations.
Yeah,
Could
I'm
not
going
have
to
been
start.
done
You
by
start.
anyone else other than you
Okay.
or Satish.
Now again, see here. This is the. I'll go here. This is the adenoid. Aesthesion tube. Aesthesion tube. This is tensor lever palatinine. Aesthesion tube is here. V2 is here. VDN now is
VDN is
here.
here.
Go closer. Go closer. This is the VDN here. This is the carotid here. This is the carotid here. Clivus is here. This is nasopharynx. All that completely removed now. Okay. So that's
Right.
it. Thank you very much. That's the final view
Great,
you
sir.
get. Yeah, I'm just going to the next case. A simple case. I'll finish off with a simple case. And that case is a case of septal deviation and with a turbinate hypertrophy. So I'm going to show what we do for the turbinate and how we do our septal correction.
With endoscope.
Yeah, endoscope. Huh?
Okay.
Enough.
Excellent demonstration of the most difficult case, sir. Hearty congratulations. Thank you very much for the whole extensive procedure, meticulously done.
Great demonstration, sir. So, how will we follow the case now? Post-operatively?
I think Sarah's gone to next theater to set up.
நல்ல பிரைட்டா இருக்கு, அது ரொம்ப டல்லா தான் இருக்கு. ஒயிட் பேலன்ஸ்.
சார் நீங்க நான் ஸ்டாப் லஞ்ச் எல்லாம் பண்ணாம சாப்பிடுறீங்க சார், இப்போ ஒர்க் பண்றீங்க சார்.
ரெடி. ஹலோ,
we can hear you sir.
வா லைட்ஸ் கொஞ்சம் குறை, லைட்ஸ் குறை, லைட்ஸ் குறை. போதும், கரெக்டா இருக்கு. ஹலோ,
Yeah, we are there.
We can hear you sir.
this guy is new, not good. This guy is new. Audia. He's stammering.
Everything. Laptop only he got.
Yeah. Maybe you should arrange for 2. சூப்பரா இருந்துச்சுல்ல? ஏன்னு பயங்கரமான கேஸ், பயங்கரமான கேஸ் சார் அது. செம்ம கேஸ் சார் அது. சுத்தமா ஒண்ணு பார்க்கும் போது ஒரு அனாட்டமி இருப்பே இல்லாம அங்கேருந்து கொஞ்சம் கொஞ்சமா இல்ல ஃப்ரெஷ்ஷோ இதோ வாட் எவர் இட் இஸ் சேலஞ்சிங் கேஸ். ஏன்னா இன்ஃபில்ட்ரேட்டிவ் வெரைட்டினாலே சேலஞ்சிங் கேஸ் தான். இதை பண்ண முடியாது சார், யாராலையும் பண்ண மாட்டாங்க. they'll leave behind again the patient will have recurrence. அதான் பிரச்சனை.
அது DNA இது பண்ணுறது என்னால பண்ண முடியாதுன்னு பேக் பண்றதுக்காக DNA எடுத்து பேக் பண்ணி
அப்படியா?
சரி,
ப்ளீட் ஆகலையா?
இது சத்யா கேட்டுட்டு
ப்ளீடுன்னு அவன் சொன்னான், என்கிட்ட சொன்னது அப்படிதான் சொன்னான்.
நான் வந்து
இல்ல இது இனிமே நல்லாயிரும் சார், சூப்பராயிரும். What my dear friend?
Sir, you're on live, sir.
Okay. Okay, ready? My dear friends?
Ready, sir.
Hello?
Yes.
Yes, sir.
Yes, sir. We are just coming out of the last case, sir.
Onkar, huh? Onkar.
Yes, sir, obviously.
So
I know what Shilpi must be saying there.
No. Actually, you see, these are all cases we face and we should get out of it and keep going. That's it. Finished.
So, but the way you managed the video was amazing, sir, because otherwise anybody of us would have gone behind it, chased it, actually.
Yeah.
I mean, that is the one thing that we learned from this case, sir, actually. Obviously, pterygoid drilling, every surgeon has to do post JNA.
Yeah.
But the way you managed the video, that was amazing, sir.
So actually, we should understand that there are 2 varieties of JNA. First is called the normal variety and second is infiltrative variety. If we understand that, then that carry home message is conveyed.
Yes, sir.
Okay, now I'm going to start this for the sake of the international group, which I've started. They wanted me to show a septal correction. We have a lot of cases in the ward. I selected this. You can see here that's the nasal endoscopy. Can you see the deviation, Dr. Omkar?
Yes, sir.
Very nice deviation. And this side, the patient is complaining of nasal blockage on the right side because of paradoxical nasal obstruction due to inferior turbinate hypertrophy. So I'm going to do a septal correction and I'll show how to manage the inferior turbinate. So the first step in septal correction is I infiltrate at the bottom like this. I infiltrate at the bottom. This is just normal saline. I never infiltrate anything else other than normal saline. This is called blanching. You can see beautifully the blanching. Some more. So here again on the other side, I infiltrate where the other side you have a deviation. So that is where I might get a tear. So I want to infiltrate nicely. See.
Yes, sir.
This is hydrodissection. Can you see the hydrodissection?
Yes, sir.
See. Wow.
Yes, sir.
Some more. So that is hyd. Always make the incision on the convex side, not on the concave side. This is, I think you should go through our paper which we have presented. That is by Uday Chanukya.
Yes, sir.
On modified novel technique of Royal Pearl. Technique of septal correction. See how nicely we are infiltrating and rising that plane. That's very, very important. Once you rise the plane like this, half your dissection is over. Then the first step, see, anteriorly itself you have deviation. You don't need to use the headlight. Many people use the headlight. Don't use the headlight. You don't need to. You just have to be thorough with your endoscopic approach and then make that incision. Make the incision with on the skin. Very, very important. I saw one recent video, somebody was making L-shaped incision and all. All that bakwas you should not do. Don't make L-shaped incision. All that you should never do because you might have a tear and that will lead to a problem. Now, the next step is, you see here. Now, Shiva is helping me. See, I have gone into the plane straight away. The first step is push. The second step is elevate. So this is the first step which I am pushing. And then what I do is I make Shiva go inside like this and keep that like this. See now he is keeping the suction. It's a three-handed technique. Very beautifully seen there. Nicely seen. Some people use the suction elevator. I don't use the suction elevator. I don't because I see there's a small layer. Don't worry about that layer. I will get that shortly. Now hold this. Now give me a knife. Now having done that, I create what is called the septal window. It's called a septal window. See here. Now automatically it will come. Don't worry. Some people strive for that layer. I never do that. So leave a little bit of the septum here. Slice the septum. Don't cut the septum. Slice the septum. We never use the headlight. You cannot find headlight in Royal Pearl at all. In any other Royal Pearls, whether it is Hyderabad or now we are starting Chennai also, you will not find headlights here. Now, having done that, now see here, I'm just going to rise. No, don't do that. Do just. Now I go to the opposite side. The main thing is I have to save. Take it out. Now come this side. Come this side. Come on. Irrigate. You have to wash up, man. When there's a conference, you can't tie your hand and stand there, Satya. And Ranga is not able to irrigate. Take it out. Gently take it out. Suction four. Not used to this cottle. Problem is I'm not used to this cottle. Take it off. Take it off. My elevator has not come. இல்ல ஒரு கான்ஃபரன்ஸ்னா என்ன வேணா பண்ணலாம்னு நினைச்சுக்கிறீங்க, அதான் பிரச்சனை உங்க கூட. Hey, don't trick. So I've gone till the floor. Can you see that very clearly, my dear friends?
Yes,
Hello?
sir.
No. What do you... Hold. Irrigate. Now, irada. அவசரப்படாத. Right. Hold. Wait. Now I'm going to create a septal window here. People are now doing all sorts of rubbish. Hold, Satya. Now, this is what is called the septal window. See what I'm doing now. I'm going to take off a little bit of the septum. Not much. I'll just take a little bit of the septum. Scissors. So, this is the technique which we published. You can see here, this is the septal window. Why do I create a septal window? Because this 4mm endoscope will have a nice space to sit. Now give me a Blackesley. So I create a small window, a pocket. That's all. Now you see what's happening now. My life has become so easy now. Come out. Now this side I've elevated right till here, no tear at all. Irrigate. Very simple. That's all. Finished. So you always elevate the other side. Nowadays there's nothing like septoplasty, SMR and all. It is septal correction. That's all. Suction block. You were holding it. Now you see what I'm doing. See here. I want to show you something. Now you see here. This is the deviation. Okay. Don't elevate on both sides of the deviation. You will cause a tear here. So first you elevate here. The upper part alone. Suction. First you elevate the upper part alone. See here. Suction. Don't pinch unless I tell you, my dear friend. Who is doing that? Hold, my dear friend. என்னடா ஆச்சு உனக்கு? என்ன ஆச்சு உனக்கு? Now I'm elevating above only. Take it off. Now I'm elevating above only. Don't go below, my dear friend. That is the commonest cause for the tear. People might ask, one side tear, what is the big deal? You are defeated by the septum. This is what I call. As a surgeon, you are defeated. Number one. Number two, if you want a hard flap, in such a case, then you should take it intact. So you practice without making a tear. If you're a skull-based surgeon, you have to practice without making a tear, especially endoscopic septal correction. Now you see, I have removed the upper part alone, and I didn't use lux. I used the scissors to cut it, and this I call as the superior osteotomy. Wood. Pinch. Now I call this as the superior osteotomy. Having done that, now how do I deal with this part of the septum? How do I deal with this part of the septum? This is a deviated part of the septum. I don't want a tear here. How do I deal with it? Very, very simple. Now what I will do is give me a knife. You see what I do. This is a thing which we actually wanted to publish The reason why we wanted to publish is don't make a tear even if there is a spur, massive spur. I think Omkar, you have seen me doing many times.
Yes, sir.
So see here, what I am doing now is I am trying to create a small ledge-like pocket here of the cartilage in a septum. Okay, I am not elevating on the other side of the septum. I am elevating on the non-deviated part of the septum. This is the most important thing. Give me tuck. Give me tuck.
Malatanguj.
Ah, correct. Now see what has happened. You should understand the septum first. You see here, what has happened is this septum has got dislocated from this bone. Can you see that clearly? See. Can you see?
Yes.
So now we are trying to take that cartilage away from that bone. And then what I'll do is I'll make a osteotomy below. Give. Tuck. Chinnadilla. Right that. Cut. Cut. Not good. Now you take a 4 millimeter osteotome. Tap. Wait. Tap. Okay. Tap.
Tuck.
Tap. Okay. Now what I've done is I've created a small osteotomy inferiorly, like this. I've created an osteotomy. Tap. Now it's almost free. Okay, right. Now what I will do now, you see, I've created the septum is above and I've created an osteotomy below. So this bone is almost free. So leave that cartilaginous part and take off this bony part. I'll take it off.
Pushing it medially, not laterally.
Push. Don't elevate, push.
Yeah.
Don't elevate, push. You get the point? See, by doing that, what did I do? I didn't produce a tear at all.
Excellent, sir.
I elevated the bony part. Can you all see that now? My dear friends, see the spur. Omkar.
Yes, sir.
Now I will show you here. Wait. I'll go outside and show you. There is no tear at all. See here. There is no tear. Can you see here or not?
Yes, sir.
Absolutely no tear. Now what I will do is I have to take off this cartilage. Once I take off the cartilage, the septum பிடிச்சுக்கோ. ஏன்டா அங்க ஒன்னு பிடிச்சிருக்கு, ஏனடா 3 பேர் சேர்ந்து பிடிக்கிறீங்க, என்னடா ஆச்சு உங்களுக்குலாம் இன்னைக்கு? Please. Now what I will do is I will elevate the cartilage. Now I can elevate the cartilage because there is nothing at all. Now you see here.
Yes.
You also push. This is also push.
Yeah. Below or above. Yeah.
Wait. Hold. The problem is the suction can produce a tear. The problem is these guys have to hold the suction. And the suction, if it is powerful, per se can produce a tear. Now see that. That's the cartilage coming out. Can you see here, all of you?
Yes, sir. Excellent.
Finished. That's all. See the cartilage.
Yeah.
Now,
yes.
what I will show you now whether there is a tear or not. There is no tear, but still there is a little deviation here anteriorly. Posteriorly also there is a little deviation. So I have to take tuck here.
Yeah, maybe it is a crest. Yeah, down there.
புடிச்சுக்கோ நல்லா புடிச்சுக்கோ புடு லேசா புடி சக்ஷன் ரொம்ப பவர்ஃபுல்லா இருக்குடா வெரி பவர்ஃபுல் சக்ஷன் irrigate good லேசா விடு லேசா now that's the cause irrigate that's the posterior part which is deviated. You can see that very beautifully.
Yes, sir.
Now what I will do with that is I will elevate now. Always elevate. That is very, very important. You elevate it and then push. Don't scissors. That is bone, so scissors. Always push. Don't elevate. Suction apudi.
Around the rostrum, no, sir. No, it's almost on the spine.
Near the rostrum, but not on the rostrum. Wait.
Like the keel. Near the keel.
Wood. Scissors. Always create osteotomies. No, today he is not in form because tomorrow he is leaving. Hold. Kuda elevator kuda. Elevator. ஏதோ ஒரு எலிவேட்டர் கொடுப்பா போனை எடுக்கிறதுக்கு புதுசு தானே பெருசு தானே கொடுப்ப again push only Omkar.
Yes, sir.
Very thick.
Yeah. Sir, I think we have to disengage from below also. I think.
Give me a lux. Quick. That's the rostrum only. That's the rostrum only. You don't have to delineate. You just have to break it with the lux.
Yeah.
Come out, go inside, and then hold it properly, and then break.
Yeah.
Yes. Now I have to have a small anterior deviation. See that? Now completely it's gone. You can see the septum is in midline except here. Now I will take a Manhattan gooch and I will take this out.
Is the crest? No, sir. The crest part.
Tuck. See that? You don't even have to take it out. You just have to gouge it and leave it like that.
Got it from there, yeah.
Now you see the septum now, how it was before and how it is now. Completely straight. I just have to push the inferior turbinate and that's it. So that's the kind of septum I expect out of my students. So here, this is just mucosa. There's no bony, this one. I just have to pack it. It will become all right. And this side, that's the turbinate. I'm going to show you how to do the turbinate on the right side. Just one side and then Satya will take over. Okay, now I'm just going to show because many people abroad, they wanted me to show how we do with the turbinate. In fact, this time when I did in Dubai, there was a lot of bleeding. No, I need a 50% reduction.
Debrider ready.
Give one more. So how do I deal with the turbinate? See, the main problem with the turbinate, I will tell you, is this part. The anterior part of the turbinate is the problem part. So what you do now is, the first step is you debride away the anterior part. So you see what I'm doing now. Ma pudichuko, because it will flap. Okay, ready, start. So this is the main culprit of the deviation in the turbinate. So only the anterior part. Okay, right. Coblator. Now the next step, what you have to do? Coblator. Ilya. Kuda. Suction kuda. Irka. Ma, coblation foot switch yaar marka. Yaar ma kidhar ka. Beulah just okay, so I have done that. So the next step which I have to do here is I am going to elevate the flaps. See what I do now. Action. Hold, my dear friend. Now give me a elevator. Give me my elevator. Quick. Now you see, elevate from superiorly. See here. Elevate from superiorly. Now that is the elevation here. Hold more. See here, I have the luxury of 400. I'll straight away go for the 400. What is the BP, man? ஏன்டா இப்படி இருக்கு கொஞ்சம் கொஞ்சம் பண்ணேன்டா நல்லா இருக்கேன்டா என்னாச்சு உனக்கு
பண்ணிட்டு இருக்கேன் நல்லா போகணும்
அதான் இல்ல So when you get the plane, it becomes so easy. See, I got the plane. Can you see the plane there?
Yes, sir. Yes, sir. Oh, wow.
The only problem with the turbinate bone is it's irregular. Can you see?
Yes, sir.
This is the lateral wall of the turbinate. Can you see here clearly, my dear friends?
Yes, sir. Inferolateral one. We can see.
See how 400 is so easy. You can actually use the suction. You can play around with the nose boss.
You're separating and removing the bone it only, right?
Yeah. I'm removing the bone. Hey, calm it down. I'm removing the bone, my dear friend.
Yes, sir.
Okay.
Yes, sir.
Now, give me a scissors. Now, what I will do is I'll cut the turbinate exactly in the middle.
Okay.
Why do I have to cut it? Because I don't want the lateral aspect. The lateral aspect doesn't take part in the, and doesn't have nerve endings also. Can you see that very clearly now?
Yeah, yes, yeah.
I have cut the inferior part of the
Lateral aspect, yeah.
Okay, having done that, I've gone right till the posterior end and give it a Blexley now. I'm going to remove that bone now. I'm going to remove that bone now. Once I remove that, Satya, Kami. The bone is still not separated. Come on, Satya. Come on. Now I'm just feeling for the bone there. That's the bone here. You can see that very clearly, the bone. Give me a scissors now. The most important thing is to preserve the elevator. Preserve the mucosa in the medial aspect. My dear friends.
Yes, sir. Tissue respect is one thing that, inferior turbinate, who would have thought, sir?
What? I don't understand. What did you?
I meant, sir, one should learn tissue respect from you, sir. That is the one thing from day one you have been teaching, because mucosa is gold.
Yeah, mucosa is gold, correct. See now how nicely the bone is coming out. Can you see?
Yes, sir.
Figures.
This is inferior turbinoplasty in true sense.
Inferior turbinoplasty?
In true sense.
What in?
In true sense. In its true sense.
Yeah, in true sense. Correct. Now I'm just taking off that bone now slowly. I will show you another technique on the other side. That's far easier. This needs a little, it's not an easy technique. What I'm doing now is not at all easy. If you think it's easy, then
one who has worked with inferior turbinate will know that, sir.
Definitely. Exactly. Now, the posterior part of the bone, please understand one thing. It doesn't take part in nasal resistance. Many people, they actually want to cut it or remove it. It's not required. Why? Because it doesn't take part in nasal resistance. Now, having done that, you see now what is happening now is, give me elevator, big elevator. See, I preserved the mucosa on the lateral aspect a little. Why? Because I didn't want to create a synechiae in the nasolacrimal duct area.
Yeah, inferior meatus. You don't want to.
See here now. See the kind of this will go for fibrosis and it will look beautiful. At the same time, there will not be any problem with empty nose. Nothing.
Moreover, crusting will also be less, and
no crusting, no bleeding.
No bleeding. Yeah, that is.
Bleeding is because bleeding is because the artery comes from posteriorly.
Yes.
The inferior turbinate branch comes from posterior. So, but we have not touched the posterior part at all. You see how now the whole thing is rolled over. Can you see that clearly now?
Yes, sir. Excellent, sir.
Now, this is the flap laterally, and that is actually, you can put it like this.
Wow. Nice. Great.
That's it. Now, I will show you an easier technique, far easier technique. I know you would be thinking, why the hell did he do such a difficult technique, Kableshan Guru?
So, this is a good exercise to raise the inferior turbinate.
What?
This is a good exercise to raise the inferior turbinate flap.
Lateral nasal wall flap. Correct. But I'm telling you, there are some people who want to take it light. They are not skull-based surgeons. I will teach one technique for them. One is you just lateralize it like this and do what is called island coblation. See what I do now. You go posteriorly. Coblate.
But this is a relatively temporary thing, sir. Actually, the one which you did on the right was kind of permanent. I mean, here, this, after 6-7 months, it might come back.
It's not as effective as the other one, but it is for people who say that's very difficult. But more importantly, the anterior edge. This is what is the most important thing. Take off the anterior edge with the yellow.
Oh, okay, sir.
If you take it off, then you will have a good relief. See, I'm using the yellow now, not the blue.
Ah, yes, sir.
So the anterior edge is the most important because that's the inner nasal valve. That's it. So you see here how nice now. Both sides is totally different.
Initially, sir, yes.
See this one. Airway which I have. Beautiful airway. So give me one more little coblation. So I wanted to show this because this is a simple surgery, but then some people, some postgraduates can learn it. Of course, okay, you're good, but I'm just telling the postgraduates.
No, sir, it is very difficult to do a good septoplasty, actually.
So thank you very much. Can you put that, Bhaiya?
Sir, excellent demonstration, sir.
Thank you, Omke.
Thank you, Jankiram sir, for this excellent surgical demonstration from Trichy.
I want to introduce, I don't have to introduce him, my dear sweet brother.
Yes, I am here, sir.
Balamurugan.
Hi, sir. Great to see you in good shape.
Yeah, thank you.
We miss you, sir.
Omko, you're doing a good job. Great job. Keep it up.
Thank you, sir.
So,
everybody in the OT I was watching, sir, Anandi, Beulah, everybody.
Yeah.
I mean, I wanted to say hi since so long.
Yeah, so this is all our team. You know that. Yes, so, first of all, I really thank Dr. Deepak Haldipur, sir, for including me in this ENT train. Yeah, there are two meanings for that. Trained in ENT, one. Number two, you have a train of cases. So, very nicely named ENT train. And I thank MacLeod for this. MacLeod only, no?
So, micro.
Sorry, boss. Really sorry. Micro for this wonderful event. We are doing every week, boss. We are getting confused. Sorry.
No problem, sir. Your marathon event.
Micro labs. And I should thank my brothers, Dr. Dubey sir, Dr. Sanjay Agarwal sir, and of course, all the moderators of today's session, Dr. Madhuri Mehta madam, Dr. one more, Lakshmi madam, and Dr. Omkar. And I thank all the demonstrators who did yesterday, today morning, moderation, and all this stuff. Dr. Bharati, I saw your thyroid moderation was very good. So really big thanks to all of you. No words. And what can I say? I can only say namaskar. Thank you so much.
Namaskar. We enjoyed a lot. Thank you very much.
Thank you, sir. Thank you. It was a wonderful demonstration. Thank you,
Sanjay
sir.
Thank you very much.
Yeah, you're still fresh. I want to come for that fire pan.
Yeah. We will be there.
I want to come for the fire pan.
Yes.
Your video is viral, more than 10K view.
Yes. It is because of your commentary.
Your commentary was good.
Excellent. So thank you very much.
Thank you very much.
Thank you.
Thank you.
Okay, boss.
Bye to all of you.
Thank you, Janki sir. Thank you
so much, sir.
Thank you, Dubey sir. Thank you, Omkar sir.
Thank you so
Sanjay
much.
sir.
Thanks, everybody.
Thank
It
you.
was a
Okay.
wonderful surgical demonstration. Yeah. And it's over to Dr. Vishwas for the concluding remarks.
I should thank Dr. Vishwas also because he was the one who was constantly moderating.
Vishwas sir?
Dr.
Yes,
Vishwas
I'm
sir,
audible.
big support for us. Dr. Vishwas sir and his team, Dr. Deepak Haldipur sir and his team. Thank you, Vishwas sir. Are you there?
Yes, I'm here, sir. Thank you, sir. It was lovely watching you operate and giving those tips. And I personally picked up a lot of
No,
tips.
don't tell me, sir. We are learning from you every day.
No, sir, not at all. And it's so hearty to see Sanjay Agarwal sir and Dubey sir, along with Omkar sir, to come up and moderate the show.
Oh, they are my brothers. I'll get angry if they don't come.
I mean, it's always a pleasure to have them on our side, and the program gets a different kind of appeal because of them being here.
Absolutely.
And thanks to the Royal Pearl team for making this great show happen of 3 surgeries simultaneously, that too on a Sunday afternoon. It was really a great effort and helpful for the ENTrain workshop. Being the 6th year, I think it was the best conclusion that we had with Janki Ram sir operating and making sure the rhinology was complete from the lateral wall to the superior to the medial wall. I think the floor was the only thing left now.
Oh, is for you. You did know the this one, rhinoplasty.
That's okay, sir. Anyway, thank you, sir. Thanks for all the case collection because I know you were traveling and in between you had to come back for the workshop despite your busy schedule. It's now the amount of attendance that you had on a Sunday afternoon that has never been recorded. That kind of that kind of attendance. So thank you for that. And I think
thank Dinesh also. You know, Dinesh is a fantastic guy, and the professionalism he shows in this transmission is ultimate. Yes. Very good, Dinesh. Are you there?
His team is this tech support. Akshay is there from digital.
Excellent.
He is really
been sent also very good.
Taken it to a different level.
Pawan was there.
Thank you, my dear friends. Thank you, Vishwas, sir.
You've taken ENTrain
It was a lovely afternoon, sir. Thank you all. Thank you, sir. Thank you, Vishwas, sir.
Thank
Deepak,
you.
sir. Great, sir. Great demonstration as usual. Hoping to see you all the time in all the workshops. And from Dubai nowadays, I have heard like it's a great thing from there. I mean, I have people calling from Dubai. I mean, ENT colleagues saying that Janki sir has entered Dubai now. So, so they're very excited to have you there, sir. Actually,
thank you so much. Thank you. It's all my pleasure and honor, and to have a student like you, moderating. I am so proud.
Thank you so much, sir. We are still learning. Thank you so much, sir.
Thank you.
Bye, sir.
Thank you, sir.
Bye,
Final remarks. I would like to thank the entire team at Microlabs Eros division, Dr. Manjula ma'am, Dr. Krishna Kumar, Senior Vice President Dr. Durga Prasad, Mr. Bhaskar, and all the back-end teams, Dr. Urvashi, for making sure that the ENTrain runs in the best format possible. That is the hybrid, wherein there were 35 centers where people sat down and watched the surgeries even on a Sunday, as well as the online 2,400 plus registrations and counting. This is something which has never happened before, but then we are so glad that academics becomes the highlight with great experts like Janki Ram sir, Deepak sir, Satish Jain sir, Dr. Tushar Kanti Ghosh sir, and the panelists and the moderators, Dr. Bharti ma'am, Dr. Manoj Manikot sir, and Dr. Sharno Mali Patil. Thanks to the instructional sessions that are there from Professor Dr. Rakesh Kumar from All India Institute of Medical Science, Dr. Andrew Swift from UK, and Dr. Srinivas Murthy from Bangalore, who's been talking on silendoscopy. It is a wonderful amalgamation of the faculties who have come together over the last 2 days. I think 41 faculties to be precise, which is almost like a mini national conference where everybody has put their effort to make the academics the main spirit. My personal thanks to the Trustwell Hospital team, the Royal Pearl Hospital team, the Jain ENT Hospital team, and Ghosh ENT Super Specialty Hospital team for making sure that we run the program spick and span and on schedule, and to the wonderful chairing faculty who came by and helped us interact with the faculty and the program ahead. And my special thanks to the audiovisual team by Dinesh Pal and company, who gave us crystal clear communication, audiovisual and surgical demonstrations to be visualized across the globe, and for the YouTube transmission also, which clocked maybe around 4,000 views. A special mention to all the audience who were there with us so long, patiently waiting and making sure that we get the best questions to be asked, as well as a good encouragement for the learning. This program was thanks to the chief mentor, that is Deepak Haldipur sir, who conceptualized it and made sure that the program is of pure academic intent, and it is not about any particular surgeon, but then the ENT subject itself gets the highlight and everybody learns in the process and raises the bar. With these few words, and looking forward to more such events from Microlabs EROS division, I would like to conclude personally as the organizing secretary. It has been a great moment for me to interact and learn, as well as contribute in my own little way to this program. Hopefully, we will have many more contributions from the EROS division towards the ENT fraternity. Thank you so much.
And we are extremely happy that the whole sequence of events went. I would like to personally thank each of the faculty, and whether it is Satish Jain, Tushar Kanti Ghosh, and Janki Ram, and all our people who conducted the panel, Dr. Bharti, or our Dr. Manoj Manikhot. We tried to choose those things, Dr. T.M. Srinivas Murthy. So we tried to choose those topics which were relevant, and definitely we will value the feedback from all the delegates. I know about the good points, and more important, the pitfalls of the program, in what way we can correct and go better. And as usual, I am always grateful to the EROS Pharma Microlabs. I keep saying this, that we should maximize the use of the doctor-pharma partnership, which helps in training doctors, making them better doctors, so that they can treat patients better, adding overall to better healthcare. And the pharma also gets indirectly benefited. Thank you so much, heroes. Thank you for all the members of the faculty, and of course the delegates and the students, PGs, and the members of the ENT doctors fraternity, without whom no event can be complete. Have a wonderful Sunday. We'll meet again next year, but probably there is a plan in about 6 months. I'm initiating the talk with EROS, where we can do some exclusive programs for PGs, training programs, especially in rhinology, otology, and laryngology. We'll announce the same in the near future. Thank you.
Thank you, sir. Thank you very much. Thank you, sir.
Thank you, sir. So we'll wind up.
Yeah.
Akshay will wind up. Thank you all.
Vishwas sir, thank you very much.
Thank you.